Is it moving?
Yes, ma'am.
Okay.
I will start recording, ma'am.
Okay. Shall I begin?
Sorry, ma'am.
Shall I go ahead or you want to wait for some time? Is it okay to begin?
Yes, ma'am. So you can start it,
Oh,
ma'am. I'll start
okay.
the recording, then we will start.
Yeah.
This meeting is being recorded.
Yeah. Good afternoon, all. I'm Dr. Priya. So I'll be taking care of the gastroenterology part, and Dr. Jasmine will be joining in the next session. So she'll be taking care of the respiratory part. So we'll go ahead with today's topic. First one is abdominal compartment syndrome. We'll be looking at an overview of definitions, pathophysiology, diagnosis, and management of abdominal compartment syndrome. So what is the intra-abdominal pressure? It is a steady state pressure concealed within the abdominal compartment. So the normal pressure being 5 to 7 millimeters of mercury. When it is sustained or repeated elevation more than 12 millimeters of mercury is known as intra-abdominal hypertension. So if the intra-abdominal pressure is more than 20 or and it is associated with a single new onset or multiple organ failure, it is defined as abdominal compartment syndrome. So what are the various grades of intra-abdominal hypertension? So it is divided into 4 grades. Less than 12 is considered to be normal. More than 12 is considered to be intra-abdominal hypertension. Grade 1 is between 12 to 15. Grade 2 is 16 to 20. Grade 3 is 21 to 25. Grade 4 is more than 25. And more than 20 associated with any organ, new organ dysfunction is defined as abdominal compartment syndrome. So the World Society of Abdominal Compartment Syndrome projects these risk factors. So either it could be any pathology associated with the abdominal wall compliance, that is, there is a decreased abdominal wall compliance or increase in the intraluminal contents or increased intra-abdominal contents. So these are the various causes. So abdominal wall compliance decreases in cases where you resuscitate with large volumes. So large volume fluid resuscitation, sepsis, septic shock, any burns patient, major trauma, abdominal surgery, prone position. So these are the causes for decreased abdominal wall compliance. Increased intraluminal contents could be associated with any intestinal bowel pathology like ileus, gastroparesis, gastric distension, some pseudo obstruction, volvulus. So these are the various conditions. So along with the tumor, ascites, hemoperitoneum, any peritonitis. So all these conditions can cause increased intra-abdominal volume. So these are the various conditions or risk factors associated with abdominal compartment syndrome. So it can happen due to capillary leak or fluid resuscitation. It can result in it can be a result of damage control laparotomy as well. Okay. So in any patient who has a risk factor, known risk factor for intra-abdominal hypertension, it is important to measure the intra-abdominal pressure. So we looked at various factors that can cause abdominal compartment syndrome. So what are the effects? So in terms of central nervous system, it can cause increased ICP, decreased cerebral perfusion pressure. Coming to the pulmonary, compliance will be decreased. The airway pressures can go up. There will be increased, there will be VQ mismatch, hypoxia, carbon dioxide retention, atelectasis. So these are related to the pulmonary. Abdominothoracic, there will be increased abdominal intrathoracic pressure, elevated diaphragm, IVC will be distended, decreased chest compliance, abdominal wall compliance will be low, and the perfusion to the abdominal wall can also be decreased. Cardiovascular system, when you're considering there is a heart-lung interactions as well, and there is an increased intrathoracic pressure. Your venous return to the heart is going to be decreased because of the increased intrathoracic pressure. So there is a decrease in the IVC blood flow. Venous return to the heart is going to come down, so your cardiac output can come down. There is a increased SVR, increased pulmonary vascular resistance, and the CVP will go up. In terms of renal, the renal blood flow will come down, urinary output, and the GFR will go down. With the bowel related, the gastrointestinal perfusion will come down. The celiac blood flow, SMA blood flow, mucosal blood flow, everything will come down. The perfusion to the abdominal perfusion pressure, which is defined as mean arterial pressure minus the intra-abdominal pressure, will go down. So there can be poor blood flow to the liver as well. The portal blood flow will be diminished and there can be decreased lactate clearance. So these are the effects of abdominal compartment syndrome. So how will you measure the intra-abdominal pressure? This is a very important part wherein there are various methods can be done. So first one, the commonly used method in the ICUs is the intra-bladder method. That is through the Foley's, through a three-way Foley's catheter. Other methods which can be done is the gastric method. There are several catheters that are being available, as well as intraperitoneal drains or probes that are available through the IVC, through the uterus. So these are the other routes where it can be measured. And how the intra-abdominal pressure should be measured through the transbladder method. So the patient should be in supine position. These are the prerequisites. Patient should be in supine position. There should be absence of muscle contraction, and the transducer should be placed at the mid-axillary line at the level of the iliac crest. And after installation of 25 ml of saline into the bladder and clamping the return line. Okay, so this is the prerequisite. So this is how it is measured. So either a three-way Foley can be used, or it can be done through the aspiration port, which is connected through the transducer. And remember, always supine position, iliac crest, and mid-axillary line at the end expiration. So these are the requisites. And 25 ml is the recommended volume, though several papers say different. 25 to 50 ml is the recommended volume. So how will you manage intra-abdominal abdominal compartment syndrome? So this is a very busy slide. So I've split it up. So whenever a patient has risk factors, you always go ahead and measure the intra-abdominal pressure every 4th hourly. So if the patient has an intra-abdominal hypertension more than 12, first and foremost measure is to restrict the fluid, avoid excessive fluid resuscitation, and maintain your organ perfusion pressure. Try to keep your perfusion pressure above 60. So even with this, if there is a new associated organ failure, what are the medications that you can do? So you can improve the abdominal wall compliance by keeping the head end of the bed low, that is supine position, sedation and analgesia, neuromuscular blockade, evacuate the intraluminal contents, either a nasogastric decompression, a rectal decompression, or you can give some prokinetic agents. Sometimes neostigmine can also be used in case of any bowel pseudo obstruction. So evacuate the abdominal fluid collections. So paracentesis can be done, a percutaneous drainage can be done. Correct the positive fluid balance, diuretics, and try to use colloids like albumin. And other thing would be do a hemodialysis in refractory cases if you're thinking of volume overload. And also organ support. Your ventilation should be optimal. And remember, the airway pressures, whatever you're measuring, should be kind of modified. The plateau pressure is equal to plateau minus 0.5 times your intra-abdominal pressure. Similarly, your pulmonary occlusion pressure and your CVP should be modified to minus 0.5 times the intra-abdominal pressure. So this is the first preliminary step. You have corrected first, you have done the initial medical management, Along with side by side, you have to make sure the primary etiology or the cause for the abdominal compartment syndrome is treated. For example, if there is an abscess, you should try to drain it. Ascites, drain it. If it is a bowel pathology or a tumor which is causing it, try to remove it. So identify the primary etiology and treat it. So you can actually classify this into primary, secondary, and recurrent abdominal compartment syndrome. So what is primary? Primary is a disease or injury related to a abdominopelvic region. So it is related to the abdominal organs as such. Secondary is not originating from the abdominopelvic region. That is due to some wall compliance, abdominal wall compliance issue. Recurrent is wherein the patient has undergone a surgery or a medical treatment for primary or secondary and then again develops a abdominal compartment syndrome. So this is recurrent. Okay. So if the patient has primary, treat it. If the patient has recurrent and then you try to measure your abdominal pressure, try to optimize revision abdominal decompression or temporary abdominal closure can be done, and try to optimize and measure every 4th hourly. And fluids need to be very careful. So despite all these things, if the patient has a refractory abdominal compartment syndrome, then you will have to think of a open abdomen or decompressive laparotomy, or you can use a Bagota bag, open abdomen, or vacuum assist devices can be used. So these are surgical management of abdominal compartment syndrome. So we come to the end of first topic. Shall we go to the next topic?
Yes, ma'am. You can.
So the next topic is pancreatitis. We'll be looking into acute pancreatitis and a sub-question, biliary pancreatitis. So what is the definition of pancreatitis? It is defined as an inflammatory process that occurs in the gland that was morphologically and physiologically normal. It's just an inflammatory process. Okay, and it can return to a state of resolution after the inflammation of the exocrine part of the pancreas has settled. The common etiological conditions, the most common being ethanol abuse, followed by gallstones. Okay, gallstones. And the other things would be hypertriglyceridemia, hypercalcemia, infections, autoimmune, idiopathic. So these are the common causes. Okay, biliary stones and ethanol abuse have been the first two common causes. And most common etiology due to biliary stone is a common channel theory, which I'll be talking about specifically in the biliary pancreatitis. Other things would be the drugs which will cause thiazide diuretics, furosemide, estrogen, steroids, valproates, tetracycline. So all these things can cause hypertriglyceridemia, that is more than 1000 milligram per deciliter, is an independent risk factor. Mostly there will be a family history of hypertriglyceridemia. Viral infections like Coxsackie, CMV, HIV, HSV, mumps, and bacterial infections like Mycoplasma, Legionella, Salmonella. So these are the various bacterial, fungal, viral, even other etiology can be contributing to pancreatitis. So what happens is with biliary pancreatitis, there is ductal obstruction. With other causes like alcohol, drugs, trauma, ischemia, and viruses, there can be a acina cell injury. There can be defective intracellular transport. So these are the three main mechanisms. So when there is cholelithiasis or obstruction, there will be increased interstitial edema, impaired blood flow leading to ischemia, ultimately leading to acina cell injury. In case of alcohol, there will be more enzymes that are being produced, proenzymes, lysosomal hydrolases. This activate the intra and extracellular injury and cause acina cell inflammation. So that is related to alcohol and drugs. Defective intracellular transport, this is another method wherein mechanism by which the injury to the pancreas occurs. Delivery of the proenzymes to the lysosomal compartment is impaired and there is intracellular activation of enzymes. So the common features, clinical features will be most typical abdominal pain, epigastric pain, rapid onset, radiating to the back, relieved on bending forward, nausea, vomiting are other features. So patient will be tachycardic because of volume depletion, tachycardic, can be hypotensive, tachypnea, and there will be guarding and rigidity in the abdomen. Okay, and other thing would be gray turners and Cullen sign. Cullen sign being abdominal, there will be a discoloration around the umbilicus. Gray turners is along the flanks. So these are the clinical features. So how will you diagnose? So the diagnostic criteria includes presence of 2 out of 3 criteria. Abdominal pain, which is consistent with the disease. Second would be serum amylase and lipase greater than 3 times the upper limit of normal and characteristic findings in the abdominal imaging. So which enzyme is more specific? So lipase, amylase, amylase rises early and falls early. So amylase is not very specific. Lipase is supposed to be very specific for pancreatitis. So what other investigations you can do is abdominal ultrasound. So when is imaging supposed to be done? Early, that is 24 to 48 hours, you will not be able to appreciate anything in the ultrasound or the abdominal imaging. So you have to wait for up to 48 to 72 hours unless or until you don't know exact cause for the abdominal pain. Only then you have to proceed with an imaging. Otherwise, if the cause of the abdominal pain is known as pancreatitis, then you wait for the 48 to 72 hours to proceed with abdominal imaging. And transabdominal ultrasound will be helpful to identify the gallbladder stone or any CBD stone. Okay, see, contrast CT abdomen can be done to establish any kind of like necrotic pancreatitis. You'll be able to identify how many percent of necrosis is there, whether it's interstitial edematous pancreatitis or necrotizing pancreatitis. If there is if there are gas collections, then it could be an infective necrosis as well. So the CT helps in identifying the percentage of necrosis. It can help to identify the complications of pancreatitis as well. Like there can be peripancreatic collections, wall necrosis. So all those things, complications can be identified with the contrast CT. So initial assessment. So how will you classify pancreatitis first? So you can classify it as early and late. Early is in the first week, late being after the first week. Your management also happens the similar way. First week followed by next week. Severity is mild, moderate, and severe. So the severity you decide how can you stratify? It is based on the modified Atlanta criteria. So here it is mild, moderate, and severe based on the organ failure and absent and the local complications. It's mild if there is no organ failure and no local complications. Moderate if there are local complication and transient organ failure which resolves within 48 hours. Severe if the organ failure persists beyond 48 hours. It can be a single or multiple organ failure. Critical when there is persistent organ failure more than 48 hours and there is a infected pancreatic necrosis. Okay, so the two types of pancreatitis, edematous interstitial and necrotizing. So what is how can you score, or at the bedside, how can you score? So this is the BISAP score, the bedside index of severity assessment. So here it looks into 5 variables: blood urea nitrogen more than 25, impaired mental status less than 15 GCS, SIRS criteria met, age more than 60, pleural effusion. So 0 to 2, lower mortality, more than 3 to 5, it has a higher mortality. but beyond this is a simple bedside index, but there are other criteria for predicting the mortality or prognosis in case of pancreatitis. So these are the various scores, the Ranson's criteria and the modified Marshall scoring. The Ranson's criteria is done at admission and at 48 hours. It mainly looks into multiple parameters, whereas the modified Marshall scoring system looks into organ dysfunction, specifically respiratory, renal, creatinine, cardiovascular. So this is mainly based on the organ systems. So the Ranson's criteria at admission looks at if the patient's age is more than 50, WBC count, glucose more than 200, enzyme elevation more than 250, LDH. And at 48 hours, it looks into, you have to look into the calcium levels, hypocalcemia, fallen hematocrit, base deficit more than 4, fluid sequestration of more than 6 liters, blood urea nitrogen that is elevated, oxygenation. So these score from 0 to 8, and as the score increases, the mortality increases. More than 3 score, severe pancreatitis is likely. So the modified Marshall score based on the PF ratios less than 100 to 400, you have 4 grades. Similarly, the creatinine 1.4 to more than 4.9, and your cardiovascular system defined by your mean arterial systolic blood pressure more than 90, which is fluid responsive, not responsive, requiring vasopressors, that comes under grade 2, and along with the pH that is less than 7.3, that is grade 3. Acidosis is grade 3 and 4. So grade more than 2 defines the presence of any organ failure. So here the baseline creatinine is 1.4 is considered. So it is not defined for patients with CKD. So these are the various scoring systems. So how will you manage pancreatitis? So first, 7 days, your basic management will be fluids, analgesia, and nutrition. So these are the 3 main aspects that you will have to concentrate on. So intravenous hydration is the most important aspect because the patient would have vomited, there will be anorexia, decreased intake, and there will be there will be retroperitoneal sequestration and capillary leak as well because of the pancreatic inflammation that's going on. So the fluid loss can be up to 6 liters. Okay. And so how conventionally, what was our targets being, like almost 250 to 500 ml per hour was being given. So current strategies, we have modified from aggressive to more moderate fluid infusion. So initially, so much of fluids were given every hour, unless there is cardiovascular or renal. Otherwise, if the patient is not desaturating, you can go up on the fluids. So current strategies based on the waterfall trial is what we follow. The moderate fluid infusion, that is 5 to 10 ml per kg per hour. Then you look at what are the targets of fluid resuscitation. You look at the heart rate, your heart rate less than 120, maintaining your mean arterial blood pressure more than 65 to 80, urine output maintained between 0.5 to 1 ml per kg. And you look into you're replenishing the fluids like 6 to 8 liters. Every 6 hours, you have to reassess the volume status and then modify your fluid administration patient to patient basis. Okay. And the most beneficial period is during the first 12 to 24 hours. So you have to do the fluid replenishment between 24 to 48 hours, and you have to monitor the drop in hematocrit as well. Okay, the targets being almost 30 will be your target. So aggressive fluid management can lead to pulmonary edema, volume overload, abdominal compartment syndrome. Is there any role of ulinastatin? So it halts the autodigestion due to trypsin inhibition, but the role is not being established so far, so it's controversial. So pain management in pancreatitis. So multimodal approach is something that we can do. Opioids or narcotics are generally being provided as infusions or transdermal patches. NSAIDs are controversial because there is a risk of acute kidney injury to these patients. Thoracic epidural is another good option that can be done to these patients. Other one would be patient control analgesia. So these are the various options for pain management in pancreatitis. Nutritional aspect. Patient already is in a very catabolic state. The intake will be low, as well as there is a inflammatory state that is going on. So patient is in a very catabolic state. So depending on the severity of pancreatitis, depending on the symptoms, whether the patient is tolerating, early enteral feeding is recommended. So enteral feeding decreases ischemia, reduces transmigration of organisms, thereby reducing the risk of infectious complications. So how early should you initiate? As early as 24 hours to 72 hours. So the Aspen guidelines recommends 24 hours. Okay. Although there was no difference in mortality, but there were higher rates by delaying the enteral feeding. There were higher rates of peripancreatic necrosis, multi-organ failure, and total necrotizing pancreatitis. So in mild acute pancreatitis, initiate with oral feedings as the patient tolerates. Polymeric feeds can be started on normal requirements like 25 to 30 kilocalories per day and protein of 1.5. If the patient has severe complication and if the patient is not able to tolerate orals, nasogastric route can be tried. If not, nasojejunal delivery can be attempted. So what is the difference between nasogastric and nasojejunal delivery? Nasojejunal requires a procedure, either a endoscopy or a fluoroscopic guided placement of the nasojejunal tube. Okay, there is an additional procedure that's being done on the patient. The theoretical benefit would be, it will be bypassing the duodenum, and the stimulation of the pancreas is going to be less. So the enzyme secretions, inflammation, pain, everything can be low because of nasojejunal delivery. But studies have shown nasogastric and nasojejunal delivery, there's not much of a difference. Okay, in case of intolerance to nasogastric feed, nasojejunal feed can be tried, and always try to give a continuous infusion rather than cyclic or bolus administration. Okay, and this is one important trial that everybody has to know. This is the waterfall trial. Aggressive resuscitation defined by 20 ml G in 2 hours, followed by 3 ml per kg per hour. So when they looked into the complications, that is the outcome being moderate or severe acute pancreatitis, it was more in the patients who received aggressive resuscitation, and also the fluid overload was more in the aggressive group. Okay, so in early aggressive fluid resuscitation resulted in severe acute pancreatitis and higher fluid overload in these patients. So next, is there any role? Antibiotics are not almost recommended extra pancreatic infection that you are suspecting. So the incidence of peripancreatic infections is 3 to 7% in pancreatic necrosis. In 30% necrosis, it's more than 50%, and the peak incidence occurs around 2 weeks only. So what are the organisms, in case if there is any infection, what are the organisms that you are suspecting? E. coli, Enterococcus, Klebsiella, Pseudomonas, and other anaerobes. So these are the most common organisms. There's no role of prophylactic antibiotics. Okay, if you're suspecting an extra pancreatic infection like cholangitis, or if it's associated with some kind of other urinary tract infection, pneumonia, or some other catheter-related infections, then antibiotics can be administered. Use of antibiotics in patients with sterile necrosis is not recommended to prevent infected necrosis. What antibiotics should be given in case if you are initiating for an infective necrosis? In case if it's an infective necrosis, ideal would be to do an FNAC, send it for cultures, and then start with antibiotics. So most often, because the procedure being invasive, may not be done. But quinolones are the initial antibiotics that are advised. But then, because it has a good penetration, but the resistant rates in our ICUs are very high, so quinolones may not be sufficient enough. So carbapenems, imipenem, next would be piperacillin tazobactam or a third generation cephalosporins have moderate penetration. Then comes our carbapenems. Imipenem has a good penetration into the pancreas. Okay, infective necrosis should be considered in patients with peripancreatic or extrapancreatic necrosis who deteriorate or fail to improve after 7 to 10 days of hospitalization. So I already mentioned FNAC, cenphogramstin in cultures, and then start the antibiotics. So what other things you can do? Is there any role of ERCP, any minimal invasive surgeries or surgeries? So routine ERCP is it's not recommended, but if there is a gallbladder stone or if there is any stricture which is causing obstruction, biliary obstruction, and if there is intrahepatic biliary radicals that are dilated, yes, there is a role of ERCP. And if there is concurrent cholangitis, yes, you have to go ahead and do it within 24 hours. Okay. Cholangitis, if the patient has cholangitis, that is enzymes being elevated, intrahepatic biliary radicals that are dilated, you should also consider antibiotics in this scenario. Okay, if ERCP or MRCP with endoscopic ultrasound can be done to diagnose choledocholithiasis. Okay, if there is a CBD stone, that has to be removed as early as possible. So, role of surgery. If surgery for pancreas, surgery for gallbladder stones. So these are the two things that can be done. In case if there is mild acute pancreatitis with a gallbladder stone, so it can be done. Cholecystectomy can be done. If the patient has necrotizing pancreatitis and severe inflammatory status, severe acute pancreatitis, ideal to wait and then after the patient stabilizes, proceed with cholecystectomy. So what are the other complications that the patient can develop? I'll go into this. So these are the complications that the patient can develop. If it's an interstitial edematous pancreatitis, within 4 weeks, the patient can have an acute peripancreatic fluid collection. Okay, around the pancreas, there can be a fluid collection. So beyond 4 weeks, this fluid will become encapsulated. So this becomes an encapsulated, well-defined extrapancreatic fluid collection. In case of necrotizing pancreas, there will be a necrotic collection. Okay. And this with a ill-defined wall. So after 4 weeks, there is a defined wall that develops after, and it becomes a walled off necrosis. So these are the various complications. So when you are looking into interfering with these complications, always wait for 4 weeks because there is no definite wall that has developed around. So within 4 weeks, there is no wall or a defined collection. So always wait for 4 to 6 weeks. Allow liquefaction of the contents and development of a fibrous wall around the necrosis. So then you can proceed with either draining the fluid or if it is causing some kind of obstruction or some abdominal compartment syndrome, you can aim at removing this fluid or the cyst. So what procedures are preferred? Endoscopic or surgical. So endoscopic or minimal invasive or percutaneous are better than surgical. So surgical procedures are associated with more morbidity and mortality. So a minimal invasive or endoscopic percutaneous drainage is preferred. Asymptomatic pseudosis or pancreatic extrapancreatic necrosis do not warrant intervention regardless of the size or location. So it depends mainly based on if it's really causing any issue to the patient, only then drainage is required. So other complications of pancreatitis include ARDS, abdominal compartment syndrome, aneurysm, and pancreatic hemorrhagic pancreatitis. There can be intestinal fistulas, infective pancreatic ascites can develop pancreatic fistulas, and patient can have pleural effusion. So next we'll be looking specifically into biliary pancreatitis. It is almost same. So specifically, this is a gallstone, which is common cause of pancreatitis. It can happen even post cholecystectomy status in patients who had a cholecystectomy also. So the concept being the common channel theory. So it can be due to because the gallstone is obstructing the duct. It can cause reflux of bile into the pancreas. So it can activate a cascade of proteolytic enzymes. This is one theory. Another would be because of the obstruction of the stone, there will be a raised pressure in the pancreatic duct, which causes acinar disruption. So this is another concept. So this is the common channel theory of development of the biliary pancreatitis. So what labs you will look for? So amylase and lipase. Lipase is supposed to be more specific. And in case of biliary pancreatitis, more specifically, you will look into other enzymes also. The AST aminotransferases, aspartate and alanine aminotransferases. Because associated cholangitis will cause elevation of these enzymes along with serum bilirubin. It is very important to detect this. Other biomarkers can be looked into procal, phospholipase, CRP, interleukins, trypsinogen, activation peptide. These are some of the biomarkers. Imaging wise, ultrasound can detect a gallstone. Most of the time, MRCP is the preferred method. MRCP, if the patient is stable enough to undergo. ERCP is both therapeutic it is both diagnostic as well as it has the interventional capacity for stone extraction if needed. If there is a stricture, a stent can be placed, and if there is some other like tumor or something, a biopsy can be taken as well. MRCP, the disadvantage is that it is very less sensitive for small stones which are less than 4 millimeters. So small ampullary lesions, ductal strictures and all, it may not help. So if there is associated cholangitis, always go in for ERCP within 24 hours and also consider initiating antibiotics early. Okay. When you're doing ERCP, it can be done along with the endoscopic ultrasound. So the complications, we have looked into it. And the outcome mainly depends on, we have looked into two scoring system. It's mainly based on the percentage of pancreatic necrosis and organ failure. So along with this Ranson, Glasgow, Apache, and the CT severity index is one thing. So the percentage of necrosis. So with the CT findings, you can grade from A to E. Okay, and the percentage of necrosis between 30 to 50. A being normal pancreas, B just enlargement of the pancreas, C is pancreatic inflammation with peripancreatic fat stranding, D is fluid collection, E is air collection, that is retroperitoneal air and more fluid collections. So this is grade A to E. Then depending on the percentage of necrosis, it can be divided into less than 30, 30 to 50 and more than 50. So your CT severity index 0 to 3 has 8% complications and mortality is 3, and when the grade goes up to more than 6, the complication raises to 92% and the mortality to 17%. Okay, so ERCP we already looked into when there is cholangitis, that is elevated enzymes, and when the bilirubin is more than 5, always ERCP antibiotics ERCP within 24 hours. Okay, to decompress the biliary tree. So sometimes even post cholecystectomy patient, when there is a suspected biliary pancreatitis, you will have to proceed with ERCP. If there is a sphincter of Oddi dysfunction, ideally during the intervention, it is better to place a pancreatic stent also. So it is protective for drainage, or it helps drainage of the pancreatic duct as well. So laparoscopic cholecystectomy, is it really required? And endoscopic biliary clearance in treatment of which are the patients who will benefit? If it is a mild disease, it can be performed within 7 days. If it's severe disease, wait for at least 3 weeks, treat with antibiotics, and when the patient stabilizes, you can proceed with cholecystectomy. So we look at the next topic. So acute liver failure, we'll be looking at the definition, etiology, pathophysiology, diagnosis, ICU management, prognostic scores, and complications, and specifically acute liver failure in pregnancy. So these are some of the questions asked in the previous years. So how will you define acute liver injury? It's a severe liver injury, potentially reversible in nature, with with injury occurring followed by acute onset of hepatic encephalopathy and coagulopathy within 26 weeks, okay, of the first symptoms, okay, from jaundice to encephalopathy. That is, if it is less than 1 week, it is hyperacute, okay. This is the O-Grady system. So in general, it is defined as within 26 weeks, okay. And this does not include alcoholic hepatitis, okay. The first symptoms in the absence of pre-existing liver disease. So this is a very important definition. So here the liver impairment is defined by jaundice, coagulopathy with an INR of more than 1.5, encephalopathy, no prior liver disease, and within 26 weeks of onset of symptoms. So there are several system classification. Okay, so the O-Grady one defines hyperacute, acute, and subacute. Hyperacute is like 1 week, and then 1 week, and then 1 to 4 weeks as acute, and 4 to 12 as subacute. Why this classification is important is because of prognosis. Hyperacute is something which has a good prognosis if you intervene early. For example, paracetamol poisoning, the patients usually end up with a hyperacute liver failure, but the prognosis is good if you treat it appropriately. So this is one classification. The Bernau system defines as fulminant 2 weeks, 2 to 12 as subacute, subfulminant. Usually the subacute form has a poor prognosis. Okay, the Japanese system defines as fulminant as 0 to 8 and late onset as 8 to 12. So in the fulminant, they subclassify as acute and then subacute. So these are the various classifications. So what happens in acute liver failure? So there is some insult which causes massive destruction of the hepatocytes, direct cytotoxic effect, and there is immune response to the antigen. There is cellular injury, death resulting in necrosis and transient apoptosis. There is liver cell death, which triggers a lot of inflammatory cascade immune responses and massive inflammation, which results in vasodilatation and vasoplegic circulatory shock. There is pro-inflammation as well as anti-inflammatory cytokines, that is SIRS, as well as compensatory inflammatory response that happens, and followed by multi-organ dysfunction. There can be secondary infections due to this also because of the immune pharesis as well. So there is impaired hepatocyte regeneration, altered parenchymal perfusion, and endotoxemia. So what are the causes of acute liver failure? We can remember the mnemonic as A, B, D, E, F. So A, acetaminophen, hepatitis A, B, D, and C, hepatitis, autoimmune hepatitis, C, cryptogenic, remember, D, drug-induced liver injury, E, Wilson's causes like Wilson's Budd-Chiari syndrome, fatty liver of pregnancy, Rye syndrome, and then other causes like tumor, HLH, stroke, and ischemic hepatitis. So these are the various causes of acute liver failure. So what are the different features like in paracetamol poisoning? What will be there will be very high levels of aminotransferases. The bilirubin may not be elevated so much. It is rapidly progressive. The patient will develop acidosis, renal failure. Phosphate is a very bad is a good low phosphate is a good prognosis, as seen as a good prognostic marker, but replacement is required. So non-paracetamol poisoning can mimic cirrhosis. But Chiari syndrome, usually in Doppler, there will be a loss of hepatic portal venous signal, reverse flow. Wilson's high bilirubin to ALP ratio, clinical features would be Fisher rings, and the patient can have Coombs negative hemolytic anemia, urinary copper will be elevated, there will be low ceruloplasmin levels, mushroom poisoning, autoimmune will be subacute presentation, and malignant infiltration can cause elevated ALP. Acute ischemic injury will cause very high enzyme elevation and increase LDH. So what are the clinical features of patients who have acute liver injury? In the lungs, ARDS, acute lung injury. Brain, most important one would be intracranial hypertension due to cerebral edema, and the patient will have hepatic encephalopathy. And liver loss of metabolic function. So the liver synthetic function will be decreased. Hypoglycemia, lactate clearance will be decreased, lactic acidosis, urea cycle impaired, hyperammonemia will be there. There will be poor synthesis of the clotting factors. So there'll be coagulopathy. The pro as well as the anticoagulants like protein S, protein C, everything will be impaired. So you need to remember there is a rebalanced coagulopathy which is happening. Bone marrow suppression will be there, and circulating leukocytes, there will be immunoparesis basically that can be associated pancreatitis because of high inflammatory state, and there will be a high cardiac output, hyperdynamic circulation. There will be decreased glucocorticoid production. The patients will end up in renal failure. There will be high portal hypertension. The portal hypertension will be there. This is more prominent in subacute and chronic, not in acute liver failure, that you need to remember. The symptoms would be jaundice, vomiting, abdominal pain, fever, tachycardia, hypotension, and hyperventilation. So we have seen at the etiological factors. So along with the hepatitis, also remember these are some of the viruses that can cause acute liver failure. So lymphoma, malignancy, we looked into, and we look into pregnancy specifically. So what are the causes of acute liver failure in pregnancy? First and foremost, in the first trimester, hyperemesis gravidorum can also cause, okay, very unlikely, but then hyperemesis gravidorum can also result in elevated liver enzymes, rarely translate into a liver failure. Okay, then the most important factors would be preeclampsia and eclampsia with liver infarction, HELP syndrome, acute hepatic rupture, acute fatty liver of pregnancy. So these are the most pregnancy-related causes of acute liver failure. Some of the conditions like viral hepatitis, Budd-Chiari syndrome, that is portal vein thrombosis, gallstone, can be exacerbated by the pregnancy state itself. So some of the conditions unrelated to pregnancy state, like drug-induced toxins, mushroom, or shock due to any other condition, trauma, or decompensation of the pre-existent liver failure. So these are some of the conditions can cause acute liver failure in pregnancy. We look into some of the important causes in detail. So first, coming into acute fatty liver of pregnancy, this is a very important condition. If not diagnosed early, it will cause increase in mortality. So this is mainly due to some mitochondrial pathology wherein dysfunctional fatty acid oxidation happens and there is fatty infiltration of the liver resulting in acute fulminant liver failure. The common presenting feature of these patients will be jaundice, hypoglycemia, confusion, the classic picture of acute liver failure. There'll be jaundice, hypoglycemia, coagulopathy, DIC, and patient will have elevated liver enzymes. Elevated liver enzymes more than 3 times normal. Okay, clotting factors, everything will be deranged. Okay, and how will you treat this? Most definitive treatment would be immediate delivery of the baby, and it can develop even after pregnancy, 4 to 5 days, even up to the first week post delivery, it can occur. Second, preeclampsia with severe features. Preeclampsia, usually the patient will present with hypertension, proteinuria, edema, headache, epigastric pain, and all that. And main pathophysiology being abnormal placentation, there will be the prostaglandin and thromboxane. So all those factors that there will be an imbalance, placental hypoxemia and ischemia. So these are the inciting conditions. So your diagnosis mainly based on the patient's blood pressure more at beyond 20 weeks, and then elevated liver enzymes more than 2 times the normal. So for preeclampsia, seizure prophylaxis with magnesium sulfate, BP control with labetalol, hydralazine, nifedipine, delivery. Ultimately, in all status, delivery of the fetus is going to be therapeutic. Okay, HELP syndrome. HELP syndrome, usually the patient has kind of presence with jaundice, and then there will be there can be high blood pressure also. This is mainly due to microthrombi in the portal system, low hepatic perfusion, ischemia, hepatocellular injury, and there can be deposition or distension of the deposition of platelet thrombi, platelet-rich thrombi in the capillaries, resulting in microangiopathic hemolytic anemia and thrombocytopenia. So this is the main reason. Okay, so the classic findings: HELP, hemolysis, low platelets, elevated liver enzymes. Along with that, your LDH and uric acid will be elevated. So because of hemolysis, you will find schistiocytes or fragment cells in your peripheral smear. Liver enzymes will be very much elevated. There can be associated proteinuria and hypertension as well. Treatment would be delivery, magnesium sulfate prophylaxis, BP control. Okay, then cholelithiasis, because there is a hormonal, there is a change in the hormonal milieu in the pregnant patient. Estrogen and progesterone can cause, estrogen can cause high biliary cholesterol excretion, and progesterone, the gallbladder contractility will be low. So this results in sludge or stones that can cause pain. If there is a cholelithiasis, biliary colic, definitive management would be cholecystectomy. Intrahepatic cholestasis of pregnancy, usually the patient comes with pruritus in the 3rd trimester. This is the classic presentation with jaundice, pruritus, itching in the hands, feet, and all that. So it's multifactorial genetic, all those. High bile acids will be there. Alkaline phosphatase will be very high. Direct bilirubinemia and liver enzymes may not be very high. So direct bilirubin elevation, bile acids will be elevated. So treat with antihistamines, cholestyramine, and also deoxycholic acid. So this is the treatment. Non-alcoholic fatty liver disease can be due to insulin resistance due to upregulated triglyceride synthesis. Okay, and there can be metabolic syndrome as well, obesity, diabetes, and all that pre-existing. So there is steatohepatitis hepatitis with AST to ALT ratio less than 1. So the treatment would be just lifestyle changes and modifying the diet. So this is the difference between HELP, acute liver failure, and viral. Just remember, the enzymes will be very high in viral hepatitis. Acute fatty liver will present as fulminant liver failure, coagulopathy, encephalopathy, hyperammonemia, hypoglycemia. HELP, so the name, as the name says, hemolysis and all those picture will be there. More than 20 weeks will be HELP. More than 24, it can happen postpartum also. Okay. So the enzyme levels will be very high here. Prognosis, if you look into the prognosis, maternal mortality is very high when the patient has viral reactivation or hepatitis E. So prognosis is very poor in viral hepatitis followed by acute fatty liver. So HELP syndrome mortality is 1%. Okay, perinatal, the fetal mortality is this much. So HELP and ALV, acute liver failure, may not have a very high bilirubin. Sometimes acute fatty liver can have more than 5 also. So what will be your further management? How will you proceed with this patient? First, investigation aspect, you'll look in for complete blood picture, renal functions, monitor the urine output, LFTs, arterial lactate is something important, arterial ammonia, ABGs, looking for the coagulation parameters. And looking for specific tests for the diagnosing the etiology, toxicology panel, including paracetamol, which is very important, viral workup, HBsAg, anti-HBC, IgM. If it is positive, then look for the HBV DNA, HDV in case of HBV positive, anti-HAV, HEV, then HSV, and varicella, CMV. So all these viral you have to rule out. Autoimmune, if you're suspecting autoimmune, look into ANA, anti-smooth muscle antibody, anti-LKM, liver kidney muscle, this antibody as well, Wilson's, ceruloplasmin, and copper levels. So also look into complications like pancreatitis in case of amylase or lipase also. So how will you further proceed with managing these patients? So monitor routine diagnostic tests here sent. Then imaging of the abdomen is something that you need to contrast CT abdomen if you're looking into something specific that can be diagnostic. Then monitor vitals along with the neurological status. Glucose monitoring, coagulopathy is there, so ulcer prophylaxis you have to consider. In case of paracetamol or any specific conditions, you have to administer specific therapies. So this is something important. So paracetamol, N-acetylcysteine, Wilson's, copper chelating agents, hepatic vein thrombosis, tips or clot retrieval or thrombolysis, hepatic viruses, antivirals, for example, B. entecavir or tenofovir, you will have to consider. Autoimmune, consider steroids. Alcoholic hepatitis, you have the Madre discrimination factor score. If it is more than 32, administer steroids. Valproate, consider hemodialysis. Amantadophiloids, hemoperfusion. So these are definitive treatment. Then comes your organ specific management. Every organ can be affected. So depending on what is the profile of the patient. Renal, proceed, optimize your hemodynamics, fluid status, consider RRT. Pulmonary, so patient can have ARDS or volume overload. Hemodynamic, because it's a hyperdynamic circulation, infection management, coagulopathy, and then neurological. This is something very important because this is a very important complication of acute liver failure. Ensure your ABCs are okay. In case if the patient is in encephalopathy, make sure head end is raised and sedate and keep the patient calm. If needed, if airway remains threatened, intubation, and a low threshold for empirical antibiotics in patients with acute liver failure. Okay, intubation and make sure your metabolic status is optimized. So this is specific for every organ. So brain, grade 3 and 4 encephalopathy, intubation, role of non-invasive intracranial pressure monitoring. Okay, optic nerve sheath diameter is something that we perform normally. Transcranial Doppler can be done. Routine use of extradural ICP sensor is kind of controversial because patients will be coagulopathic also. But if the patient is going into transplant and then like post-transplant, you want to monitor. So invasive intracranial pressure monitoring can be done. So avoid hyponatremia, maintain the temperature. So mannitol, CRRT. In case if the patient's ammonia level is more than 100, consider RRT. So which mode we will consider? Better to go ahead with the continuous renal replacement hemofiltration method because it can avoid intermittent, will avoid rapid fluctuations in your ICP. So continuous will be a better one. So cardiovascular, intra-arterial line placement, vasopressors, stress steroids if needed. Respiratory wise, the patient can aspirate, so airway protection is something important. ARDS, you will have to maintain lung protective ventilation. Renal, avoid nephrotoxic drugs. Then tight glycemic controls. Patient can be hypoglycemic, hypoglycemic. So you will have to make sure the glucose levels are optimal. Okay. And early enteral nutrition is something that you need to consider. So coagulation, how will you monitor PT-INR can be misleading because your anticoagulants will also be protein C will also be low along with your 279, 27, 8, 10. So all these factors can be low. So you'll have to monitor the TEG, and then in case if there is bleeding, you'll have to transfuse accordingly. Infections, there is a high potential for infections in these patients. Always consider prophylactic antibiotics. So for hemodynamic optimization, fluids, NS, if the patient is acidotic, isobicarb can be considered. Noradrenaline is the first choice, followed by vasopressin. In case if the patient is kind of requiring large volumes of fluid, albumin can be considered. So there is rebalanced coagulation. That is, all factors are synthesized in the liver except for factor 8, and the inhibitors of coagulation like protein S and C are also decreased to up to 30% of normal. And there is low fibrinogen because it's synthesized in the liver. Thrombocytopenia can be there due to increased consumption or decreased production, and there will be also associated platelet dysfunction. So the patients will have poor coagulation reserve, so increased tendency to bleed, TEG or ROTEM to guide transfusion. So as per the guidelines recommendation, in case if it is bleeding, your targets will be more than 50,000 platelet count, INR less than 1.5. So if you need to correct the coagulopathy, so FFPs 15 to 20 ml per kg will be the dose. If not, recombinant factor 7A, so 40 micrograms per kg can be given to correct coagulopathy. So measures to manage your ICP. So measures to manage your ICP would be your targets, maintain your cerebral perfusion pressure of almost 50 to 60, your MAP a little higher, mannitol bolus, and hypertonic saline can be given. Hyperventilation, not on a long term, only for short term. If there is herniation risk, barbiturates can be given, thiopentone, but clearance is compromised in liver failure. Corticosteroids, not no role in reducing the ICP, but in case of the stress dose steroids for shock, yes, there is role of steroids. Indomethacin, not ideally recommended. Hypothermia is also not recommended because it can worsen coagulopathy. So hepatic encephalopathy, I'll be taking another in detail on hepatic encephalopathy, but just for completion, your grades from 0 to 4. So it is based on the level of consciousness, personality, neurological signs, and EEG findings. 0 will be subtle signs only found on psychometric testing. Okay. Grade 1 will be sleep cycle alteration, and then mild tremors, apraxia, and coordination will be there. Grade 2, asterix is hypoactive reflexes, mild disorientation. Grade 3, aggressive behavior, complete disorientation, and asterix is, it will be severe hyperactive reflexes. Grade 4 will be complete coma. So from 1 to 3, EEG will be triphasic. As the patient goes into coma, grade 4, there will be delta, a slow wave activity. So this mechanism, I'll be talking in detail in hepatic encephalopathy separately. So it's mainly due to gut dysbiosis, wherein high ammonia is produced, which is metabolized in the liver and muscles. Okay, and also when there is acute liver failure, there is a hyperinflammatory state. There is high inflammatory cytokines, and there is high ammonia that is not being metabolized in the liver. So thereby, this causes the high cytokines causes a breach in the blood-brain barrier. So these ammonia not metabolized by the liver as well as by the muscles cause neuroinflammation, astrocyte swelling, and neuroelectrical activity dysfunction. So this will result in cerebral edema. So these are the various pathological issues that happen, which will result in either a minimal or overt encephalopathy. Okay, so this is about hepatic encephalopathy and management. So the difference in management in hepatic encephalopathy in patients with acute and chronic liver failure is that lactulose has a limited role in acute liver failure, whereas in chronic liver failure, lactulose has a definitive role. Okay, it does not improve survival or outcomes in acute liver failure and not routinely recommended. Okay, so anti-edema measures we talked about, main thing would be treating the precipitating cause. Okay, CRRT and emergency liver transplantation should be considered. So this is what I spoke to. So this is one slide which contains almost everything which we talked about. Ultimate would be liver transplantation. Okay. Plasma exchange can be considered. Okay, plasma exchange Mars. So all those Prometheus. So liver assist devices can be considered, but there is no improved survival with the Mars or liver assist devices. Okay, so liver transplant would be the ultimate solution. So what are the prognostic scores? This is the King's College criteria. So who are the patients who have to be shifted to a transplant center or who needs to be posted in the list of liver transplant? So if it is a paracetamol poisoning, this is the criteria. So if the arterial pH is less than 3 after adequate resuscitation and more than 24 hours of ingestion, and if the arterial lactate is still more than 3, so pH less than 7.3, lactate more than 3. So, or three of the following. So, either pH or lactate, or three of the following: hepatic encephalopathy grade 3, serum creatinine of 3.4, or PT more than 100, or INR more than 6.4. So, this is the criteria for paracetamol poisoning. For non-paracetamol poisoning, so your PT more than 100 or INR more than 6.5, or any of the 3 out of 5 criteria. So if the patient's age is less than 10 or more than 40, or if it's a non-hepatitis condition like indeterminate etiology, drug-induced hepatitis, so this is unfavorable etiology. Jaundice to encephalopathy more than 7 days, bilirubin more than 17, INR more than 3.5. So this is the criteria. Any 3 out of 5 is there, then you will have to think of liver transplant. This is not applicable to patients with pregnancy-related complications, Wilson's, trauma, pediatrics, and Budd-Chiari. So this is an exception that you have to remember. So the other criteria is Glitchy criteria, where this looks into hepatic encephalopathy grade 3 to 4 and factor 5 levels. So only 2 factors are looked into. If the grade of encephalopathy is very high, and it looked into factor 5 levels, so coagulopathy and encephalopathy alone. If factor 5 level less than 20, that is for less than 30 years, or if the patient is more than 30 years, factor levels less than 30. So this is criteria for transplant. So these are the prognostic factors, the King College and Clutchy. For end-stage liver disease, actually, this has been asked in some of the previous papers, so I thought it will be useful. So just for completion, the MELD score has been asked in multiple papers, actually. So what is the MELD score? This is a prognostic score, ideally used in patients who were undergoing TIPS and all that for prognostication purpose. But then this has been employed in patients with chronic liver failure for prognostication purposes. So this looks into serum creatinine, total bilirubin, INR, 3 factors. Okay. So if the score is from 6 to 40. As the score increases, the prognosis is bad. So the patients who have a high score need to undergo a transplant, but then the probability of coming out is like very less. So this, if you can remember the formula, it will be good, because if you can write it, so 0.9 times creatinine, 0.3 times bilirubin, 1.1 times INR, plus 0.6, the whole multiplied by a factor of 10. So that's the MELD score. So because sodium has a prognostic value in liver failure, so I'm talking about end-stage liver failure. So here, so they have included sodium as well. So here they have considered the sodium lower limit of 125 to some papers say 137 or 140. So here they have included the MELD score minus sodium into 0.025 times MELD minus the difference in the serum sodium and the upper limit plus 140. So this is the formula. So MELD sodium. So this score is also 6 to 40. So this has some prognostic value. The MELD 3. So this is not yet confirmed, but just to remember, the albumin and the gender has been included as factors. So contraindication for liver transplant being neurological prognosis is not good. So brain death, no. So if there is herniation, loss of gray white matter differentiation. So if the neuroprognosis is good, it's an if the neuroprognosis is bad, it's an absolute contraindication. Relative contraindications being any extrahepatic involvement, organ involvement, or infection. So this is the absolute contraindication. So any bacteremia or sepsis, shock with vasopressors, or any uncontrolled ARDS, severe pancreatitis, low cardiac output states. So these are the contraindications for liver transplant in acute liver failure. So I think from here, Dr. Jasmine will be taking over to RS, respiratory system. Can I ask Dr. Jasmine to join?
Yes, Dr. Priya, I'm here. Thank you.
Yeah, thank you.
The recording has stopped.
Ma'am, once you start, I will start recording again.
Yeah, just a second.
Okay.
Good evening, everybody.
This meeting is being recorded.
I hope you had a good workout through your gastro system. Now we will start with the respiratory system. We're just interspacing topics in between to break the monotony. So before I start, I have two things to share with you all. One is about how to go about this course. So all of us have given all the data to you in one place. Please try and keep your ears open as much as possible. I have been on the other end, and I know you land up just taking screenshots thinking you will grab it all. At the end, you just go through it all. But when you hear it and then read it, it makes a huge difference. And in this crunch of time, this is the intention of this course, to help you get through it faster. So that is one thing. Second thing is one thing that I learned the hard way. I didn't read the updates book. Every year there is an updates in critical care, and a lot of your off topics are asked from that book. So every day in the evening, try and spend like an hour or two with your latest update book and just go through the topics, because majority of like 40% of our question paper was from that book of that year. Okay. So now coming to the respiratory system. So for the respiratory system, I have divided it into parts. First, we'll just deal with basic physiology. Then we'll deal with the core diseases, your asthma, COPD, RDS, pneumonias. And then we will deal with airway. And then we'll deal with theoretical topics of mechanical ventilation. So today we'll start with the physiology. So under the physiology, I'm trying to cover these topics. I have included all all the questions that have been asked on these topics and just kept it as simple as possible for you to revise. So beginning with the first topic, that is the oxygen cascade. So this question is also asked as the transport and delivery of oxygen, but it is also known as the oxygen cascade. So the word should not confuse you. Okay, so what is the oxygen cascade? Oxygen cascade is basically when your oxygen is moving from the atmosphere down to the lung, to the airway, to the lung alveolus, from there to the blood, from the blood to the capillaries, to the tissues, and into the mitochondria of the cell, the partial pressure or the concentration of the oxygen keeps on dropping. So this movement, this decrease in the PO2 from air to the mitochondria is what is known as the oxygen cascade. So in exam, you can draw a simple graph. This graph will just give you an idea of how to write the whole answer. So in the bottom, you have the part, the position in the circulation. On the x-axis, on the y-axis, you have partial pressure. So like you can see over here, from the atmospheric air, it starts at 159 PO2. In the airway, it becomes 149. In the alveolus, it becomes 99. Then at the end capillary, again 99, in the blood around 92, drops down in the tissue to 33, and finally in the mitochondria at 5. Okay, this is what I have explained in this. So each of these are your subheadings for the answer, just to simplify it for you. So what we are discussing in the oxygen cascade is how at each stage there is a drop. So what is happening because of which the oxygen PO2 is dropping. So first comes the atmospheric level. So at the the atmospheric pressure is 1 atmosphere or 101 kilopascals or 760 mmHg, whatever unit is convenient to you, stick to that throughout. So this is primarily 21% oxygen, 78% nitrogen, and small quantities of other gases. So predominantly nitrogen and oxygen. So all the gases, when pressure exerted by each gas, is what sums up to the atmospheric pressure. So if you say 21% of your 760 is oxygen, that comes up to 159 mm of Hg. So this is the PO2 at the atmospheric level. Now you come down to the trachea. So as this air enters into your trachea, it is warmed and humidified by the upper respiratory tract. So that means to this nitrogen and oxygen, now what is being added is water vapor. So the water vapor pressure is around 47 mm of Hg. So now if you subtract this from your atmospheric pressure of 760, you will get 713, and the partial pressure of oxygen in this moist air is now 21% of this 713. So from the atmospheric O2 of 159, we have dropped down to 149 mm of Hg. The next comes the alveolus. So what happens in the alveolus? Now, in the upper airways, it is diluted by water vapor. Down in the alveolus, it is diluted by carbon dioxide, because carbon dioxide is continuously being released by the blood into the alveolus. So how do we calculate this dilution? This is given by the alveolar gas equation. So what does the alveolar gas equation says? Your P capital A O2, that is your alveolar PO2, is equal to FiO2 into atmospheric pressure minus water vapor pressure minus PaCO2 upon RQ. RQ is your respiratory quotient. All the units and the full forms have been mentioned here. So this, if you want to simply understand this equation, if you see the alveolar gas, the first subtraction is actually the dilution by water vapor, and the second subtraction is the dilution by carbon dioxide. Okay. So if you fit in the values, we already had 149 at this level, right? When at the tracheal level. Now this part, if you put PaCO2 of 40 and a normal respiratory quotient of 0.8, this is around 50. So 149 almost minus 50 is almost 100 or 99. So that is your PO2 at the level of the alveolus, or P capital A O2. So far what we have seen dry inspired air, the atmospheric air having a PO2 of 159, entering the trachea getting humidified becoming 149, entering the alveolus getting diluted by carbon dioxide and becoming 100. Now from here, it goes into from the alveolus, it will go into the blood. So ideally, if the alveolus and the arterial oxygen, it should equate, right? So you start off, this is your P small aO2, which is around, PVO2. This is a pulmonary vein, which is around 40. So as it passes through the alveolus, it should equate with the alveolar O2 and become 100. But ideally, it is not 100, it is slightly less than 100, correct? So what causes this difference? Okay. So this difference occurs because of two things. The first is your VQ mismatch, and the second is your diffusion limitation. Okay. So if you at this point, we have to elaborate both these points of what is your VQ mismatch and second is your diffusion limitation. So VQ mismatch, you all know, in a normal lung, the ventilation and the perfusion varies with region. It is not perfectly matched throughout. If you see at the apices, the ventilation is relatively more, perfusion is relatively less. And so that means if there is more ventilation and relatively less blood to acquire that ventilation is like a dead space. So where and such in the apices, there's a tendency towards dead space. That means your VQ ratio is more than 1. If you see, as you go towards the bases, these are relatively more perfused and relatively less ventilated. So what happens is there is more blood, but there is not enough ventilation available to oxygenate this blood. So this blood is having a tendency to get shunted. So this is known as a shunt tendency, where your VQ ratio is less than 1. Okay, so this is what is your VQ mismatch. So what are your examples of pathological extremes of these? In dead space, you have pulmonary embolism, and shunt phenomenon, you have atelectasis, edema, consolidation, or anything that occludes your alveolus. I've mentioned this specifically because this itself is a potential question. What are the west zones of the lung? So when you like we have described already, that the ventilation and perfusion is not uniform throughout the lung, and this varies in each region. In zone 1, that is your apical region, your P capital A is alveolus. So your PA pressure is much more than your arterial, much more than your venous. As you go down to zone 2, your arterial pressure is more than your alveolar pressure, which is more than your venous. This is your middle segment. Over here, there is a relatively matching of your VQ and you have a relatively normal gas exchange. And as you go down to the basal segments, here the perfusion is a lot more than the ventilation, because of which the arterial pressure is more than the venous pressure and it is more than the alveolar pressure. So over here, the VQ ratio is the lowest. Now, the second point regarding transfer of oxygen from alveolus to blood is diffusion across the alveolar capillary membrane. So if you see if this is your alveolus and these are your pulmonary capillaries and blood transports from year to year, if the time taken for this capillary transit is around roughly 0.75 seconds, it takes only 1/3 of this time at around 0.25 seconds for it to equilibrate with the alveolar oxygen. So this extra 2/3 time is like a buffer. So this is especially useful in cases like exercise, where your blood flow is now increased. So there is enough time for the blood to equilibrate with the alveolar oxygen. But whenever in some disease cases like lung disease, ILD, or fibrosis, this diffusion will be limited. So with exercise, your oxygenation will worsen and that will cause an exertional hypoxemia in such patients. Okay, so I'm just briefing. When in the oxygen cascade, we were at oxygen transport from the alveolus to the blood, and we noted two phenomenon that factors that affect this. One is the VQ mismatch, and the second is the diffusion across the alveolar capillary membrane. Now, at this point, I am taking the liberty to talk about alveolar arterial oxygen gradient. Okay, so your alveolar arterial oxygen gradient is also a potential question. Since we already spoke about the alveolar gas equation, I have just included this over here itself. So what is this gradient? It basically is used to assess the efficiency of oxygen transfer from the alveolus to the arterial blood. So it quantifies the difference in the oxygen partial pressure in the alveoli, that is your P capital AO2 and the P small AO2, and helps identify the cause of hypoxemia in critically ill patients. So the next thing is you mentioned the definition, you write the formula, that is your capital A PO2 minus your small a PO2. And what is the normal value? Normal value is 5 to 15 mm of Hg in healthy young adults on room air. Okay, so you have to remember that this is very much driven by the FiO2. So we are talking about a normal FiO2. So one thing is that this normal gradient will vary with the FiO2. If there is a higher FiO2, the expected gradient will also increase. And also it increases with age. And a rough estimate of how the AA gradient varies with age is age upon 4 plus 4. You should add, this would give you the how much the normal AA gradient increases with age. So what is the clinical significance before this? So now this formula, I have not elaborated much because we have already discussed the PaO2, that is the alveolar oxygen partial pressure. So you can just mention that same formula and then write the normal values, and you can derive the final AA gradient and mention that the normal range is 5 to 15. So what is the clinical significance of this? So if a patient has hypoxemia and the AA gradient is normal, that means the transfer from the alveolus to the blood is normal. So what is wrong? Either the inspired oxygen itself is low or the patient is hypoventilating. Okay, so these are the two important causes of the normal AA gradient hypoxemia. You can give examples of these: opioid overdose, neuromuscular diseases, airway obstruction. Over here, the PaCO2 is often elevated, and supplemental oxygen will correct the PaO2. So when you have hypoxemia with an elevated AA gradient, that means from the alveolus to the blood, the transfer is affected. So now you have to think of all the diseases that will affect this. So we have just seen those factors, right? First was the VQ, second was the diffusion, and third is a right to left shunt pathology. So all these three causes will cause an elevated AA gradient with hypoxemia. Okay, so I'm going through this again. Normal AA gradient means alveolar to blood transfer of oxygen is normal. So you think of causes where the oxygen inspired was less, like high altitude or hypoventilation. Elevated AA gradient means from the alveolus to the blood, the oxygen transfer is impaired. So the factors that we just described that affect the transfer from alveolus to oxygen, one is the VQ mismatch. So when will the VQ mismatch worsen? Pulmonary embolism, COPD. One is diffusion impairment, wherever your alveolar capillary membrane is diseased, like interstitial lung disease, ARDS. And the third is when the blood bypasses a ventilated alveoli, that is creating a right to left shunt. So this is about your alveolar arteriolar gradient. So now coming back to the oxygen cascade. Okay, in the oxygen cascade, we've reached from alveolus to blood. Now oxygen carriage in blood. So oxygen carriage in blood is in two forms. One is the major form that is bound to hemoglobin, and the other is a minor form that is dissolved in plasma. So how do we calculate the amount bound to hemoglobin? Each gram of hemoglobin carries around 1.34 ml of oxygen. So roughly, if we, for calculation purpose, if we say we have a individual with a 15 gram per dl of hemoglobin, to multiply this by 1.34, you will get around 200 ml of oxygen per liter of blood when it is fully saturated. And dissolved in plasma is given by Henry's law. That means it gives the concentration of any dissolved gas as alpha into the partial pressure, where alpha is your solubility coefficient. The solubility coefficient for oxygen in blood is 0.003. There are two zeros over here, okay? Solubility coefficient is 0.003. And the PO2 is roughly 100. So even if you multiply this, the value you will get is 0.3 ml. Okay, so major form is actually by bound to hemoglobin, which is around 200 ml, which is hardly anything when compared to this 0.3. So a lot of times in questions, this part, even if you don't calculate this part, it won't be at a very big loss. But you have to always mention the two forms of which oxygen is carried in blood. Okay, so now coming to the bound form. Okay, now we are discussing the bound form of hemoglobin. So for that, we need to discuss about the oxygen hemoglobin dissociation curve. Now this again itself is a question. So that is why I've described this again in detail. So what is the oxygen hemoglobin dissociation curve? It is the relationship between the partial pressure of oxygen with the saturation of hemoglobin. So what are the components of this graph? On the x-axis, you have PO2, that is partial pressure. On the y-axis, you have SO2, that is your oxygen saturation. Okay, so now to understand why this graph looks like this, we need to understand what is the mechanism of binding between hemoglobin and oxygen. So in the body, hemoglobin is in two forms. One is your taut form. So taut form or tense form is your deoxygenated state. In the deoxygenated state, hemoglobin will have low affinity for oxygen. That means it requires a higher PO2 to facilitate binding of oxygen molecule. Okay. So this, if you see, to explain this form, we can take an example of what happens in the alveolus. What happens in the alveolus is that your PO2, the concentration of oxygen, partial pressure of oxygen is very high. So in this form, your deoxygenated blood will bind more easily. That means it needs a very high PO2 to get converted into the relaxed form. Relaxed form is your oxygenated state. Oxygenated state is, it has a high affinity for O2 and it requires a lower PO2 to facilitate binding of oxygen molecule. So converting from taut form to a relaxed form, what you have to understand is whenever a single molecule of oxygen binds to the hemoglobin or deoxygenated hemoglobin, it converts this taut into a little more relaxed form and facilitates further binding of the second molecule. This facilitates further binding of the third molecule. Okay. So this is what we call positive cooperativity. So this phenomenon where the initial binding is the most difficult and further binding, the affinity is better, is known as positive cooperativity. And this is what is responsible for your sigmoid shape of the oxygen dissociation curve. Okay. So far what we have seen in oxygen dissociation curve, we have seen what exactly it is. It is a relationship between PO2 and SO2. We have seen the components, the x-axis, the y-axis. we have described the mechanism of the shape of the curve, which is a sigmoid shape. That is an S shape due to allosteric binding of oxygen to hemoglobin. The binding of the first molecule makes the binding of subsequent oxygen molecules easier. So now if you see this graph carefully, if you see what is happening in the lungs I already told you, partial pressure is high. So now this exposes the T state or the taut state to vast amounts of oxygen, and this will cause more oxygen loading. So hemoglobin will now get converted into a more R state, facilitate further binding of oxygen. But what happens in the tissue? Tissue partial pressure of oxygen is not that high. So it will cause release of oxygen, and your hemoglobin will preferably stay in the T state or the taut state. Okay, so tissues at rest, the PO2 is around 40, needs a PO2 of around 40, and tissue and the alveoli, you see, it acquires a PO2 of the PO2 is around 100. So the next component of the ODC or the oxygen dissociation curve is something known as the P50. Now, P50 is a little bit of a confusing term. It is the partial pressure of oxygen at which the saturation of hemoglobin is 50. Okay, so the 50 over here is the saturation. So at this saturation, what is the partial pressure is what is the P50 value. What does it imply? It basically is a measure of the affinity of hemoglobin for oxygen. The normal adult, the P50 is around 24 to 28. Some texts will describe it at 26, some at 27. The rough range is around 24 to 28. What happens when you have a higher P50? A higher P50 denotes that the affinity for oxygen is lower, and a lower P50, that means less partial pressure is required to saturate the oxygen, the hemoglobin, right? So this means the affinity is higher. Okay. I hope it is clear. If at any point you think I am going fast or you want me to slow down, please let me know. So the next thing that you have to describe in the oxygen hemoglobin dissociation curve is the factors that affect it. Okay. So we all know about two things. One is factors that cause a left shift, factors that cause a right shift. When we say that there is a leftward shift, what do we imply? That means lesser PO2 is required to increase the saturation. That means the affinity is high of hemoglobin for oxygen. So there will be less release of oxygen. So when will this occur? Whenever I've tried to put everything in decrease. There's a decreased CO2, decreased H plus, or an increased pH, decreased temperature, and decreased 2,3 dpg. So that means your hemoglobin is holding on to oxygen very tightly. Okay, that means basically your tissue demand is not so much over here. So it is holding on to the oxygen. Okay, what happens when there's a rightward shift? That means the higher PO2 is required to achieve a same level of saturation. Higher PO2 is required to achieve the same saturation, meaning affinity of hemoglobin for oxygen is less. That means it will release more oxygen. So when will it release more oxygen? It will release more oxygen in conditions where the tissue demand is so. So you will see this in conditions where there is increased carbon dioxide, increased H plus, temperature is high. Again, that means the metabolic demand is higher. 2,3 dpg is high. Okay. So right, I've just put everything over here as decrease. So or when all of these decrease, there's a left shift just to make it easier to remember. And when all of this are increased, there is a right shift. So these shifts, if you see this curve, is explained by, one is the Haldane effect, where O2 is displaced from O2 displaces carbon dioxide from hemoglobin, which causes the left shift, and one is the Bohr effect, which causes the right shift. So let us just discuss these two effects a little. Okay, so Bohr effect. Now, The Bohr effect is basically what happens between hemoglobin and oxygen in the presence of acid. Okay, this is what your Bohr effect is. So Bohr effect is basically described as a decrease in the affinity of hemoglobin when the blood pH falls. Okay, what is the mechanism of this? Whenever your pH falls, more of your H plus ions will bind to hemoglobin, and this binding will stabilize the tense form. And tense form we know has lower affinity for oxygen. It will facilitate release into the tissues. Okay, so by and large, whatever unloading of oxygen by the hemoglobin occurs in the tissues is basically decline in the PO2, difference, concentration difference. But a little extra hemoglobin unsaturation is due to rise in the CO2 at the tissue level, and this causes the consequent shift of the curve to the right. Okay, basically it is how the tissues locally regulate their oxygen supply. How? If the demand metabolic activity is high, there's more carbon dioxygenation, more H plus release, both of these will bind to hemoglobin and stabilize the taut form, causing more release of oxygen. And the opposite is happening in the lungs. Over here, there is lesser CO2, there is lesser acid, and HB loads onto oxygen. Now coming to Haldane effect. So what is the Haldane effect? So Haldane effect is the exact opposite of the Bohr effect. What does the Haldane effect says? It is basically the equation of hemoglobin with carbon dioxide in the absence of oxygen. That's the simplest way to remember it. So deoxygenated hemoglobin has an increased capacity to carry CO2, and this is what is called as the Haldane effect. So why does this occur? So if you see at the tissue level, deoxygenated hemoglobin will bind more, it binds more readily with carbon dioxide and forms carbamino hemoglobin. Also, deoxygenated hemoglobin is like an acid buffer, so it will buffer more H plus ions, and if more H plus ions are taken up, there is more enhanced conversion of carbon dioxide to bicarbonate, and this promotes the uptake of carbon dioxide from tissues into blood. So actually, not to explain this, I'll tell you this simple equation of where your CO2 and your carbonic anhydrase enzyme is here. So your CO2 plus will give you your bicarbonate ion plus H plus. Okay. So when more of this is buffered, this conversion will increase. That is what is the implication of this statement. And what happens in the lung? In the lung, you have more of an oxygenated hemoglobin. So oxygenated hemoglobin will have, because of the Haldane effect, less ability to bind to carbon dioxide. So this carbon dioxide will be released, and there is more release of carbon dioxide into the alveoli for exhalation. So basically, your deoxygenated hemoglobin has more affinity for carbon dioxide by virtue of the Haldane effect, and it is a weaker acid and buffers more H plus ions. Okay, so at this point, now we end the whole oxygen cascade. Now we come down to some concepts known as the oxygen content, oxygen flux or the oxygen delivery, oxygen consumption, and oxygen extraction ratio. So these four terminologies, their definitions, what are their formulas, what are the factors that affect it, and what are its clinical implications. Okay. So coming to what is oxygen content. Oxygen content is also described as CaO2. When we're talking about arterial content, it is A, and when we're talking about venous content, it is V. So basically, it is the total amount of oxygen carried in the blood. So the formula is very simple. We've already seen two forms, right? Hemoglobin bound form, dissolved form. So hemoglobin bound form will be hemoglobin into 1.34. That is, each gram carries 1.34 ml of oxygen into the saturation of oxygen. Plus the dissolved oxygen is given by the Henry's formula, where it's basically solubility factor multiplied by the partial pressure of oxygen. Okay. So, okay, I've broken it down in a text form. You have a bound oxygen, you have dissolved oxygen. So what is the clinical implication of oxygen content? It basically determines the amount of oxygen available for delivery to tissues. So now comes the next concept based on oxygen content is the oxygen delivery or oxygen flux. Oxygen flux was an older term used for oxygen delivery. Right now, it is more commonly described as the DO2 or the so delivered oxygen. So what it is, it just quantifies the amount of oxygen delivered to tissues per unit of time. The formula is given by the oxygen content into cardiac output into 10. Why 10? Because you're converting oxygen content, which is per deciliter or per 100 ml, to per liter. So you'll have to multiply it by 10. That's just a conversion factor. Okay, this is a self-explanatory formula. Now, how much oxygen will be delivered is a product of the content in the content of the oxygen and the cardiac output. Now, you remember by this, the earlier formula, content is dependent on hemoglobin and saturation. If you remember these formulas, now writing the entire answer is very easy. You just have to describe each factor based on what all are the components of that formula. So, you know, if your DO2 depends on hemoglobin, it will be affected in anemia. DO2 depends on saturation, it will be affected when there's hypoxemia. DO2 depends on cardiac output, so it will be affected in a shock state. So, basically, you should know the components of the formula and you can just describe the answer. So, what are the factors that reduce DO2? Like I told you, three things, right? We were talking about oxygen content में hemoglobin, saturation, and cardiac output. So anemia reduces the oxygen carrying capacity, hypoxemia or low SO2, and finally low cardiac output, which will be seen in any shock state. So even if you have a normal oxygen content, your oxygen delivery can get affected if your cardiac output is low. So how does the body compensate for this? If your hemoglobin is low, they will try to increase your cardiac output by tachycardia, or it will enhance the oxygen extraction. So whenever the delivery of oxygen to the tissues falls, the tissues will not get hypoxic because they have a margin of increasing the extraction from whatever oxygen is delivered to them. Okay. So we'll see oxygen extraction also later. So now what is the limitations of using DO2 in clinical practice? One, it is a global oxygen delivery, does not consider regional perfusion differences. Second, now how much oxygen is utilized by the tissues is also dependent on microcirculation and mitochondrial function, which is not calibrated by the DO2. And what is more important more than the delivery is what is the consumption and the balance between the two, the oxygen extraction ratio and the balance. So plain DO2 has these clinical limitations. Okay. So now from delivery, we move to the next thing, that is the consumption. So consumption is denoted by VO2. So VO2 is the rate at which your tissues will extract and utilize oxygen from the blood for aerobic metabolism. It basically reflects your body's metabolic activity. How much oxygen we consume is basically a reflection of the metabolic rate. So if your metabolic activity increases, like fever, sepsis, anxiety, pain, all of this will cause your VO2 to go up, your oxygen consumption to go up. So if your delivery is not matched, there will be tissue hypoxia. Okay. So coming to the formula for VO2, it is basically cardiac output into the difference between the arteriolar and the venous oxygen content into 10. So we saw 10 is basically your conversion factor. CaO2 is your arterial oxygen content. CvO2 is your venous oxygen content multiplied by your cardiac output. So what is the normal value for this? It's around 200 to 250 ml per minute for a healthy individual at rest. So if you multiply, simply you can see if your cardiac output is say 4 to 5 liters. Okay, say 5 liters roughly normal. Arterial oxygen content we just saw, no, it was around 20. The same thing venous, if you calculate, it will roughly come up to 15. Okay, so this difference is around 5. So 5 into 5 is 25, into 10 is 250. Okay. So now how do you measure oxygen consumption? This comes in as a part of nutrition also. It is measured by either indirect calorimetry or you can use fixed principle. But for fixed principle, to measure VO2, you need to know the cardiac output via some measurement, like either PA cath or echo. And you need AV oxygen difference. So for this, you need a central venous oxygen and an arterial oxygen. So pulse oximetry and mixed venous oxygen saturation, so you can indirectly put in the values in the formula and get the VO2. And there are certain non-invasive methods like NIRS, which are less precise. So again, I told you what increases consumption. Anything that increases the metabolism: fever, sepsis, trauma, burns, increased work of breathing, pain, agitation. And what will decrease VO2? The exact opposite. Anything that decreases metabolism, your hypothermia, sedation, paralysis, or if there is any end stage organ failure. Also, your VO2 in a critical care setting will depend somewhat on your oxygen delivery, correct? So if in a critically ill patient, your delivery of oxygen is impaired, after a point in time, even your consumption will drop. I will explain this later because there's an entire question on relationship between delivery and utilization of oxygen in the critically ill patient. So before that, we come to something known as the oxygen extraction ratio. Okay. I'm just giving you a brief of what we have seen so far. We saw delivery of oxygen or DO2. We saw consumption of oxygen, that is your VO2. DO2 is basically your cardiac output into your arterial oxygen content into 10. VO2 is basically your cardiac output into difference between arterial and venous oxygen content into 10. And oxygen extraction ratio is the ratio of your VO2 to DO2, basically how much of what is consumed to how much of what is delivered. So this can simply, if you put it in the form, you put the formula of VO2 and DO2, cardiac output in the numerator and denominator will get cancelled. So it is basically AV difference in the oxygen content upon arterial oxygen content. So what does this imply? It is the balance between delivery and consumption is what is given by your extraction ratio. So it gives you an insight into the tissue oxygenation and metabolic demand, balance between demand and supply in a critically ill patient. So your normal extraction ratio is around 20 to 30%. Okay. So if you take this difference, we have roughly calculated CO2 in the previous slides. It's around 20. If you take venous as around 15 and this upon 20. So you get 5 by 20, this is 1/4, almost 25%. So the range for a healthy individual is around 20 to 30. So what is the clinical significance of oxygen extraction ratio in critical care settings? When does it increase and when does it decrease? So when it is high, that means your tissue have a high demand or a low supply, correct? That is why the or a low supply. So that is why the extraction is more. So when does the demand increases? Sepsis, fever, trauma. And when, or if there is a low delivery, that means in a shocked state or an anemic state or a hypoxemic state. I told you, na, DO2 is basically hemoglobin, SO2, and cardiac output, right? So when either your delivery is not matching your demand or your demand has gone above your delivery, your extraction ratio will increase. When your extraction ratio is low, what does it imply? It implies either there is either your tissues are not taking up only the oxygen, maybe due to some microcirculatory dysfunction or mitochondrial failure, or you have over resuscitated the patient. Now, there's excess oxygen delivery. So basically, while describing oxygen extraction ratio, you are only talking about the demand supply match. Okay. So why is this important? It will help guide you. I'll explain this in the further slides. Okay. So now you listen, just pay attention to this graph. In this graph, you have DO2 on your x-axis. So if you see how much ever the DO2 decreases, the VO2 doesn't change. Matlab, oxygen ka delivery is decreasing due to some reason. But even then, the utilization is not affected. Why? Because the utilization, the tissues are compensating by increasing the oxygen extraction. Okay. So once this is maxed out, this is known as your critical DO2. Okay. Below this, now your oxygen utilization is becoming supply dependent. This is what is happening in a critically ill patient. This part is what is normal. Once the critical DO2 is crossed and the oxygen extraction ratio is maxed out, more than this, the extraction cannot increase, your utilization now becomes supply dependent. What does it mean? If my delivery of oxygen is not good, my tissues will become hypoxic. Okay. So this is what is seen in critically ill patients. This is a phenomenon known as the DO2 dependent VO2. So this slide is important because this is a question of what is the relationship between transport, utilization, delivery of oxygen in a critically ill patient. So in a critically ill patient, once the oxygen extraction ratio is maxed out, the utilization of oxygen or your O2 consumption, VO2, is now dependent on the delivery. And if this delivery falls or it does not match the supply, there will be tissue hypoxia. Okay, so again, I told you 3 states always remember. Wherever there is either the cardiac output is failing you or your sorry. So we are 3 examples you will remember. One is the shock state where your DO2 is dropped because of decrease decrease due to some shock state, either septic, cardiogenic, or hypovolumic. Second is hypermetabolism. Hypermetabolism, that means now your consumption was gone up. So that is why this supply, whatever you're getting, is not enough. This can happen in sepsis, trauma, burns, where your oxygen consumption is increasing. And that is why the delivery is not matched. So here you need to do measures to improve your delivery or improve your cardiac output in order to match the metabolic needs. Then third is impaired utilization. That means your delivery is also normal. Your consumption, your consumption is also normal, but there's some microcirculatory or mitochondrial dysfunction. So the extraction of so utilization of oxygen is affected. Because of this, the O2 extraction ratio will be normal. So these three things you have to remember. One is where your DO2 has actually fallen. One is where your demand has increased. And one is where your utilization is impaired because of some microcirculatory dysfunction or mitochondrial dysfunction. So this is basically summing it up of how VO2 and DO2 interplay during a critical illness. So certain examples, like in septic shock. Septic shock is a high metabolic state. Your consumption is high. Your DO2 might be normal or variable, and your extraction will be elevated. So you have to resuscitate more by giving more fluids, vasopressors, source control. Despite that, in an advanced stage, your microcirculatory dysfunction may persist. In cardiogenic shock, the cardiac output is only low, so your DO2 is low. In an ARDS, what is happening is hypoxemia, because of which your DO2 is low. So you need to focus on ventilatory strategies to improve your saturation. And in states like burns and traumas, what is happening is your consumption is increased. So if your supply is not in match with this increased consumption, there will be tissue hypoxia. Okay, so this is how we've ending this part of interplay between oxygen delivery, oxygen utilization, oxygen extraction ratio, and certain examples and how they interplay in the critically ill patient. What I would suggest is you focus on this graph. This graph will give you all the information. Focus on the formulas, and then you can formulate your own answers on how the factors are affected. Okay. Now coming to a next question. This is a very basic question, but it is just good to pass this thing below your eyes just before the exam, so that you don't fumble in formulating the answer. So the question is on acute respiratory failure types and causes. So basically, what is acute respiratory failure? Inadequate oxygenation or ventilation, ultimately causing impaired gas exchange. There are 4 types. Most commonly described are type 1 and type 2. Type 1 is hypoxemic. That means your PO2 is less than 60 on room air. Often the PaCO2 will be normal or low, because the patient will hyperventilate to compensate for the decrease in the oxygen. Second is your hypercapnic respiratory failure. Hypercapnic respiratory failure means this is mainly there's some sort of hypoventilation. This may be associated with or without, it may be associated with hypoxemia or not. So if you focus on the figure, hypoxemic, anything that causes hypoxemia, you can just list out these causes: edema, pneumonias, ALI or ARDS, atelectasis, aspiration, pulmonary contusions or trauma, pulmonary embolism. Hypercapnic is basically your ventilation is affected, right? So this is either a pump problem or a load problem. If there is a pump problem, you can start right from your CNS to your muscles. So it can either be CNS depression, spinal cord injury, neuropathy, neuromuscular junction, or myopathy. Or if there is an increase in the workload, this is seen basically in obstructive diseases: COPD, asthma, cystic fibrosis, and bronchiectasis. Okay. So if you understand the term, you understand the mechanism, you can list out the causes. This is your type 1, type 2. Some texts also describe type 3 and type 4. Type 3 is basically a subcategory of type 1, but it is specific to what occurs in a perioperative setting, where you see a lot of atelectasis due to anesthesia or any surgical complication. And type 4 is shock related. Shock related, basically, since your delivery of oxygen is affected, your respiratory muscles demands are not met. There is muscle weakness and muscle fatigue. Okay, so these are the 4 types of acute respiratory failure. This is a small question. Just let it go across your eyes before the exam so that you don't fumble. This is again one slide on a very small question on the types of hypoxia, because It's a very basic thing, but sometimes you just get confused at the time of the exam as to what is what. So you have hypoxic hypoxia, hypemic hypoxia, stagnant hypoxia, histotoxic hypoxia. Okay. Hypoxic hypoxia is basically your lung oxygenation is only affected. This can be seen in high altitude or alveolar hypoventilation. Hypemic hypoxia, that means this is hypemic, or you can say anemic, basically due to drop in the hemoglobin. Stagnant is where your circulation is there's a circulatory failure, and histotoxic is where your delivery is fine, but your cells are not able to use it because of either some mitochondrial damage, same cyanide poisoning. Okay. So just a small go through. Okay, so the next part, I hope these concepts are clear. I know these they are a little confusing and a little repetitive, each of them. But it's if you don't go through it before your exam, you will fumble to write the answer. So please take some time in this week to go through this again. And if at all you feel you need any clarification on any of these, please let us know. Coming to the next question, this is I've covered everything under oxygen therapy. So there are questions like indications. Delivery devices is a big question in itself, and each of the devices a short question in itself. Monitoring and complications. Complications basically oxygen toxicity. Okay. So oxygen therapy is basically administration of oxygen at a concentration greater than the ambient air. So oxygen is a drug. So you need to write the therapy as a proper prescription that is described under 4 headings. 1, flow rate. 2nd, delivery device. How do you intend to give that flow rate? Duration of how long do you want to give, and instructions for monitoring. What is your target? You're targeting your saturation, you're targeting your PF ratio, all of that. Okay. Coming to indication, just remember 4 categories. You can write the categories on it. 1 is hypoxemia, of course. All your causes of respiratory failure, ARDS, pneumonia, pulmonary edema, pulmonary embolism. 2nd category is a demand-supply mismatch, sepsis, trauma, burns, post-arrest, myocardial infarction. 3rd category is peri-procedural for airway protection, like during intubation, during suctioning, during bronchoscopy, post-extubation support, during any sedation or procedural anesthesia in the ICU. And other categories in certain categories like carbon monoxide poisoning, where high flow oxygen or even sometimes hyperbaric oxygen is therapeutic. Cluster headaches, one of the approved indications for using high flow oxygen as an abortive therapy, and methemoglobinemia. Okay, so the 4 categories are hypoxemia, demand supply mismatch, peri-procedural, and other conditions in which you have to deliver a higher concentration of O2. Now coming to O2 delivery devices. Okay, so now O2 delivery devices, there are basically 2 types of O2 delivery devices. One is based on ambient pressure, and one in which there is positive pressure. Ambient pressure devices are again 2 types. One is a variable performance device, also known as a low flow device. So variable performance device means it delivers oxygen at flows less than the patient's inspiratory demand. So what is varied over here? Varied is the FiO2. So it is giving a fixed flow. The patient might have a higher tidal volume, a higher respiratory drive, tachypnea. So that delivered the flow, the FiO2 will get diluted in the patient's ultimate minute ventilation, and the delivered FiO2 may vary may vary and not be what you have administered. The next is fixed performance devices. Fixed performance devices, also known as high flow devices. So what performance is fixed? FiO2 is fixed. So how does the FiO2 get fixed? By delivering a flow which is either equal to or greater than the patient's peak inspiratory flow. Okay, so this ensures that the FiO2 is fixed at all times and it is not diluted when the patient's minute ventilation does not match the flow rate at which you're delivering oxygen. What are the examples of low flow devices? Nasal cannula, simple face mask, rebreather mask, non-rebreather mask. And what are the examples of fixed performance devices? There are two: high flow nasal cannula or a Venturi mask. Positive pressure, it's either a non-invasive ventilation or an invasive mechanical ventilation. Okay, so we'll deal with each of these devices and also we'll deal with NIV. Invasive mechanical ventilation, we'll be dealing with all those questions in another session. Coming to the differences between what a low flow device and a high flow device, we've just discussed this. Flow is not constant. FiO2 is not constant. Here the FiO2 is constant. Flows are lower, 6 to 8 liters. It is mixed with oxygen and room air. Here the flows are very high. It is almost 4 times the actual minute volume of the patient. Okay. So the FiO2 over here varies with the tidal volume. So if the patient is having a shallow breathing, there will be less entrainment of room air. A higher FiO2 will be delivered. The patient is having a deep hyperapneic breathing. There will be more entrainment of room air and lesser FiO2 will be delivered. Okay, high flow oxygen devices, contrast to these low flow devices, they are actually preferred in patients who depend on the hypoxic drive to breathe, like COPD patients who require a controlled increment in the FiO2, okay, where the FiO2 cannot vary. So I'll give you a numerical example of how a low flow device delivers or dilutes the FiO2 with the patient's minute ventilation, okay? So if you're providing an FiO2 of 2 liters per minute with a low flow device, take two examples. One, a patient who is breathing at 30 liters per minute. Another, a patient who is breathing at 5 liters per minute. Okay. So out of this 30, 2 liters is going at 100% FiO2. The rest of the 28 liters is going at 21% oxygen. That is your room air FiO2. Okay, so if you add this 2 into 100% plus 28 into 21% out of the total 30 liters, your ultimate FiO2 is 26%. But the same thing in a patient whose minute ventilation is only 5 liters will come up to 53%. Okay, so 2 liters of 100% FiO2 plus the remaining 3 liters of the 5 liter at 21% FiO2. If you add this and divide it by the total 5 liters of minute ventilation, your ultimate FiO2 delivered is higher. That is 53%. So the FiO2 is varying in a variable performance device. Now coming to each device. Okay, so each device I have, just for the ease of revision, put it in 4 tables. Okay, one, the flow FiO2 ratio of each. Second, what is the reservoir there? What are the advantages? What are the disadvantages? Advantages, you too much experience at the bedside to understand and write these. But what you need to make sure that you revise is these 2 columns before the exam. The exact number of the flow and the exact number of the FiO2. So what is a nasal cannula? It basically is an O2 delivery device with 2 prongs attached to a tubing. Okay, so it gives you a flow of 2 to 4 liters per minute only and an FiO2 of 0.28 to 0.36. Okay, the formula for calculating FiO2 based on the flow over here is 20%, that is your room air FiO2 plus 4 into the flow rate. So if you're giving 2 liters of oxygen via nasal prongs, the FiO2 ultimately delivered be 2 into 4, that is 8. 8 plus 20, that is 28. Okay. What is the reservoir? The reservoir basically, your nasopharynx in case of a nasal cannula acts as a reservoir. That means when the patient breathes with a breathes through the mouth, whatever air is flowing, it will produce a venturi effect in the posterior pharynx, and it will entrain oxygen entering from the nose. So now your entire dead spaces become of a higher FiO2. What are the advantages? You can write that, right? It is patient is comfortable, he can eat, speak, drink. It's a low flow device, does not require humidification. It is cheap. It is ideal for patients on long-term therapy. What are the disadvantages? Of course, it cannot provide a high flow O2. Side effects, it can cause some nasal irritation. And of course, it's a variable performance device. So the FiO2 is varying with the patient's respiratory efforts. And if you give a higher flow rate through this, it will become very uncomfortable for the patient. Also, that the FiO2 will not really increase with the flow rate of more than 6 liters. So that is the maximum you can go with a nasal cannula. Right? Next comes your simple face mask or your Hudson's mask. It's basically a transparent mask provided with side holes. So over here, what is the flow and FiO2 ratio? Minimum flow that you have to give is of 4 liters, and the FiO2 achieved is roughly 0.35 to 0.4, 35 to 40% in a normal respiratory pattern. Beyond 8 liters of flow will not really increase your FiO2. And this is one device which gives a very unvariable and a very unpredictable FiO2. Okay, so it has a reservoir capacity of 100 to 200 ml. The mask size itself is around 100 to 200 ml. And in this, what happens is rebreathing of CO2 can occur if you give a flow rate of less than 2 liters. Okay, so you have a mask on the face. In that mask, if the flow of oxygen is less, whatever carbon dioxide is released out will just occupy that mask, and patient will rebreathe carbon dioxide instead of breathing oxygen. So this is one sort of a disadvantage. That's why you say minimum flow rate should be 4 liters over here so that this dilution doesn't occur. Again, advantages, it's cheap, can be used in patients who are mouth breathers. What are the disadvantages? Uncomfortable, requires a good seal, does not deliver. Same, all the disadvantages of a low variable performance device. It will FiO2 delivery is not consistent. It varies with patient effort. Since it's a face mask, it will interfere with communication, eating, drinking, and its patient won't keep it for too long. And also, like we explained earlier, chances of rebreathing are very high over here. Then coming to a rebreather mask. So what is a rebreather mask? Rebreather mask means there is a reservoir bag, but there is no valve between the bag and the mask. So whatever the first portion of exhaled gas is coming out from the patient, which is rich in carbon dioxide, this is the reverse. Rich in carbon dioxide and less in oxygen, it enters the bag and it will be inhaled again in the next breath. So that is what it is called as a partial rebreather mask or a rebreather mask. Okay, so it lacks a valve between the bag and the mask. Okay, I have a picture for you. Okay, so partial rebreather mask. These two ends are open. Okay, in the mask. So this open end allows your expired gas to go. Some of your expired gas will enter in this reservoir because there is no valve over here. So some of it will dilute this. Okay, so the ultimate FiO2 delivered will not be as great. It's around 0.6 to 0.8. Now, in order to give a good flow rate, in order to give a good FiO2, the flow rate should be high enough to keep the bag 1/3 to 1/2 inflated at all times. So minimum 8 liters of flow of oxygen should enter the mask in order to effectively remove the exhaled carbon dioxide. Okay, so the reservoir capacity over here is around 1 liter. Advantages, though there is partial rebreathing, the inspired gas over here is inspired gas is not mixed with the room air. You're breathing from the reservoir, and here again disadvantages: how much ever you increase the flow, it does not increase the FiO2, and mask, so interferes with eating, drinking, communication, all that. Okay, so just going through the flows of each. Nasal cannula 2 to 4. FiO2 is given by the formula 20% plus 4 into oxygen flow in liter per minute. Simple face mask, minimum flow should be 4. Flows beyond 8 will not increase the FiO2, and the FiO2 delivered is roughly 35 to 40%. It's highly variable. Rebreather mask, here the minimum flow is 8 liters. It should be titrated to keep the bag inflated at least 1/3 to half, and the FiO2 delivered is 60 to 80%. Okay, now coming to a non-rebreather mask. So in a non-rebreather mask, the difference is that at this point, there is a valve. Okay, there is a valve which prevents your expired air to come here, and it allows only 100% oxygen to occupy this reservoir. So the breath taken is not diluted with carbon dioxide. Also, there are two one-way valves at the expiration port. So whatever gas is expired is going out and again not occupying your mask space, so that there is no dilution of the oxygen delivered. Okay, but as a safety measure, both the sides of the expiration ports are not having a one-way valve. Usually one of it has a one-way valve, one doesn't, just in case your oxygen supply fails, the patient will suffocate and further desaturate by rebreathing more and more carbon dioxide. So it's a safety measure. One of this valves has an exhalation port, and one of the exhalation ports has a valve, and the other exhalation port does not have a valve. Sorry. Okay, so the FiO2 achieved over here is around 95%, and the flow rates should be as high as 10 to 15 liters. Again, bag capacity is 1 liter. So this is, you get a good FiO2. The only variable performance device or low flow device giving a decent FiO2 is your non-rebreather mask. Okay, again, these disadvantages you can write. The major disadvantage, like I told you, if there is any malfunction in the oxygen supply, the carbon dioxide will build up, and that will further worsen the patient's condition. Next, we come to a Venturi mask. So now we have done with 4 low flow or variable performance devices. Now we are coming to a high flow or a fixed performance device. The first we are going to see is Venturi mask. First, I will discuss with you the principles involved in the mechanism of the Venturi mask. Okay, so there are 2 principles involved. One is the Bernoulli's principle. So what does the Bernoulli's principle say? Bernoulli's principle says that whenever there is any narrowed tube through which air has to flow, what will happen is the velocity beyond this narrowing will increase. Okay, so if the velocity increases, it comes at the cost of what? It comes at the cost of pressure. Okay, so your pressure drops. All right, this is what is your Bernoulli's phenomenon. That is, when any fluid, air or liquid, passes through a narrowed tube. So you know na, the classical example they give you to a jet. If through a pipe, suppose through a pipe a fluid is flowing, and if you obstruct it and you make it narrow, the velocity of the flow of that liquid beyond that narrowing will increase. Okay, but this comes at a cost of a drop in pressure over here. Now, the second principle that is used in that is applied in a Venturi mask is that of the Venturi effect. Okay, so what does the Venturi effect say is, beyond this narrowing, if you put an additional port, okay, so because the pressure has dropped, it will suck in air from these ports, okay. This is what is known as the Venturi modification of the Bernoulli's principle. Okay, so now you have mixing of two gases, one that you have flowing through the narrowed tube and one that you have entrained into from the room air by causing the pressure drop. Okay, so if you adjust the diameter of the jet and the entrainment port, you can exactly fix the FiO2. Okay, so as the oxygen velocity will increase at the nozzle, lateral pressure drops, entrains room air via the side holes. Okay, so this we will see in this diagram over here. I'm just going through it again once more. You have a Bernoulli effect in this diagram. This is something you can just easily recreate on your exams also. One side you show the Bernoulli effect, the other side you show the Venturi effect. Bernoulli effect, you show that the nozzle has caused an increase in the velocity beyond and a drop in the pressure. And this, when there are two side ports, it is entraining room air. So if the patient is breathing over here at 30 liter per minute, okay, and you have passed 2 liter per minute of oxygen through this jet of nozzle, the pressure drop created through this nozzle in this part will allow 28 liters. So 30 liter में से 2 liter गया ना, तो बाकी का 28 liter will be sucked in from these two side ports, 14 each. Okay, so this will give you a total gas flow of 30 liter, and you can calculate your exact exact FiO2 if you know the size of this nozzle. So there are different colored nozzles with different flow FiO2s to each. I've just kept this here so you can revise it for your practical exam also. Your FiO2 over here will vary from 24% for 2 liter flow to 28% for 4 liters, 31% for 6 liters, 35% for 8 liters, 40% for 12 liters, and 60% for 15 liters. So the maximum FiO2 that can be generated by a Venturi mask is 60%. So the FiO2 range provided is 24% to 60%, which I've put in this part of the table. Next is what is the reservoir or dead space over here. So there is a continuous flow of fresh gas, right? So there is no rebreathing and there is no increase in dead space. So what are the advantages? So when you're providing a fixed oxygen, it provides a fixed oxygen concentration. It's useful in patients who depend on their hypoxic drive, like COPD patients. So the high flow comes from the air. Okay, so this actually saves the oxygen cost. You don't need a specific blender. You just a nozzle and two side ports, which is causing blending of oxygen with the room air in a fixed proportion. It will help you get an exact measurement of how much FiO2 requirement is going up or going down. Disadvantages, again, it's a mask, so it interferes with food and drinking, and it cannot deliver a FiO2 more than 60%. We've seen maximum FiO2 given by Venturi mask is 60% with a 15 liter flow. I hope Venturi mask concept is clear. You need to just see this diagram to remember what is the Bernoulli effect and what is the Venturi effect. Now the second second fixed performance device or high flow device is your high flow nasal cannula. This is a very is a very repetitively asked question. So what is a high flow nasal cannula? It is a device that delivers heated humidified oxygen at a high flow of up to 60 liter per minute, which matches the patient's inspiratory demand. Okay. So the major parts of this definition is heated, humidified, and high flow. Okay, so the defining features of a high flow nasal cannula are these three only. If you remember these 3 points, you can elaborate your whole answer around it. Okay. So first you describe the parts of a nasal cannula. High flow nasal cannula, sorry. Okay, so it has an air oxygen blender. It has a flow meter that regulates your FiO2. From this, there is a tubing that enters the heater humidifier unit. This heater humidifier unit needs a sterile water supply. So there's a sterile water bag connected to it. From here, the tubing, which is a heated breathing unit. This circuit is special. There's a special circuit that is providing both heated and humidified air through a nasal cannula. Okay, so you can draw a schematic diagram of this, label all the parts. Now describing the mechanism of HFNC, I told you, just remember these things: heated humidified oxygen and a high flow rate. So when you're giving heated and humidified oxygen, what all you're doing? One though, since it's not, you're giving a good flow with the good humidification, so there is less airway inflammation. This maintains the mucociliary function. Okay, normally if you give too much, you try to give a high flow with a low flow device, they are not humidified, right? So that can cause drying and dysfunction of the cilia. So this is maintained with an HFNC, because of which there is better clearance of secretions. The third is the decrease in the metabolic cost of breathing. Of course, so if you're giving, if you give dry air, no, the patient's airway resistance also sort of increases. There's inflammation, there's some little sort of constriction. So all of that is eliminated. So the amount of work that has to be generated against that inflammation is less. Okay, so this, in a more refined way of saying it, it decreases the metabolic cost of breathing. Next comes the high flow rate. So what are the benefits of giving a high flow rate? First, that's your favorite go-to answer of an HFNC. You get a small PEEP effect provided the patient breathes with a closed mouth. Okay. This PEEP effect is very minimal, around only 2 to 6 centimeter of water. Along with that, if you're giving a high flow, there is some amount of positive pressure generated by it. How much is that? For every 10 liters of flow, a positive pressure of around 1 centimeter of water is generated. So if you're giving a 30-liter flow, it is as good as giving a pressure support of 3. Like we've discussed, high flow rate matches the patient's flow rate, so the FiO2 is not diluted. Of course, it reduces when the flow rate is good, you're matching the patient's demand, the work of breathing is less. Third, it flushes the nasopharynx with oxygen and reduces the dead space. Okay, so the next breath that is taken from the dead space is also highly oxygenated. Okay, so this one diagram sums it up all. I'm telling you, HFNC, heated humidified oxygen, and high flow rate. These two things you remember, you will be able to recreate the whole chart. So what are the indications of HFNC? Indications of HFNC are predominantly hypoxic respiratory failure. So also it finds its role in immunocompromised patients, in post-extubation respiratory failure, pre-intubation oxygenation, during procedures like bronchoscopy, post-cardiac surgery hypoxemia, and for palliative care patients, because it keeps the patient very comfortable. Okay. There are a lot of studies on immunocompromised, role of HFNC in immunocompromised patients. And also we know during pre-intubation oxygen, how much it helps during procedures like bronchoscopy, since your mouth is, is clear, the scope can pass through easily. And also in post-cardiac surgery hypoxemia, where, you don't want to use too much of a positive pressure post-thoracotomy. monitoring the patient on an HFNC. So this, for HFNC monitoring, what we use the ROX index. Okay, it's a bedside tool to predict success or failure of an HFNC, high flow nasal cannula therapy in patients with acute hypoxemic respiratory failure. So now try to understand a simple concept. When your patient is in a respiratory failure and you're giving such a nice high flow device which is maintaining your saturation, sometimes you might be fooled into delaying intubation, thinking that okay, your saturation is being maintained and a patient is your problem is solved. But delaying intubation in critically or severely hypoxemic patients and just pulling on an HFNC will also cause an increased mortality. So that is why they have devised certain indices or certain ways of monitoring such patients to make sure that your HFNC will be successful or it will fail, so that you can decide early on whether you want to switch to an intubation. You don't wait till the patient crashes. So what is the formula of the ROX index? ROX index basically is the ratio of SpO2 to FiO2 with RR. Okay. So your SpO2 is your peripheral oxygen saturation, FiO2 is your fraction of inspired oxygen, and RR is your respiratory rate. What are the normal values? So the original study from where the ROX index was derived was from non-COVID pneumonia patients, where they found out that a ROX index of more than equal to 4.88 is at 12 hours is high, suggests a high likelihood of success with HFNC, and it is safe to continue HFNC with a lower risk of intubation. But if the ROX index is less than 3.85 at 12 hours, it predicts HFNC failure, and you should consider early escalation in such patients. Most of your validation studies are in COVID patients, and the cutoff varies in different studies and depending on which timing the ROX index has been measured. So what you need to understand is a trend over time is more important than a single value. But for exam purposes, just these two values: ROX of more than 4.88 at 12 hours, likelihood of success; ROX of less than 3.85 at 12 hours, likelihood of failure. These two numbers you have to remember. The formula, that is SF upon RR. So where does the evidence for the use of HFNC comes? Nowadays, a lot of questions are asked on hot papers. Okay, so there are a lot of questions on your ARDS trials, EOLIA, Caesar trials, and ECMO. So these classic trials, they do ask points like compare and contrast or criticize. So for some studies, I preferred making notes so that at the time of exam, it's just easy to revise. So one of them is the Florali trial. Basically, it is an evidence for use of HFNC in hypoxemic patients. So you don't need to know all the details. What you need to understand is they compared 3 groups: HFNC, NIV, and standard oxygen therapy. The primary outcome was intubation and secondary outcome was mortality. What if you see the patients on HFNC requiring intubation were less, but this didn't touch statistical significance, but the mortality was slightly lower in patients who were on HFNC. There was no difference in length of stay. And when they did a post hoc analysis in patients with severe hypoxemia, where the PF ratio was less than 200, they found very nice results. That is, the rates of intubation, ventilator-free days, mortality was significantly lower in patients with HFNC compared to those with NIV or standard oxygen therapy. Okay, so after this paper propagated the use of HFNC a lot, but there are certain weaknesses to this study. Most of the patients are of pneumonia. Okay, they don't study the classical definition of ARDS. They just have taken patients with acute hypoxemic respiratory failure. That's it, okay? And the patients on the NIV group most of them were hardly on the NIV for less than 4 hours a day or less than 8 hours a day. So it's kind of a crossover effect. It's not classically studying HFNC versus NIV. It's more like HFNC versus standard oxygen therapy only. Okay. So this was a if at all you get a question on evidence of use of HFNC, you can mention about the Florali trial. Now moving to the last part, that is non-invasive ventilation. So non-invasive ventilation definition, we are providing a positive pressure ventilation through a non-invasive interface, that is a nasal mask, face mask, or nasal plugs. Indications. So in HFNC, what all indications we saw were hypoxemic respiratory failure. Okay. And then we saw some immunocompromised, peri-procedures, all of that. Here, you are classically hypercapnic respiratory failure and classically acute exacerbation of COPD. In that, class 1 indication is acute on chronic respiratory acidosis. And if the pH is less than 7.25, even then they say you can attempt an NIV before going for invasive mechanical ventilation. This is strictly for acute exacerbation of COPD patients. Okay. It should not be routinely used in normocapnic or mildly hypercapnic patients. So other causes of hypercapnic respiratory failure included in these indications are neuromuscular weakness or chest wall deformity and obesity hypoventilation syndrome. Okay, so this I've picked up from the ISCCM guidelines on the use of NIV in ICU. So first indication that you will write is hypercapnic respiratory failure. In that you'll mention 3 things: acute exacerbation of COPD, neuromuscular or chest wall deformity, and obesity hypoventilation syndrome. Among AECOPD, even when there is a severe drop in the pH, there is a class 2B recommendation to use an NIV before going for invasive mechanical ventilation, obviously under strict monitoring. Okay, so the next category of indications are your hypoxemic respiratory failure. So again, class 1A classical indication for NIV is cardiogenic pulmonary edema. Okay, and the studies have shown CPAP having a slightly better efficacy and safety than BiPAP for cardiogenic pulmonary edema. So whenever you're describing indications of NIV, never ever forget these two. These two are the most classical class 1 indications, that is exacerbation of COPD with respiratory acidosis, acute or chronic. And second is hypoxemic respiratory failure due to cardiogenic pulmonary edema. The other causes you can mention are ARDS, but it should only be in mild to moderate cases. Severe cases, it will delay intubation and increase mortality. So chest trauma, there have been RCTs that have compared it to standard oxygen therapy and endotracheal intubation and have shown that it reduced infection and ICU stay. Palliative care patients, just to elevate their dyspnea. Immunocompromised patients, it has shown that it reduces the short-term mortality and rates of intubation. Post-operative care, whenever you see that there's a lot of basal atelectasis, you try treating that hypoxemia with NIV. Then post-surgery, abdominal surgery also, though we feel that we shouldn't, but it has actually shown to reduce intubation, mortality, length of stay. Even in bariatric surgery patients, there was no increase in the risk of anastomotic dehiscence because bariatric surgery patients are already OSAs on the NIV. So you might need to use it post-surgery also. And there has been evidence that it does not increase the risk of anastomotic dehiscence. Thoracic surgery patients increases oxygenation and decreases intubation compared to HFNC. Except for esophageal surgeries, where it is a relative contraindication. Post lung transplant, it is proven to reduce the weaning time and decrease re-intubation, and procedures like perioxygenation during endotracheal intubation. Okay, so we saw the hypercapnic indications. This is basically all your hypoxia causes, but you should be careful on the order in which you write. Always mention cardiogenic pulmonary edema first. When you're mentioning ARDS, make sure you're writing mild to moderate and not severe. And all the other causes you can definitely add on to the indication list. Now coming to the role of NIV post-extubation. Okay, so which patients do you directly extubate to NIV? So they have defined such high-risk patients, those who have failed spontaneous breathing trial more than once. Chronic heart failure, we already saw. If the CO2 is slightly high after extubation, hypercapnia is one of the classical indications of NIV. If the patient has more than one comorbidity, weak cough, or an upper airway stridor at extubation, require such patients, you can use NIV to wean from mechanical ventilation. But if you have extubated the patient and post that the patient went into respiratory failure, then you should not use NIV to manage this distress. You should directly intubate this patient, as these these patients will not do very well. Okay, so only in certain high risk patients you can directly try extubating to NIV. That is also a class 2B indication. But you should not try and use an NIV in patients who went into respiratory distress post extubation. What are the contraindications? These all you know. I've just listed it out once with examples. Inability to protect the airway, such as comatose patients, CVAs, confused, agitated patients. Hemodynamic instability requiring high-dose vasopressors. Inability to fix the interface. Any facial abnormalities, facial trauma, facial surgeries. Severe GI symptoms, because obviously you are going to risk aspiration, massive hemoptysis, copious secretions for the same reasons, and post-cardiac arrest. Okay, so these are all the list of contraindications. Always remember, inability to protect airways, severe hemodynamic instability, massive hemoptysis and severe GI symptoms, and difficulty in fixing the interface. Now coming to the types of interface that we use with NIV. One is a nasal mask. The nasal mask obviously gives you advantages. These you can write certain advantages and disadvantages. It is since there is a leak through the mouth, so the efficacy might not be very good. Second type of interface is your oronasal mask. So patient with mouth breathers, this will get covered. So it is more helpful, and this is a more efficient CO2 clearance method as compared to nasal mask. The only advantage of nasal mask is the dead space is less. Third is your nasal pillow or nasal prongs. So here you can see in this picture, there's a small pillow and two prongs coming out of it. This is light, comfortable. There you don't get skin breakdowns due to tight mask fits. But obviously, very high pressure will not be tolerated. Does not has a limited use in acute care setting. Okay. Both nasal, you should remember there will be leaks from the mouth as a disadvantage, and that is what is the advantage of oronasal. Okay, I've listed this down. This is what you do every day. You will be able to write it on your own. Just go through it once before the exam so that you don't fumble at the last minute. I've put one entire slide on helmet NIV in the ICU because it is another commonly asked question. So what is a helmet? It is a transparent hood that will enclose the entire head and a soft collar seal around the neck. Okay. So it is an alternative interface for delivering NIV. What are the advantages? Improved tolerance, obviously less claustrophobia, less skin breakdowns. Patient uses it for a longer time. Communication, drink, and nutrition is possible. And so now when we talk about NIV, we classically talk first about hypercapnic respiratory failure. But when we talk about helmet interface NIV, we talk about hypoxemic respiratory failure. So there was a key RCT that showed that it actually reduced the rate of intubation, a helmet interface in a hypoxemic. I'm again telling this is for hypoxic respiratory failure. Itna bada dead space leke you will not prefer it in a hypercapnic respiratory failure. Okay. So what are the limitations? Like I told you just now, high dead space. So it needs a very good high flow of fresh gas to prevent CO2 rebreathing. bulky, noisy, discomfortable around the neck, and limited availability and expertise, and any other contraindication to NIV, that is risk of aspiration or inability to protect the airway or poor mask fit. So like I told you, this is used for hypoxemic respiratory failure, less evidence for hypercapnic failure, and it should only be used where there is familiarity with the device if your ICU is experienced. So what are the settings that we put? One is the modes. This volume targeted you don't prefer in NIV. Theoretically, they have said for certain conditions to cause where too much pressure is required for lung expansion. Such cases, they prefer volume targeted. I've not practically seen it. Then pressure targeted modes, there's time, there's spontaneous time, pressure control, and pressure support. There are certain newer modes. One is your AVAPS, that is your average volume targeted pressure. So this ensures a specific volume being delivered in a specific range of a pressure. So in an AVAPS, if you've ever set it, you will know you set two pressures, maximum and a minimum pressure. So how much ever pressure is required in this range to achieve one target tidal volume will be delivered by the machine. Other examples are PAV, adaptive servo ventilation, NAVA. Again, these are just newer advances. So what all do we set when we set an NIV? We set trigger, we set rate or the inspiratory time, or the I time. In patients with obstruction, we set it at around 25 to 33%. In patients with restriction, we set it higher. We want the inspiratory time to be around 33 to 50%. The rise time, again, obstructed patients less, 100 to 400, restricted patients 300 to 600. And the pressure settings, your IPAP, your EPAP. And how do you establish what pressure support is to be given? It is always the difference. So if you're switching from a portable BiPAP to a ventilator NIV, always remember pressure support is calculated by the difference in IPAP and EPAP. So what are the predictors of NIV failure? There are certain there are certain risk factors: severity of illness, older age, failure to improve after 1 hour, pre-morbid multi-organ failure, if your pH doesn't improve with NIV, if there's an unidentified etiology, ARDS and pneumonias with PF ratios less than 150, and if the patient is generating high tidal volume. So a more objective way of predicting NIV failure is your HACOR score. So remember, ROX index was an objective way of predicting failure of HFNC. HACOR score is an objective way of predicting failure of NIV. So like I told you, you cannot delay intubation by giving such prolonged trials. So there are certain scores that help you understand whether you should escalate to intubation or not. So the components of the HACOR score are H for heart rate, A for acidosis, C for consciousness, O for oxygen, R for RR. Your acidosis is given by your pH and your consciousness by your GCS. Your oxygenation is given by the PF ratio. So if you see your acidosis is maximum score of 4, consciousness, the score goes up to 10. So impaired consciousness will actually within one go change the score very badly. And RR is again maximum score of 4 and oxygenation is a maximum score of 6. So what is the implication? Sorry. So if the HACOR score is more than 5 at 1 hour, okay? HFNC, we were calculating, it was the score was at 12 hours. For NIV and HACOR score, it is at 1 hour. If the HACOR score is more than 5, there is an 80% risk of NIV failure, and the predictability of this is the AUC is really good. It is 0.9, and when there an external validation show 0.71. So with good predictive value, you can say that the HACOR score will estimate risk of NIV failure. And the last thing is oxygen toxicity. So I have just pulled out points which are specific to the ICU. Okay. So I have gone from airway Airway में you will have inflammation, bronchoconstriction, increased mucus production. उसके बाद impaired mucociliary function causing mucus plugging. Down when you go from the airway to the alveolus, what you will see? One, you will see adsorption atelectasis because all the air in that alveolus is oxygen. Entire air will get absorbed in the bloodstream and there will be a collapse. Surfactant dysfunction because you're exposing oxygen, your surfactant proteins and lipids to a high oxygen concentration, which is basically a free radical. So you will have a lot of loss of the surfactant and again promotes more collapse. So two things at the airway, bronchoconstriction, inflammation, mucus plugging. Down in the alveolus, adsorption atelectasis, surfactant dysfunction. Systemic dysfunctions, you'll see again free radical injury, you will have lipid peroxidation, protein peroxidation, DNA damage. These free radical injury symptoms are classically seen in the respiratory system and the neural tissues. So that will cause more interstitial edema, pulmonary hemorrhage, worsen your gas exchange, worsen your dyspnea and hypoxemia. And in the CNS, it will lead to more and more it can assess hyperexcitability causing seizures, dizziness, and visual disturbances. Okay, so this part of biomedical waste management is, I think I'll stop here and I'll let Dr. Priya take over her session and I'll continue from here in the next session. So this ends physiology and respiratory system. If you feel I was very fast, you need help in any section, particularly with regards to your DO2, VO2 oxygen extraction ratio, please let me know. Dr. Priya?
Hi, I'm there. Yeah. Is it okay for everybody? Are you finding any difficulty? Please let us know. So, shall we continue with GI, gastrointestinal, and hepatology? Okay. So, hope I'm audible.
Yes, ma'am, you are audible.
Yeah. So, these are very important for practicals also. Hepatic encephalopathy, most commonly asked questions. So, we look into first definition. So what's the definition of hepatic encephalopathy? It's a neurological and neuropsychiatric abnormality caused by accumulation of neurotoxic substances. It's not just ammonia. So neurotoxic substances in the bloodstream of patients with liver dysfunction. So what is the mortality rate? It exceeds 50% in the first year. So with liver transplant, it improves survival. So if you do a transplant, the survival is more than 70% in these patients. So what are the potential triggers or precipitating causes? So most common will be infections, can be a GI bleed, constipation, dehydration. Mainly the patient will be on diuretics for the ascites and all that. So diarrhea, vomiting, fluid restriction, excessive paracentesis, not replaced with adequate albumin, electrolyte imbalances like hypokalemia, hyponatremia, alcohol use disorder, benzodiazepines. This is something that can potentiate hepatic encephalopathy and kidney dysfunction, uremia. So these are the triggers of hepatic encephalopathy. So how can you classify? Based on the etiology, it is classified into A, B, and C. A being acute liver failure, B any portosystemic shunt. Okay, without any, some patients can have congenital portosystemic shunts also without any pre-existing liver disease. So that is type B. Type C is cirrhosis or chronic liver disease related. So this is the type of acute hepatic encephalopathy. And the vast heaven grading, they have graded from 0 to, that is minimal, to grade 4. So grade 0 or minimal and grade 1 is considered as covert, whereas grade 2 to grade 4 is overt. Okay, so based on the clinical symptoms, it is classified as minimal if only there is abnormal psychometric test. Grade 1, there is attention deficit, altered sleep pattern, some personality changes, subtle changes. Okay. Grade 2 will be lethargy, apathy, disorientation, personality changes. Grade 3, patient is somnolent, semi-stupor status, responsive to stimuli, grossly disoriented, confused, and bizarre behavior. Grade 4 is patient is in coma or like in stupor. Okay, this is the vast heaven grading. Based on the episodes, okay, episodic is bouts occurring more than 6 months apart, a period of bout and then it subsides, and 6 months later another episode occurs. So that is episodic. Recurrent, the time between the hepatic encephalopathy episodes is less than 6 months. Persistent, when there is persistent behavioral changes that is superimposed on exacerbations. So these are the various types of hepatic encephalopathy. So this is a very complicated slide, but I'll make it simple. So what's the pathophysiology? So when we look into what happens here is in the intestine, we'll come to the intestine. Here there is ammonia production. The colonic bacteria help in producing this ammonia. So this ammonia is kind of metabolized in the liver, brain, muscles. So liver and the periportal hepatocytes, it's converted into urea, whereas in the perivenous hepatocytes, it's converted into glutamine. Even in the muscle, ammonia is converted into glutamine by the glutamine synthase enzyme. Okay, this is a very important enzyme. So what happens in the brain? In the brain, it goes into the astrocyte and glutamate synthase converts ammonia into glutamate and lactate. So this is the normal metabolism. So also kidneys play a role in metabolism. So these are the various organs that play a role in ammonia metabolism. So what happens in cirrhosis? In cirrhosis, there is liver failure, hepatocyte dysfunction, there is portosystemic shunting, there is sarcopenia, so the muscle mass is getting lost. There is electrolyte imbalance, which are potential triggers. There can be precipitating events like GI bleed, infection, and all that. And all these conditions trigger a state of systemic inflammation. Okay, this systemic inflammation is the first thing that you need to remember. So this causes an oxidative stress and increase in the blood-brain barrier permeability, along with ammonia not being adequately metabolized by the liver. So there is inflammation, blood-brain barrier permeability that is kind of worsened, and hyperammonemia. So because of this, the ammonia as well as other free radicals enter into the brain. So ammonia gets in the astrocyte, it is converted into glutamine. So, and also due to cytokines, reactive oxygen species, nitrogen species, lactates, and other neurosteroids, there is astrocyte swelling, which results in cytotoxic brain edema and raise in ICP. And this is the primary pathophysiology of hepatic encephalopathy. Okay, the next theory what is put forth is the GABAergic theory, which means it is not just ammonia, but also there is a modification in the protein. There is some protein modification and the gap junctions, okay, in the brain cells, which is getting modified, as well as microglial activation, and the GABAergic tone is also modified, and NMDA stimulation occurs. Okay, there is excessive stimulation, that is kind of exotoxicity which occurs, which results in death of the brain cells. So this is one of the other mechanisms by which senescence and death happens in the brain cells. Okay. So the other thing is the branch chain amino acids are there should be a balance between the branch chain amino acids and the aromatic amino acids. In cirrhosis, the branch chain amino acids come down and the aromatic amino acids increase. So these aromatic amino acids like tyramine, serotonin, and octopamine, so these act as false neurotransmitters in the brain, which cause, again, excitotoxicity and then senescence and cell death. Okay, so these are the various factors that contribute to hepatic encephalopathy. So it is not just ammonia, but a lot of factors, especially inflammation, free radicals, okay, and there is a GABAergic tone that is modified and NMDA stimulation. So these are the various factors that play a role in hepatic encephalopathy. And ammonia levels, actually more than 100 or 150 are supposed to be very high, and it can result in significant increase in the ICP and brain herniation. Okay. So is there any role of measuring ammonia in this patients? Okay, ammonia has a good negative predictive value. If it is normal, it has a high negative predictive value. If it's more than 120, there is a high risk of ICP, high risk ICP and brain edema. It can result in herniation also. It has a good prognostic value. Okay, if there is no reduction in ammonia with after you initiate the anti-encephalopathy measures, it is not coming down, it has a prognostic value. Okay, so the patient's prognosis is as such going to be poor. But does it follow the severity? Okay, serial measurements, does it have a role? Okay, no, there is no role of kind of serially monitoring the ammonia levels to look in for the severity of encephalopathy. Okay, and advanced degrees of in advanced degrees of hepatic encephalopathy, you need to understand. So we spoke about other factors in addition to ammonia. So those factors are also important. So it is not just ammonia, other factors also play a role. So measuring ammonia is also need to be done appropriately. For example, if there is a time delay between the sampling and measurement, so that will have an impact of ammonia measurement. So tourniquet, which is tied, fist clenching, so all those things, and sample processing, so all those things can give you a falsely elevated ammonia levels. So you need to be very careful when you're doing the sampling as well. Okay, ammonia cutoff, that is the prognostic value, a cutoff of more than 80 is associated with a high risk of death. Okay, it is considered as one of the biomarkers. So how do you approach a patient with hepatic encephalopathy? First, look into any patient with liver failure, has some neurological signs, looking for focal deficits. It could be a bleed also. So patient is coagulopathic. If the patient has seizures, focal neurological deficit, get a brain imaging to rule out a bleed. Okay. Then make sure all of the precipitating factors are being addressed, like electrolyte abnormalities, GI bleed, infections, and any new benzodiazepines or sedatives that has been added, make sure all of those are kind of discontinued. Okay, and the CT can also show cerebral edema. Okay, if you're doing an MRI, okay, and normally we don't do MRI in an unstable patient, but then MRI findings would be hyperintensities and globus pallidus, that is pointing towards a metabolic encephalopathy. EEG will show triphasic waves, okay, in grade 1 to 2. And beyond 2, in grade 4, it will be slow progressing. So in the as per the Vast-Haven grading, up to 3 grades, there will be a triphasic pattern. 1, 2, and 3, there will be triphasic pattern. And grade 4, when the patient is in stupor or in coma, there will be progressive slowing of the rhythm. And also do other diagnostic tests to rule out infections like paracentesis, drug screening. And in patients with chronic liver disease, start lactulose, rifaximin, okay, rifaximin, and looking for if there is a recurrence and if the patient is not improving, looking for any shunts, actually, there could be some portosystemic shunts that could be the reason for hyperammonemia. So consider embolization of the shunts as well. Last would be liver transplant. So in a CLD patient, so correct the etiology and manage with lactulose rifaximin. In ALF, in a patient with acute liver failure, you try to reduce the ICP. So we have already looked into these things: head up, intubation, then osmotic therapy, mannitol, and neuroprotective measures. So what are the osmotic laxatives do? So lactulose is a laxative. So how does it act? It is a non-adsorbable disaccharide. So it has a negligible impact on the gut microbiota, but it increases the intestinal transit. So what happens is that lactate, it gets converted into lactylol and lactate, and it acidifies the bowel milieu. So because of the acidification, NH3 is converted into ammonium ion, NH4. So this ammonium ion will not be absorbed in the gut. So thereby it decreases the absorption of ammonia, as well as by increasing the intestinal transit, the formation of ammonia will also come down. But what will be the disadvantages? Disadvantages being diarrhea, vomiting can lead to electrolyte imbalances. The dose of lactulose is 15 to 20 ml BD. So you have to titrate it to the amount of stools the patient passes. The target would be to at least 3 times a day. Okay, what is the difference or comparing lactulose with polyethylene glycol? So in an RCT, it has been found that polyethylene glycol improved overall grade of hepatic encephalopathy after 24 hours, but reduced days to hepatic encephalopathy resolution and shorter hospital stay. So the polyethylene glycol is supposed to be more beneficial. So antimicrobial agents like rifaximin. So rifaximin is a semi-synthetic non-aminoglycoside which acts on the gut enteric bacteria. So it binds to the DNA-dependent RNA polymerase, inhibiting the bacterial RNA. So it is administered orally for 400 or 550 BD to thrice a day. So minimal absorption. So it acts intraluminally. So the risk of bacterial resistance is low. A combination of lactulose and rifaximin was more effective than lactulose alone in the improvement of hepatic encephalopathy. It reduces the hospital stay, reduces the mortality, and also which was due to sepsis-related deaths. Okay. Is there any role of probiotics? Probiotics are live bacteria which are believed to improve the gut dysbiosis and negatively impact the ammonia production. So is there any role? As per the studies, a little effect on mortality. It has some effects in ammonia lowering. Current recommendation may lead to improvements, but definitely not one of the proven treatment for hepatic encephalopathy. Okay, branch chain amino acid. How does this help? Okay, a Cochrane review suggested that the manifestation of overt hepatic encephalopathy improved, but there's no effect on mortality. So how does this act? Okay, it acts in the brain and muscle. In the brain, it competes with aromatic amino acids. So it prevents the negative effects of the aromatic amino acid, which act as false neurotransmitters. In the muscle, what happens is that it promotes muscle protein synthesis and thereby helps the muscle to metabolize the ammonia. So the alternative mechanism of ammonia metabolism will improve. So L-ornithine, L-aspartate, LOLA. So how does this improve? So meta-analysis compares LOLA with placebo suggested that it improved overt hepatic encephalopathy. So it stimulates the urea cycle in the liver. So aspartate provides nitrogen for the urea. So it helps in the metabolism. As well as in the muscle, it increases glutamine production. So it acts in the muscles as well as in the as well as in the liver, and it has some effect in the kidneys as well. So next option would be, in case if there are portosystemic shunts that are detected, either a contrast CT or a MR abdomen will help in detecting the shunts. So in recurrent episodes, wherein especially when the encephalopathy is disproportionate to the liver dysfunction, we need to think of these portosystemic shunts. Especially patients might have some type B encephalopathy. We saw type A, B, and C, wherein A is acute liver failure, B is due to portosystemic shunts. So in this scenario, we'll have to look in for, in recurrent cases, we need to look in for portosystemic shunts. And if the shunts are very large, we should think of embolizing these shunts. So clinical trial data and many case reports and case series, okay, not large RCTs. So these have shown that embolizing these shunts can elevate the hepatic encephalopathy, particularly in patients with MEL less than 11. Other thing would be volume expansion with saline over 1 hour to reduce ammonia. So this is something that can be done, but not beneficial on a long-term basis. Hemofiltration, that is CRRT, can be done to decrease the ammonia levels, but it can reoccur. So albumin and extracorporeal albumin dialysis. How does albumin help? Albumin acts as a plasma volume expander. It has anti-inflammatory properties. It has the ability to bind to many toxic substances like bile acids and many other reactive oxygen species, nitrates, and it can act as an antioxidant also. So lactulose and ammonia more effective than lactulose alone. Okay. So what does the study say? 2 RCTs in patients with cirrhosis showed faster reduction in the severity of hepatic encephalopathy. So, but ultimately, no survival benefits. Okay, whatever strategies we have looked into, rifaximin, lactulose, embolization of the shunts have a definitive role. So there has been questions on newer drugs for hepatic encephalopathy. So this is something that we can look into. So polyethylene glycol. So compared to lactulose, it improves hepatic encephalopathy. Flumazenil is a benzodiazepine antagonist. It's known to improve the symptoms, but the effects are transient and it does not affect mortality. So after the effect of flumazenil comes down, the patient will again go into a phase of encephalopathy. Zinc, because cirrhotic patients have long-term zinc deficiencies, zinc supplement has been tried in recurrent encephalopathy, hepatic encephalopathy, but it has not shown any consistent improvement. Sodium benzoate. Okay, this is something that increases the urinary excretion of ammonia by converting into hippurate. Okay, the dose is 5 gram twice daily. So it's comparable to lactulose in one double-blinded control trial. So there is some evidence for sodium benzoate. Closure of large positosystemic shunts that we looked into. L-carnitine. So this has some animal data, not still tried in human. NMDA receptor antagonist. So we looked into one of the mechanisms is NMDA activation. So thinking of an antagonist, that is memantine. So it has some role, but still human studies are lacking. Other things, serotonin antagonists, opioid antagonists, probiotics, fecal microbiota transplant. So these are something that are more into futuristic. So newer drugs, other drugs would be sodium phenyl barbiturates. So these are for patients with genetic urea cycle disorders. According to the randomized control studies, they have found to lower ammonia levels, reduce hepatic encephalopathy and hospitalizations. Liposome supported peritoneal dialysis. There has been evidence for this liposomes, which helped in detoxification. So these bind with the ammonia. So when this peritoneal dialysis is done with the micrometeorized liposomes, they bind to ammonia and then they neutralize it, and it helps in removal of the ammonia. So this has some effect in ammonia lowering effect, and then attenuating brain edema compared to conventional peritoneal dialysis. Combination of L-ornithine and phenyl acetate. So it increases the muscle ammonia detoxification by stimulation of enzyme, this glutamine synthase. Okay, so other things would be glutamine synthase replacement. Okay, this enzyme replacement, there has been recombinant glutamine synthase AM553. So this is also being newly studied. So this has a role in conversion of this has a role in the metabolism of ammonia, especially in liver and the muscles. Other is GABA receptor modulating steroid antagonist, the GAMSA. So this one, the AS100 is the molecule that has been studied. So this has increased GABAergic tone potentiated by neurosteroids, with which will contribute to neuroinhibition. So it has a role in mitigating the hepatic encephalopathy. So that is about hepatic encephalopathy and newer drugs. Next, we'll go into another important topic in practical aspect as well. That is chronic liver disease. So chronic liver disease is an acute hepatic insult manifestation in jaundice and bilirubin more than 5 milligrams and coagulopathy, complicated within 4 weeks by clinical ascites or encephalopathy in a patient who is previously diagnosed or undiagnosed with chronic liver disease or cirrhosis. Just to break this definition, so there is a hepatic insult and the patient has a jaundice and bilirubin elevation and coagulopathy, or coagulopathy defined by INR more than 1.5 or a prothrombin activity. So there is an insult, there is a effect in the liver. So within 4 weeks, it is complicated by ascites and encephalopathy. This is where we term as acute on chronic liver failure. Okay. So how does this happen? So any patient who has a baseline cirrhosis, what happens is that any insult results in inflammation in the liver cells, thereby resulting in fibrosis. There is nodular regeneration, which is happening, ultimately resulting in hepatic vasculature being kind of affected due to there is increased resistance in the hepatic blood flow. So as the portal blood resistance to the portal blood flow increases, there is portal hypertension. So when there is a trigger by an infection or by alcohol, what happens is that there is inflammation in the liver, as well as systemic inflammation caused by the damage associated molecular proteins or the pathogen associated molecular proteins due to TLR activation. So this results in circulatory dysfunction and multi-organ failure. So this is how the patient, primarily having a liver disease, decompensates and ends into multi-organ failure. So when we look into what are the different phases or a patient can present to us, a normal liver after an acute insult can end up in an acute liver failure, which can recompensate or end up in a liver transplant, or it can finally end up in a fulminant liver failure. Whereas in chronic liver disease, okay, in chronic liver disease and cirrhosis, if there is a acute insult, what happens? A patient might be having, without any fibrosis, a chronic liver disease with the synthetic functions of the liver being affected. So that is CLD. So in this patient, wherein an acute insult happens, the patient might have jaundice, which is progressing to ascites or encephalopathy within 4 weeks. So that is known as acute on chronic liver failure. A compensated cirrhosis, that is, a patient has fibrosis, portal hypertension, then after an acute insult decompensates that into GI bleed, encephalopathy, ascites, HRS, or a combination of any of these, okay? And this, after the first insult, either the patient can recompensate or end up in a completely decompensated cirrhosis. Okay, a decompensated cirrhosis, again an insult, the patient can finally worsen. How can you actually classify, or how can you stratify these patients? There is two classification. One is the CLIF score, CLIF C organ function score, which is the chronic liver failure consortium organ failure score, and the AARC, that is the Asia Pacific Research Consortium acute and chronic liver failure. So these are the two scoring systems that you need to remember. So the definitions, when we look into, there are various societies which has put forward various definitions, but we need to know at least these three. Okay, there is also a Chinese definition, but the East Asian, Asia Pacific, North American Consortium. So these are the three definitions we need to remember when coming to acute or chronic liver failure. So when we consider the uh, um, European here, they define acute on chronic liver failure as acute worsening of a pre-existing liver failure triggered by an event leading to 4-week increased mortality, the bilirubin concentration being more than 12, and extrahepatic failures. Okay, there are 6 organ failures that have been defined. That is creatinine more than 2, needing dial, or any creatinine value wherein the patient is on dialysis, hepatic encephalopathy grade 3 or 4, patient on vasopressors, respiratory with the PF ratio less than 200, and patient on mechanical ventilation. The primary etiology wherein these patients being classified are alcohol related or bacterial infections, and the Europeans have put forth the CLIF SOPA. So this classification is from the European guidelines. The Asia Pacific mentions acute on liver failure as jaundice and hemostat, that is coagulopathy, within 4 weeks, okay, and resulting in ascites and encephalopathy. So here the bilirubin is more than 5, INR is 1.5. So the Asia Pacific is mainly liver centric in the sense mainly it considers the liver derangement, the bilirubin more than 5 and INR 1.5 and prothrombin activity as the main factor. The secondary factors, so these are considered as additional factors, whereas European and North American consider the extrahepatic as the factors of decompensation of acute liver failure itself. So other here, there are 4 organ systems that are being considered. Primary viral infections are being considered in this acute insult. Okay, the North American, here they have considered the chronic liver disease with or without cirrhosis, and the mortality which has been described is in 3 months if left untreated. Okay, the organ systems being a patient on dialysis, grade 3 or 4 encephalopathy, circulatory dysfunction, patient on mechanical ventilation, primary bacterial infection is the type of insult, and this is within 3 months. Next, going to the classification. So we looked into the grades. So the ACLF, this is the grading system. So this is the chronic liver failure consortium organ failure score. So based on this, so they have looked into 6 organ dysfunction, and they have allotted a score of 1, 2, and 3. So the bilirubin less than 6, 6 to 12 or more than 12, coagulopathy 2, 2.5 and more than 2, creatinine value 2, 2 to 3.5 and 3.5 or renal replacement therapy, and encephalopathy grade 0, 1 to 2 and 3 to 4, circulation, use of vasopressors with the MAP less than 70, and respiratory PF ratios more than 300, 300 to 200 or less than 200. Okay, or a SpO2 FiO2 ratio. So these are the various organ systems that they have looked into, and based on how much involvement is there. So no ACLF is no organ failure, or single non-kidney organ failure, wherein they have considered creatinine less than 1.5 as normal and no hepatic encephalopathy. Grade 1 is a single renal failure or single non-kidney organ failure. Okay, grade 2 is 2 organ failures. Grade 3 is 3 or more organ failures. Okay, so there is something called as a acute on chronic liver failure and acute decompensation. So what is the difference between these two? Acute decompensation is always considered in a patient, or like in a patient with underlying cirrhosis. Okay, acute on chronic liver failure, it can be a CLD or a cirrhotic patient. And here the time from insult to presentation is considered is within 4 weeks, whereas here in acute decompensation, it is considered up to 12 weeks. Okay, what is the importance is that reversal of recovery is uncommon in these patients with acute decompensation, whereas half of these patients with the acute and chronic liver failure can recover. Okay, so what will be the changes? What is the effect on these organ systems? We looked into, there will be a decrease in the mean arterial pressure. So early goals of therapy should be maintaining the volume status of the patient, maintaining the MAP, giving albumin. So that is important. Coagulopathy, if the patient is coagulopathic with the hypofibrinogenemia, thrombocytopenia, or if there is a factor deficiency, you need to kind of replace if the patient is bleeding. Neuro-wise hepatic encephalopathy, we looked into the management. Gastrointestinal bleeding can happen. So ulcer prophylaxis, if the patient is coagulopathic, lung risk of aspiration, if the patient is encephalopathic, lung protective ventilation, if the GCS is low or if the PF ratios are low. Kidney-wise, patient can have a hepatorenal syndrome. Okay, so in hepatorenal syndrome, we look in detail about hepatorenal syndrome. Infections because of complement deficiency, immunofluorescence, patients are at a risk of 5 common infections in CLD patients is what they say. One is community-acquired urosepsis, skin and soft tissue infections, spontaneous bacterial peritonitis, and infective endocarditis. So these are the 5 most common infections in any patient with chronic liver disease. So there is always a pace of continuous inflammation, destruction, and regeneration, which is happening. So when we look into the etiology, so the precipitating factors is what we initially talked about. That is the acute insult. Acute insult can be alcohol by itself. So alcohol leads to cirrhosis, different stages, steatosis followed by fatty liver, and then hepatitis, and then alcoholic liver disease. Non-alcoholic fatty liver disease is something that is related to hyperlipidemia, obesity, diabetes, and steatohepatitis. Chronic viral infections can be HBV reactivation, which is supposed to be very, very common in the Western population, as well as chronic hepatitis C, D, Epstein-Barr virus, cytomegalovirus, herpes simplex, influenza, leishmaniasis. So these are the other important infections which can result in acute and chronic liver failure. So other causes would be alpha-1 antitrypsin deficiency, hemochromatosis, that is due to high ferritin deposition and hemosiderosis that can result in organ fibrosis. Wilson's, where there is copper accumulation, which will result in liver failure, autoimmune diseases due to autoimmune antibodies, primary biliary cirrhosis. This is due to destruction of the intrahepatic biliary channels and portal inflammation and scarring. Okay, this primarily affects the portal inflammation. Next is primary sclerosing cholangitis, wherein there is a decrease in the size of the intra and extrahepatic bile ducts due to inflammation and fibrosis. Okay, so autoimmune causes we have already seen. We'll have to evaluate for the autoimmune antibodies, anti-LKM antibodies, and smooth muscle antibodies. Also look into hypergammaglobulinemia. Drugs, amiodarone, isoniazid, methotrexate, any alternative medications, phenytoin, nitrofurantoin. So Budd-Chiari is another important, idiopathic being the last cause. So these are the inciting factors or the etiological factors or cause of acute insult to the liver. So looking into the pathophysiology. So what happens is there is cirrhosis, that is fibrosis, resulting in increased portal pressure, portal hypertension. So what happens with portal hypertension? There is mucosal edema in the gut. There can be increased translocation of the bacteria, resulting in increase in the DAMPs and PAMPs. And there is a cascade of inflammation that happens, increase in the free oxygen radicals and nitrates, resulting in splanchnic vasodilatation. So when there is splanchnic vasodilatation, what happens is that there is a low volume status. There is a hyperdynamic circulation which is going on. There can be decreased perfusion to the organs, okay, in the kidneys. There is, because of the free radicals, there can be capillary dilatation in the lungs as well, which results in hepatopulmonary syndrome. Okay, and hepatic encephalopathy because of multiple neurotoxins and ammonia. There can be adrenal dysfunction. So this is the pathophysiology of decompensated cirrhosis. And when we are classifying this clinical course of cirrhosis as compensated and decompensated, there are 5 stages that are being described. Stage 0 is when there is no varices and mild portal hypertension. Mild portal hypertension is defined by the liver, the score, liver stiffness score that is more than 15. That is the more than 15 but less than 20, and the hepatic venous portal gradient, the normal hepatic venous pressure is less than 5. So if it is more than, the gradient is more than 5 to 10, it's kind of normal. If it's more than 10, it's abnormal. So grade 0 is almost normal. And in grade 1, no varices, and the hepatic vein portal venous gradient is more than 10. So this is something that is clinically significant. Grade 1 is clinically significant portal hypertension, but no varices. Grade 2 is when the varices happen and there is clinically significant portal hypertension. So this is a state of compensation. 0, 1, 2 is stage of compensation, whereas decompensated when the patient starts bleeding. Okay, stage 3 is when the patient starts bleeding. First bleeding with the first non-bleeding decompensation, second decompensating agent. So these are the different stage. Stage 6 is late decompensation, ascites, jaundice, infection, and other issues develop, and the patient finally goes into a state of non-recovery. So these are the various clinical course of cirrhosis that we have looked into. And complications, the most important when we are talking about ACLF, we'll have to mention the grades, pathophysiology, triggers, and then most important being the complications. 4 most important complications: ascites, hepatic encephalopathy, GI bleed, and HRS. So we looked into encephalopathy. Now we look into ascites, HRS, and later bleed. Other complications that can happen is hyponatremia, hepatic hydrothorax, relative adrenal insufficiency, hepatopulmonary syndrome, and cardiac cirrhosis, cirrhotic cardiomyopathy, and portopulmonary hypertension. So a small word on this hepatopulmonary syndrome and portopulmonary hypertension. Hepatopulmonary syndrome is due to a shunt which is developing in the lungs due to the capillary vasodilatation. Okay, this can be identified by bubble echo study. Okay, the treatment for this, there is no proven treatment for this. Oxygen supplementation to the patient ultimate would be a liver transplant. Portopulmonary hypertension. The main pathophysiology in portopulmonary hypertension is that there is an increase in the vascular resistance in the lungs. So because of the increase in the vascular resistance, the pulmonary pressure goes up. So this can be treated with some measures like bosentan, endothelial receptor antagonist. So all those things can be sort of beneficial, but ultimately liver transplant would be the final therapy for this. So next we'll first looking into management. We'll have to mention that the primary etiology of decompensation, that is the precipitating factor, is something that you need to attend to. So correct the etiological factors and some of the factors that affect in pathogenesis of cirrhosis, like for example, patients who develop fibrosis further going into portal hypertension, non-selective beta blockers have been studies. So carvedilol is something that can be given to patients even prior to decompensation. So this decreases the portal hypertension. So carvedilol started at 6.25 and titrated even up to 12. So based on the patient's tolerance, based on the systolic blood pressure, that can actually be titrated. So this increases the nitric oxide. And carvedilol increases the nitric oxide and it decreases the portal pressures as well. So that's supposed to be beneficial. Long-term prophylaxis, actually some patients will be put on lactulose, rifaximin on a long-term basis as well. So those are kind of factors that can be done even prior to decompensation. So when the patient presents with the ascites, even if so all patients with grade 2 or grade 3, grade 2 is nothing but moderate ascites, grade 3 is tense ascites. So you need to do a diagnostic parasynthesis and look in for the cell count and proteins. So the neutrophil count is very important, and neutrophil count of more than 250 cells denotes SBP, and the protein ratio, you'll have to calculate the SAG. A high SAG denotes nothing but cirrhosis. It denotes there is a increased risk of translocation of bacteria from the gut into the blood. So a high SAG means there is an increased risk of translocation. Okay. And moderate restriction of fluids should be done, and salt restriction is also recommended in patients with ascites. In case of refractory ascites, how do we treat? Refractory ascites causing some problem to the patient, like breathing difficulty, or if the patient can become because of there can be IVC compression. So tense ascites, large volume paracentesis, always replace the volume with albumin. Okay, 8 grams per liter of the ascitic fluid removed. So that is something that can be done. So diuretics also remain a mainstay of treatment. So what is diuretic resistance and diuretic intractable? So diuretic resistance is, even though you are giving diuretics, the patient develops ascites or it does not come down. So that is diuretic resistant. Diuretic intractable means the patient does not tolerate the diuretic because of complications of the diuretics as such. So the patient can be either resistant or intractable to diuretics. So that is one of the cause for refractory ascites. Other then always, if there is a refractory ascites, do a large volume parasynthesis, replacing it by albumin. Ultimate treatment would be TIPS and then liver transplant. So how do you approach? So we looked into treating the precipitating factors, preventing decompensation, some of the medications that can prevent decompensation. And if the patient has gone into a stage of ACLF with extrahepatic manifestation, we looked into what are the extrahepatic manifestations that can happen. So how will you kind of treat it? So brain encephalopathy, lactulose, rifaximin, CRRT, extracorporeal albumin dialysis in case of refractory encephalopathy. So this is related to the brain. Pulmonary, you have to screen for infections because the chances of infections are very high in these patients. Hepatopulmonary syndrome and portopulmonary hypertension that we already saw. Coagulopathy, if the patient has has a low coagulation factors or derange, if the patient is in coagulopathy, then if there is any invasive procedure, then you have to transfuse, or if the patient has bleeding manifestations, then transfuse. And if the patient does not have any coagulation abnormality, consider DVT prophylaxis. Okay, circulation. Ideally, we need to manage with adequate volume replacement in these patients because there is splanchnic vasodilatation, and but there is a tendency for these patients to develop hyponatremia as well. So you need to kind of personalize the goals of fluid management in these patients. Acute kidney injury, HRS will be looking at this. CRRT, albumin terlipressin, and then refractory, going for CRRT. RRT. Then liver specific, there's no definitive treatment in terms of liver, only in case if you're planning for a transplant, artificial or artificial extracorporeal liver support, plasma exchange, there are ongoing therapies. Okay. So how will you stratify these patients having acute on chronic liver failure? So in ALF, we looked into the King's college criteria for prognostication, and you defined your patients who need a transplant or who need a transplant. So in this, you look into the ACLF grade. Okay, MELD has been initially been used. The MELD more than 30 subgroup improved survival. Now we are looking more in terms of the ACLF grades. Okay, ACLF grade 2 and 3. So if the grade is high, like if the grade is 3 and there is a contraindication to liver transplant, what are the contraindication to liver transplant? If the grade is very, very high, so they look into the CLIF-C ACLF score that is more than 64 or 70 at 3 to 5 days. So the patient has come into you, you have initiated treatment, and you're looking into the score at 3 to 7 days. Between these days, you look into the score. If the score is very high, more than 60 or 64 or 70, and there are more than 4 extrahepatic organ involvement, then it is one of the contraindication for liver transplant. Other contraindication, poor neurological status, for example, brain dead or vegetative state, that is one. Age more than 60, any other malignancy in the patient. So these are other contraindications. So if the patient has those contraindications, discuss about palliative care to the patient's family. Okay. So that is on ACLF grade 3 with contraindication. So some patients with a low grade 0 to 1 who can improve with the supportive care and appropriate reduction in the triggers or treatment of the precipitating cause. So they can improve. So this is low grade. Patients with persistent ACLF grade 2 to 3 in the absence of contraindication to liver transplant. So in these patients, you will have to categorize them. If they are considerably suitable for transplant, go ahead with a transplant especially within the window. So proceed with the urgent liver transplant, and in scenario when the patient is very sick, postpone liver transplant, reassess and discuss regarding palliative care. So regarding some of the studies related to liver transplant, the canonic study. So in patients with ACLF, grade 3, early liver transplant improved survival. mostly 20% of the patients. So this is one important study. So regarding other liver support system, Mars and Prometheus, so Helios and Relief is some recent study which showed there is no benefit of these liver support systems. And there is an ongoing trial on plasma exchange as well. This is the Apache trial. So these are the important trials related to the extracorporeal supports in and liver transplant in patients on ACLF. So that will be the ultimate management of patients with ACLF. So other complications. So spontaneous bacterial peritonitis. So how can you define spontaneous bacterial peritonitis? It's bacterial infection of the ascitic fluid without any intra-abdominal surgically treatable source of infection. That is, there is no bowel perforation. Okay, there's no other surgically treatable cause like a abscess or any other thing. It's a without any kind of pathology, just because of the bacterial translocation from the gut to the blood, to the peritoneal fluid, the patient has developed the bacterial peritonitis. The incidence being 3.5% in outpatients and 10% in hospitalized patients. The mortality exceeds 90%. Okay, and with appropriate treatment, it can be reduced to up to 20%. So what will be the clinical features? The classical triad will be fever, abdominal pain, increasing ascites. Okay. So other local symptoms would be peritonitis, vomiting, diarrhea, ileus, and systemic features, fever, chills, altermentation, then white cell counts, tachycardia, tachypnea. So those are other symptoms. Complications, worsening of liver function, hepatic encephalopathy, renal failure, GI bleed, and shock. So how will you diagnose? Perform a diagnostic parasynthesis, send it for cultures, and also send for blood cultures. So when you look into the diagnosis, you look into the cell count and the protein. So if the neutrophil count in the ascitic fluid is more than 250 per cubic millimeter, so it is diagnostic of spontaneous bacterial peritonitis. If the neutrophil count is less than 250, but the gram stain is showing a positive bacteria or the culture is showing a positivity with signs of systemic infection and inflammation, you treat it as bactericidis. Okay, the cell count is less, but still there is bacterial infection in the, so in that scenario also you go ahead and treat with antibiotics. A serum ascitic fluid albumin gradient is consistent with portal hypertension. A more than 1.4 denotes increased risk of infection. Okay, a protein less than 1 also denotes increased risk of spontaneous bacterial peritonitis. So how does this happen? So due to increased systemic portosystemic hypertension, there is mucosal edema of the bubble wall. So because of the bubble wall edema, it increases transmural migration of the enteric organisms into the ascitic fluid. Also, because the liver function is impaired, there is in fact phagocytic function. Okay, and impaired immunological activity as well. Okay, the complement levels will be low. There is immunopheresis. The phagocytic action will be low. So this is the important cause of spontaneous bacterial peritonitis. So secondary bacterial, when should you suspect secondary bacterial peritonitis? For example, you have done a ascitic tapping sent and the cell counts are more than 10,000. Okay, so that is something very, very high, a very high ascitic neutrophil count, and your gram stain shows multiple organisms. Okay, or a culture report which shows polymicrobial growth. Okay, that denotes there is some perforation in the gut. So definitely that indicates a secondary bacterial peritonitis and a high ascitic protein concentration. So these are the findings. LDH will be high, low glucose concentration, elevated protein. So these are the findings in secondary bacterial peritonitis. If you are suspecting a secondary bacterial peritonitis, immediately shift the patient for a CT scan and consider early surgery if you diagnosed a bowel perforation. Okay. So we have looked into this. Any patient presenting with ascites, do a diagnostic tapping. Diagnostic tapping, looking for looking for the neutrophil count. If the neutrophil count is normal, if the neutrophil count is more than 250, you start the patient on an empiric antibiotic. So what will be the antibiotic that you will consider? Normally, third generation cephalosporins have been recommended. But due to if the prevalence of MDR bacteria is very high, think of piperacillin tazobactam. If there is a high prevalence of ESBL, or if your culture turns out to be positive for ESBL, then think of carbapenem. So for gram-positive cover, glycopeptides, daptomycin, and linezolid should also can also be added. Okay, so most commonly it will be E. coli or enterococcus. Always think of E. coli and enterococcus in patients with spontaneous bacterial peritonitis. So if the patient you started antibiotics, also along with antibiotics, consider albumin, because these patients are at high risk of acute kidney injury or HRS. So you need to consider expanding the plasma volume by supplementing with albumin. Albumin should be given at 1 gram per kg per day, then up to 3 days. Okay. So and after your final culture reports, you narrow down your spectrum. So if the cells are negative, if the cells are less than 250, then do you treat with antibiotic? No. If the patient has some signs and symptoms, the patient has tenderness in the abdomen, vomiting, and features of sepsis, I mean, features suggestive of some infection, then you start on empiric antibiotic therapy and looking for the final culture report. Sometimes the cell count can be low, but the culture can turn out to be positive. In that scenario, it is known as bacteriocytis. And you treat the patient and then repeat the diagnostic paracentesis when the patient has kind of recovered. Most of the patients, so why do you give albumin? To prevent acute kidney injury. Why? The incidence of acute kidney injury is 40% in the patients who have SBP. So we had a look at the spontaneous bacterial peritonitis. The next important topic or complication of acute and chronic liver failure is hepatorenal syndrome. So what is hepatorenal syndrome? So it's a serious complication of end-stage cirrhosis and portal hypertension, which is characterized by increased planktonic blood flow, a state of decreased central volume, and decreased GFR. So we look at the pathophysiology or hallmark of HRS. So why does this happen? So in advanced cirrhosis, there is portal hypertension. Because of portal hypertension, there is vasodilators that are being released. That is nitric oxide, prostaglandins, endocannabinoids. So all these are being released. This results in splanchnic arterial vasodilatation. So this decreases the SVR. So there is a hyperdynamic circulation which happens, and the effective arteriolar volume comes down. There is hypovolemia. Because of hypovolemia, what happens is that there is activation of the other systems like renin, angiotensin, aldosterone system, and sympathetic nervous system, and arginine AVP also. Okay, so all these things get activated, and this acts on the kidney. So the main action of all these things would result in renal vasoconstriction. Okay, if it results in renal vasoconstriction, ultimately the renal perfusion goes low and the GFR also goes low. So this results in acute kidney injury. Also, along with this, there can be other systems which can be contributory. Because of cirrhotic cardiomyopathy, the cardiac output can come down, which will also result in effective arteriolar hypovolemia. There is increased bacterial translocation, increase in the PAMs and DAMs, which will also stimulate an inflammatory response. And there can be endotoxins, cytokines, and tumor necrosis factors, so interleukins, everything causing a high inflammatory state leading to vasodilatation. So all these factors will ultimately contribute to renal vasoconstriction and decreased GFR. So this is the pathophysiology of HRS. So traditional classification, if we look into old classification, it has been classified into HRS type 1, 2, 3, and 4. So this is based on the time course and precipitating factors. So type 1 is rapidly progressive acute renal failure. Type 2 is subacute. Type 3 is 1 or 2 superimposed on CKD. Okay, type 4 is fulminant liver failure. So the current classification, what we follow is HRS AKI and HRS NAKI. So in this factor ultimately denotes that, so you have cirrhosis with ascites and you rule out all other factors that can cause acute kidney injury, and you have the definition of acute kidney injury. So this is HRS AKI. So you have cirrhosis with ascites and you have the definition or the criteria fitting into acute kidney injury, that is increase in creatinine more than 0.3 milligrams per deciliter in 48 hours or more than 50% increase in the last 3 months. So this followed by you rule out other causes. So after no response, after volume expansion, withholding diuretics, and volume expansion with albumin, that is 1 gram per kg per day for 48 hours, and then withholding diuretics as well, absence of shock, no current or recent use of nephrotoxic agents like NSAIDs, and absence of parenchymal kidney disease, like there's no proteinuria, no hematuria, proteinuria defined by more than 500 milligrams per deciliter, and no hematuria more than 50 RBCs per high power field, normal kidney ultrasound. There's no structural abnormality in the kidney also. So you rule out other causes, and we don't have any established cause after you have improved the volume status also. That is HRS AKI. So what is NAKI? So AKD and CKD. So acute kidney disease is when your creatinine increases to less than 50% in the 3 months. This is more than 50%. So this is less than 50% and still your GFR is less than 60. No other cause of kidney disease similar to this, and cirrhosis, patient has cirrhosis with ascites. HRS CKD is patient, this is actually mandatory criteria. Cirrhosis with ascites should be there. GFR is less than 60 and no other cause. This is more than 3 months. So this is the criteria for hepatorenal syndrome, and you defined the stages of kidney injury by 1, 2, and 3. 1, more than 0.3 milligram per deciliter increase in the serum creatinine, or 1.5 times increase. Twofold 2 to 3 increase is stage 2, and stage 3 is more than 4 or an increase or initiation of RRT. So based on your criteria, you have to stage it as 1, 2, and 3. So what are the risk factors? Risk factors being, we saw SBP is one of the most important. Other infections also, any infection, okay? So any systemic infections can be one of the reasons. Large volume paracentesis, more than 5 liter without adequate albumin substitution is an important cause. Bleeding from esophageal varices, post tips, any diuretics, NSAIDs, IV contrast can precipitate a acute kidney injury. So main treatment would be avoid nephrotoxic agents, avoid nephrotoxins, diuretics, use 20% albumin during large volume paracentesis. So based on the stage, okay, aka 1, 2, and 3. So 1, usually you discontinue all the nephrotoxic agents, any vasodilators like the patient will be on beta blockers. So stop that as well. NSAIDs, diuretics, all those things you stop, and plasma volume expansion. Then observe the patient. There can be resolution. If there's no resolution, the patient can progress to stage 1B, 2, or 3. So in this situation, you consider albumin 1 gram per kg for 2 days and see if there is resolution. Yes, if there's no resolution, then consider vasoconstrictor therapy like terlipressin. And then if the patient meets the criteria for renal replacement therapy, consider RRT. So the dose of albumin is 1 gram per kg for the first 2 days, and then followed by 20 to 40 grams IV OD after 2 days. So how does albumin helps? It improves the intravascular volume. It also acts as an antioxidant and anti-inflammatory action. It mitigates the inflammatory state. Okay, it also binds to many of the substances like bacterial products, bile acids, cytokines, nitric oxide, endotoxins. So it has a ability to bind and kind of improve the kidney functions. So other thing is terlipressin. So terlipressin is a vasopressin analog which acts on V1A vasopressin 1A receptor. It primarily acts as a splanchnic vasoconstrictor. So the dose is starting from 0.5 to 1 milligram every 4 to 6 hourly. Dose can be increased to 2 milligram every 4th hourly. Non-response to treatment is defined by less than 25% reduction in the creatinine level after 3 days and no side effects occur. Okay, so this is defined as a non-response to terlipressin. So if there is a non-response after 3 days, there's no point in continuing terlipressin. So the side effects of terlipressin, very important side effect being ischemia. Patient can have intestinal ischemia. Digital ischemia is something that we have commonly seen. Peripheral vascular disease, coronary artery disease. You'll have to take an ECGs at least every day or every alternative day in patients who are on terlipressin. Respiratory failure, very common finding would be diarrhea and abdominal pain. Okay, so this is about terlipressin. Next vasoconstrictor that we can consider is norepinephrine. It acts through the alpha-1 adrenergic receptors on the smooth vascular smooth muscles. Dose being 0.5 to 3 milligram per hour. Continuous infusion should be continued. So other drugs which can be used are midodrine, which is also an alpha-adrenergic agonist, and octreotide, which is a somatostatin analog. Midodrine doses are 7.5 milligram up to 12.5 milligram 3 times a day. So maximum can be titrated to achieve an increase in the mean arterial pressure of 15 millimeters of mercury. Octreotide 100 to 200 micrograms subcutaneously every 8 hours. So if the patient does not respond and goes into a progressive renal failure resulting in volume overload, uremia, and electrolyte imbalances, consider RRT. So it is also a bridge to transplant. So CRRT, the mode of RRT, CRRT in patients with who are hemodynamically unstable and who have increased intracranial pressure. So in that scenario, you have to consider continuous renal replacement therapy. Okay, and Mars is something that can also be tried, but there are no quality evidence supporting use of molecular absorbent recirculating systems. So tips could improve kidney function by improving the serum creatinine, sodium, and urine output. And it could actually potentiate precipitate encephalopathy as well as hepatic failure. Okay, there is an ongoing trial, liver hero trial, wherein HRS-AKA patient treatment with TIPS, it compares the efficacy of transplant, safety of TIPS implant and the conventional therapy, terlipressin and albumin. So this is an ongoing trial. So liver transplant remains the definitive treatment for HRS. Okay, in patients with HRS, how will you decide whether the patient needs only liver transplant or simultaneous kidney liver transplant? So this decision has to be made. So this is based on this guidelines, the European guidelines. There are various guidelines which suggest different criteria. If you look into the European guidelines, if the GFR is less than 30 and the patient is on dialysis for more than 8 to 12 weeks, you consider simultaneous liver and kidney transplants. So you wait for 8 to 12 weeks for kidney to recover. So if the kidney recovers in this period, only a liver transplant is done. Based on US guidelines, they suggest waiting for 6 weeks. Okay, more than 6 weeks, if the patient is dialysis dependent, you go on for simultaneous liver kidney. Canadian guidelines suggest 12 weeks. So the duration is between 6 to 12 weeks based on various guidelines. So response to therapy and all that, you can decide based on the creatinine decrease. That is, we looked into is the creatinine decrease less than 25% from the peak value. Or you can increase the terlipressin stepwise also. Okay, and if the patient goes on renal replacement therapy, then there may not be any benefit of using terlipressin, then you can stop it. So these are the various modalities of management of renal hepatorenal syndrome. So we'll look into another topic now. So this is also an important question, either clinical or in theory. So use of albumin in ICU. So looking at albumin, some basic idea about albumin. So the molecular weight is 66,500 Daltons. So it is responsible for about 80% of the intravascular oncotic pressure. It is important for regulation of colloid osmotic pressure. So various action of albumin, if you look into, it's a nitric acid modulator and buffer. It's a weak acid, so it can increase the anion gap. So when you're calculating your anion gap, you also need to make sure it is corrected for your serum albumin. So 2.5 will be your factor. So that you have to remember. So again, maintaining the microvascular integrity, that is endothelial glycocalyx. It plays a very important role in maintaining the endothelial glycocalyx. So other physiological important functions, when we were talking about albumin in HRS and SBP and all that, we saw that it has some anti-inflammatory properties. It has antioxidant properties. It can bind with various substances, like it can decrease the toxicity of the drugs, but in case it can decrease the efficacy of our drugs also. Whatever potential drugs we are using also, it can decrease. So it binds with various substances like arachidonic acid, metabolites, fatty acids, vitamin D, many of the hormones like thyroid hormone and many of the hormones. Okay, drugs like anti-epileptics, anticoagulants, antibiotics, digoxin, NSAIDs, sedatives. So it binds with many of these drugs as well. It binds with bilirubin, amino acids, cortisol, and many electrolytes. Okay, calcium, magnesium, all those electrolytes, and nitric oxide as well. So that is one property of albumin. It has very small anticoagulation property and vasodilatation property as well. Okay, so endogenous binding and transport of many of the many substances as well. So these are the physiological functions of albumin. So what is the evidence of using albumin in ICU? If we look at high quality evidence, the beneficial effect is in cirrhosis with spontaneous bacterial peritonitis. So it prevents hepatorenal syndrome. So that there is high quality evidence for this. Okay, in patients who have hepatorenal syndrome, for treating that, yes, there is evidence. Patient who undergo paracentesis, Okay, large volume paracentesis more than 5 liters. Okay, there is evidence for albumin. So these are the three things which has good evidence. Okay, other scenarios where we can use this intradialytic hypotension. For example, if the patient is undergoing dialysis, you want to remove additional fluid, but the hemodynamic status of the patient is not giving you the opportunity, then you can try with albumin. So this is one of some of the low quality evidence. Okay, sepsis with hypotension despite crystalloid resuscitation. So this is based on the Albios trial. Okay, for after you have resuscitated with adequate crystalloids and the patient has not responded. So that is one of the indications wherein it can cause harm. So in traumatic brain injury, definitely not, based on the SAFE study. Okay, definitely you should not be using. Other things, cirrhosis with the extrahepatic infection, there is no role. Okay, and in case of pulmonary edema, fluid overload, and all this, it can cause further worsening. So this is the evidence. We look into each and every study in detail. So albumin as a resuscitation fluid. So when we look into the SAFE trial, they compared crystalloid versus albumin. There was no difference in the 28-day mortality when comparing 4% albumin with 0.9% saline for volume resuscitation. But in patients, in a subgroup of patients who had traumatic brain injury, it increases the mortality. So next study is the year study. So there was no difference in saline versus albumin in mortality. So, but still, the Society of Critical Care Medicine, European Society of Intensive Care Medicine, and the Surviving Sepsis Guideline recommend a campaign recommendation of albumin as the choice in patients with septic shock. So this is something that we need to look into. The Albios trial has suggested that so if you have resuscitated the patient adequately with crystalloids, then supplementing with 20% albumin to maintain the serum albumin levels of 3 grams per deciliter or 30 grams per liter. So if you maintain this level, there is a lower cumulative net fluid balance and quicker resolution of shock. So there is some benefit in albumin in maintaining when we maintain a certain amount of serum levels. So that will result in lesser fluid overload and quicker resolution of shock. This is as per the Albios trial. So is there any benefit of giving albumin for hypoalbuminemia? So normally we all know that for hypoalbuminemia, the half-life of our synthetic albumin is going to be low. So in the long term, it is not going to be beneficial for the patients. So in fact, we need to improve the protein intake of the patients. Okay, so that is where we need to give attention to rather than giving 20% albumin. So where does this evidence come from? This is from the Dubois et al. Trial. So this study said supplementing serum albumin daily in hypoalbuminemic patient. So they did not find any kind of improvement in survival or sustained improvement in organ dysfunction. So this study you need to remember. So de-resuscitation. So albumin has a role in de-resuscitation. It is used as an adjunct to furosemide in this study, the Martin study. So they found they were able to attain a negative balance and improvement in the oxygenation index. So that is regarding de-resuscitation. So other indications we already saw, large volume paracentesis. So if we are doing a more than 5 liters large volume paracentesis, you have to supplement 1 gram per kg per liter of fluid removed. In spontaneous bacterial peritonitis, 1.5 grams per kg, and then followed by 1 gram per kg on day 3. So this is for SBP, for prevention of AKI. And for HRS AKI, 1 gram per kg body weight infused for first 2 days and followed by 20 to 40 gram per kg for the 2 to 16 days. So albumin and renal replacement therapy. So intradialytic hypotension. This is based on the renal study. So this study showed that albumin during hemodialysis improved the hemodynamic stability and improved fluid withdrawal. Okay. Albumin in ARDS, is there any role? Restricted fluid management with reduced fluid intake, use of furosemide, albumin administration to achieve a negative fluid balance has been associated with improved oxygenation, reduced ventilatory requirement, but there's no benefit in outcome. Okay, so there's some kind of benefit in terms of oxygenation and reduced ventilatory requirement, but ultimately there's no mortality difference or major difference in oxygenation. So in cardiac surgery and VA ECMO, priming of the circuit, yes, there is a role for albumin. So this is about the use of albumin in critical care settings. So are there any doubts or anybody wants to kind of share anything? Organ dysfunction will also come in definition. Okay, somebody has asked this question. So in the definition, it is mainly the inciting event resulting in ascites encephalopathy in 4 weeks. Okay, that is the definition. So there's a hepatic insult which is complicated by ascites or encephalopathy. So this is the definition of ACLS, but there are different definitions of the different societies have mentioned, but mainly the Asia Pacific Society is liver centric, wherein they concentrate more on the bilirubin, whereas the other societies have included extrahepatic and intrahepatic causes as well. That is, they have concentrated on the bilirubin as well, and the extrahepatic failure also, they have included it. So when we are classifying this, we already saw that the classification is just not based on the bilirubin, it has included the extrahepatic manifestations as well. So that is what is the major difference in acute on chronic liver failure. See, 5 or 20% albumin, most of the data what we have for HR is SBP, and large volume paracentesis, we normally use 20% albumin. Even in the Albio study, they have kind of used this 20% albumin only. But in fluid resuscitation, sometimes we go ahead with 5%. So normally what we use and the evidence, whatever we look for cirrhosis, SBP and all that, it is, can we get albumin indications chart zoomed in mode? Okay. So are you able to see it? I think if you are looking into your mobile, you can take a screenshot and then you can zoom into, that will help you look into, will give you a better view. Is it okay? Can we move on to the next session? Yeah, okay. May I know if Dr. Jasmine is there? She can move on to the next topics in respiratory system.
Yes, Dr. Priya, I'm here only.
Yeah,
If
sure.
everybody is okay with it, I think we'll move on to the main diseases of the respiratory system. So I have purposely kept these topics towards the end because these I feel are relatively familiar. You will go through these in your day-to-day ward experiences also. So it would, day-to-day ICU experiences also. So it will go a little easier. So I would still request you, I know you must be tired, but as much as possible, please try and keep your ears open and try to grasp as much as you can. I've tried to make it as simple as possible for further revision later on. Okay, I'll just share my screen. So before getting into RS core topics, we had one small miscellaneous topic on biomedical waste management. It's a very easy thing. I'll just go through the points that you need to keep in mind while writing your answers. So then you can later on go through the details. Okay. So coming to the definition of both, what is biomedical waste and what is biomedical waste management? So biomedical waste is any waste that is potentially that is infectious or has potentially infectious material, which is usually generated from healthcare facilities, research labs, or veterinary hospitals. And the systematic process of handling, treating, and disposing this waste, which is generated during the diagnosis, treatment, or immunization or research activities of human beings and animals, is called biomedical waste management. So this entire session part I have taken from the Central Pollution Control Board guidelines on how to manage hospital waste. So it divides hospital waste into three categories. Biomedical waste, the categories of biomedical waste we'll go through in detail in the further slides. General waste, which is dry, wet, and construction waste, and other waste, which includes batteries, e-waste, and radioactive waste. So our focus is going to be on the biomedical waste management. So while there are 5 steps. Okay, that's a mistype. There are 5 basic steps that you need to mention. First is segregation. Second is collection. Third is pre-treatment. Then intramural transportation within the hospital and storage. Okay. So segregation, you should be knowing this. You do it on a daily basis. Segregation of waste into its specific category should always be done at the point of generation. So it should be done at the source. So the moment you are discarding something, you have to throw it in a particular category. And that category is given in a color coding system, which is stipulated in the Schedule 1 of the BWM rules. So these categories I will come to in the further slides. The second step is collection. Okay. Now collection, even the container of the collection is specified on depending upon the category of the waste. I've clubbed both the categories of the waste and the type of the collection bin in one table in the next slide. Timing of collection should be fixed. It should follow your waste generation pattern. So if you're doing a lot of changing of dressings in the morning hours, then the collection should be mid-morning to prevent its accumulation. General waste collection should be done after visiting hours to again prevent its accumulation. So this is another important thing. If you've seen in your ICUs how people discard the waste, you will see they put barcode labels on each waste, and also there is a rule of putting these two symbols, one of caution biohazard and the other of cytotoxic, on depending upon the content of the waste on the bags that you have collected. And interim storage. So you should not store the waste in your ICU or in your wards. It should always be, if at all you need to store it for some time, it should be in the DU section or the dirty utility section. So now we'll come to the categories. So your yellow category includes all your human anatomical waste, animal anatomical waste, soiled waste. This includes all your gauzes, gamgees, dressings which have been soiled with body fluids. Discarded expired medicines also come in this category. Microbiology, biotechnology, and other clinical lab waste. So all of this includes those things which are used in the lab while processing samples, even culture leftovers of the culture plates, or the leftover samples or which have been processed for testing in the lab. All of this are included in your yellow category. Then comes your chemical waste, which is solid and liquid both. Okay. So the type of container they have said is a yellow colored non-chlorinated plastic bag. So and uh, for the red category. Now, red category includes recyclable waste. So this includes all your plastics. I have put the details in this table. All your plastics such as tubings, bottles, urine catheters, bags, syringes without their needles, vacutainers, gloves, all of those come in your red category waste. Now, this also goes in a red colored non-chlorinated plastic bag, which should be more than 50 microns. Then comes your white category. White is for sharps. Now this sharp category will include, all your needles, syringes with fixed needles, scalpels, blades, anything that can cause a puncture or cut. Okay. So this is put in a container which should be white colored. It has to be translucent. It should be puncture proof. Obviously, you're putting sharps in it. It should be leak proof and it should be tamper proof. The last category is your blue category. Your blue category has A and B. A is glassware, B is metallic. Body implants like your ortho implants, sternal wires, splints. So these also are included in a puncture proof, leak proof box, which is marked with a blue color. Okay, so the next step. So we did collection, we did segregation, we did collection. Now we are at pre-treatment. So some types of waste need to be treated before being handed out for disposal. These includes liquid chemical waste, discarded linens and mattresses, all your microbiology and lab waste, and all blood containing vials and vacutainers. So these 1, 2, 3, 4, 5 categories of waste needs one specific pre-treatment, which has been mentioned, which you can go through. Intramural transport, how it should be transported. It should be in a closed trolley, which should be fitted for wheels. There should be easy maneuverability. These trolleys should be only designed for waste collection. You should not use patient trolleys for transporting biomedical waste in the hospital. And storage. So once all of the waste is collected, it has to be stored in a locked, roofed area with some responsible person away from public access. People should not try to collect something from this and reuse it. And there should be proper fire safety and pest control measures. The infrastructure should be good, and there should be space enough to collect 2 days waste. This place should be tiled. There should be easy cleaning, exhaust fans, and nearby water supply with drainage. And there should be clear identification in records. Okay, there are about like authorized personnel only or biohazard logo, and you should not mix it with general waste. So whatever you remember out of this, you just put it in these 5 headings. Okay. So now we'll come to the core topics of the respiratory system. I'll just. Okay. So the first topic we're going to deal with is acute severe asthma also known as status asthmaticus. So if you go through the guidelines in the very old guidelines, there are mention of the term status asthmaticus. The term more commonly used now is acute severe asthma. Before defining acute severe asthma, I first understand what exactly is asthma. So Gina defines it. Remember a few basic points that actually inculcate the entire disease. So the first point is it is heterogeneous. Second, there is chronic airway inflammation. And third, there is a airflow limitation. Okay. Now remember, these 3 points are common to both asthma and COPD. Okay, both of them are heterogeneous lung diseases. There is a chronic airway inflammation. Asthma more of an eosinophilic inflammation, COPD more of a neutrophilic lymphocytic inflammation. And there is expiratory airflow limitation. Okay. What differentiates asthma from COPD? That the expiratory airflow limitation in asthma is variable and is reversible. Okay, variable matlab it can fluctuate in intensity over time. It can have a diurnal variation, it can have a seasonal variation. And reversible matlab either it will reverse spontaneously or with certain treatment. Okay, so that is why you always see the on spirometry you see reversibility, how much improvement is there in your FEV1 FVC ratios after a short acting bronchodilator. So that is the characteristic feature of asthma, that it is a reversible airflow obstruction, but in a persistent long-standing case it can become persistent. Okay, so this is the basic of what is asthma. Now, what is a acute severe asthma? So now, your newest GINA guidelines, they don't they define this in terms of difficult to treat asthma and severe asthma. Okay, so what is difficult to treat asthma? When there is a medium to high dose inhaled corticosteroid and a second agent, and the patient is not controlled. So they require some long-term oral corticosteroids to maintain that control. And when these long-term oral corticosteroids are tapered and the symptoms increase, or high dose inhaled corticosteroids are also causing persistent symptoms, then it is severe asthma. Okay. So there are two terms basically. Difficult to treat is medium to high dose inhaled corticosteroids are not the patient does not respond to medium to high dose inhaled corticosteroids and requires some oral corticosteroids. In severe asthma, despite this, the patient symptoms are persistent, and whenever you reduce the high dose treatment, the patient will have worsening of symptoms. Now, what is acute severe asthma? So acute severe asthma is any severe asthma exacerbation that will pose a risk of death if not treated promptly. That is, any life-threatening symptom is called acute severe asthma. Now, if you see, though these GINA guidelines are not for our routine ICU care, it's more for an OPD care, but just to help you understand what is DTA and what is severe asthma, you have to see this stepwise approach. Okay, so GINA gives you a stepwise approach to treat asthma on an OPD basis. You have a SABA. You initially they start with a SABA, then they might add a low dose, some adjuvant therapy like a leukotriene receptor antagonist or a low dose theophylline. Then they might step up to inhaled corticosteroids. Then they might add LABA. Then they might go up to medium dose corticosteroids along with a LABA. So somewhere here at step 4, when the patient is not responding, they call it difficult to treat asthma. Okay. And when this is being treated with oral corticosteroids and that you're not able to taper the oral corticosteroid, patient needs something more like an immunological therapy, then it is a severe asthma. Okay. And acute severe asthma means any asthma exacerbation which comes with a risk of death if not treated promptly. Symptoms. So anywhere you write signs and symptoms, you start with heart rate, the RR, all of that. So you can just describe it, what you see on a clinical practice. You will have tachypnea, you will have tachycardia, you will have visible accessory muscle use. There is distress, respiratory distress in terms of wheezing, chest tightness, and cough. There's cognitive impairment because of the hypoxia. There can be confusion, drowsiness, agitation, irritability, and there is functional impairment. This is one of the telltale signs of a severe asthma attack, that the patient is not able to speak in full sentences. He becomes very breathless. And what are the signs of an impending respiratory arrest? If there is paradoxical breathing, if there is a silent chest, there is bradycardia or pulsus paradoxus. So these four symptoms indicate there is a sign, there is an impending respiratory arrest. Okay, now to classify the treatment and to classify the severity, this is one very nice diagram that sums it all up. Okay, if you just focus on the bottom line, that is the x-axis, which is a predicted percentage of predicted peak expiratory flow rate. Okay, so when your peak expiratory flow rate is below 50%, you're calling it acute severe. So this will be associated with inability to complete sentences, tachypnea, tachycardia. Okay. When this PEFR falls below 33%, then it is called life-threatening. And at this stage, it is associated with altered consciousness, exhaustion, arrhythmias, hypotension, cyanosis, silent chest, desaturation, and a normal PCO2. Okay, so always remember, unlike COPD, where you have patients come with high PCO2, here the patients either have a low PCO2 because they are breathing so fast, there is tachypnea and there's washout of CO2. But if there is a normal PaCO2, that means this becomes a life-threatening condition. Okay. And when the CO2 starts rising, it is called near fatal asthma. This part of the graph. Okay. So in each stage, what are the possible therapies are very nicely depicted in this diagram. Beginning with oxygen therapy, bronchodilators, steroids, then going to magnesium sulfate, IV salbutamol, IV aminophylline, mucolytics, going to NIV, HFNC, invasive mechanical ventilation, and certain additional therapies may be inhalation anesthetic agents or IV ketamine, ECMO, and EPOR. Okay, so this all are included in your life-threatening asthma. So to answer the question of how to treat, I've divided the treatment in three categories: pharmacological treatment, which includes your nebulized bronchodilators, ipratropium bromide, corticosteroids, magnesium sulfate, and aminophylline. What all you'll do for oxygen and ventilation, you will give some oxygen through oxygen delivery devices like HFNC and IV mechanical ventilation, and additional therapies which are not recommended, but in severe cases, you can try it as an adjuvant therapy. So first, coming to pharmacological therapy, the first and the foremost thing over here is nebulized bronchodilators, which include short-acting beta agonist, okay? High-dose nebulized beta-2 agonist, which is the first line of therapy, okay? It can be given back-to-back nebulizations, like 2.5 to 5 mg initially every 20 minutes for 3 doses, followed by once every 1 to 4 hours, or it can be given as a continuous nebulization also, depending on the response. So after short-acting beta agonist, the next is your anticholinergic. That is your ipratropium bromide, dosing being 0.5 milligrams 4 to 6 hourly. Now, this is not used as a routine treatment of asthma. It can be used as an additional treatment, okay? Especially if your patient is not stabilizing with your just plain SABA. Then comes your IV corticosteroids. So they have proven mortality benefit. One, prevents relapses, hospitalizations, and the need for beta-2 agonist therapy. There is no difference between oral, IV, intramuscular routes, and the formulation also has not shown much difference in efficacy. the recommended dose is 40 to 50 milligrams of prednisolone or 400 milligrams of hydrocortisone, which is 100 milligrams 4 times a day for at least 5 days. The side effects of steroids, what you normally see, are usually modest when you use it for a short duration, and the benefits in asthma outweigh these side effects. If the patient is already on an inhaled corticosteroid, that has to be continued. You do not stop it when you start an IV corticosteroid. So at this level also, when your patient is not responding, the next thing you go to is magnesium sulfate. Okay, now nebulized form is not recommended. The only recommendation is to consider giving a single dose when there is no good response to your initial bronchodilator therapy. Single dose, 1.2 to 2 grams IV infusion given over 20 minutes. Now, how does magnesium sulfate help? One, it will cause inhibition of the cellular uptake of calcium via activation of sodium calcium pumps. It causes muscle relaxation via the inhibition of myosin and calcium interaction. So basically inhibits calcium activation by acting on the sodium calcium pumps. Second thing is it inhibits prostacyclins and nitric oxide synthesis. It has an anti-inflammatory response via inhibition of the mast cell degranulation. So it is both bronchodilatory effect. It also has an anti-inflammatory effect. What is the evidence? So the one biggest trial that tested the role of magnesium sulfate in asthma was a 3 mg trial, around 1100 patients. It compared IV with nebulized therapy with standard therapy and did not find any benefit, okay, in terms of dyspnea, in terms of PFR, when compared to placebo. But further Cochrane review and meta-analysis showed that it did improve lung functions in patients who did not respond sufficiently to the initial therapy. Okay, so there is a very mixed evidence, and that's why it is not they don't recommend it outright, but they do say you can consider it if the patient has failed to respond to your initial SABA and corticosteroid. Always remember, for asthma, it is a SABA and corticosteroid. The next, if even this fails, the next level you go to is a aminophylline. Aminophylline is again a smooth muscle relaxant. It acts by inhibiting phosphodiesterase and enzymes. This also inhibits the translocation of calcium. It is also an adenosine receptor blocker and causes modification of GABA. So it has 4 primary mechanisms of action. Routine IV uses not benefit, no evidence of any benefit over standard therapy, but always can be given as an adjuvant therapy if there's a near fatal or life-threatening condition. So the dose is a 5 mg per kg loading dose given over 20 minutes. And loading dose is given only if the patient was not already on a oral therapy. And then it is given as an infusion at 0.5 to 0.7 milligram per kg per hour. The side effects, it causes vomiting and it can cause arrhythmias. It is a narrow therapeutic index. So whenever you're giving an IV infusion, it has to always be done under therapeutic drug monitoring. So you have to measure the plasma concentration and ensure that you are in the therapeutic range and alter your infusion accordingly. Coming to supplemental oxygenation, you know this, you can write about the target saturation here is around 94 to 98. First line, you start with a nasal cannula, face mask, or oxygen with a reservoir bag. Next line is your HFNC again. So for hypoxemic respiratory failure. So you remember, for asthma is more of a hypoxemic respiratory failure. It's not a hypercapnic. It's very rare to have. It's not that you cannot get, but it is very rare to have a hypercapnic type of a failure. It usually happens when it in a very near fatal condition, like the term mentions. Okay, so HFNC is always the way to go for a hypoxemic respiratory failure. So the next, if your low flow devices fail, you can try HFNC. Next is NIV. Sorry. So again, NIV is more established in a hypercapnic respiratory failure. Even if you're using, it should never be used as an alternative to invasive mechanical ventilation, nor should you delay intubation. If you're not able to manage with your other oxygen delivery devices, and the patient's hypoxemia is worsening or symptoms are not getting resolved, you should consider invasive mechanical ventilation over NIV. So this is in contrast to what is recommended for COPD. For COPD, what they say, you always prefer NIV over invasive mechanical ventilation. Obviously, all of this is done under strict monitoring. After that, the next stage is intubation. So when will you intubate a patient with an acute severe asthma? So all the complications that you see with the acute severe asthma, that is one to exhaustion, increasing use of accessory muscles, failure to treat the failure to reverse any respiratory acidosis if the patient has an altered sensorium or hypoxemia didn't resolve with the oxygen delivery and the patient has silent chest. These are all relative indications. Immediate indications, obviously, arrest, impending respiratory failure. We already saw the 4 classical signs of impending respiratory failure, obtundation, coma. You can just pick up the gist from this table and mention whatever like structure comes to your mind first. Okay, so when you're writing intubation, when indications of intubation, and then what are the challenges in intubation. So you do an RSI in such patients. It is pre-oxygenation is challenging because they already have a gas trapping. So this is of anticipated physiologically difficult airway. Preferred in specific to asthma, for RSI, preferred induction agent would be ketamine or propofol. And what all problems would you anticipate when you're intubating such patients? That one to the spasm will worsen, air trapping will worsen, and that air trapping will cause cardiovascular collapse, especially if the patient has a depleted intravascular volume. And finally, mechanical ventilation. So, mechanical ventilation in asthma can be a specific question in itself. So what are the challenges in ventilating an asthma patient is high airway pressures first. Okay, so you know that this is more of an upper airway problem, upper airway bronchospasm, because of which the airway pressures are going to be high. So you will require that much high pressure to ventilate this patient. So in such patients, you actually accept a higher peak pressure alarm just so that you are able to overcome that airway resistance and ventilate the patient. Other major problem in asthma is dynamic hyperinflation. And what are the complications of that? Air trapping, barotrauma, pneumothorax, hemodynamic instability. So mainly you remember high airway pressure and dynamic hyperinflation. Because of dynamic hyperinflation, you'll have all barotrauma, pneumothorax, and also you'll have hemodynamic instability. So these 3 are the major challenges while ventilating a patient of asthma. So what are the principles? How do you overcome these challenges? One, though, what all the measures you take to avoid dynamic hyperinflation. That means you ventilate with low tidal volume, so that the lesser that goes, the lesser that has to, the lesser is retained. So lesser gas trapping. So ventilate with low tidal volumes. You keep the RR low just to allow enough expiration and prolong the expiratory time. Increase your IE ratios. The controlled hypoventilation with permissive hypocapnia. Obviously, all of these measures would lead to hypoventilation. So you're doing a controlled hypoventilation. Because of your controlled hypoventilation, some amount of hypercapnia is allowed. Okay. Next is minimal PEEP. Minimal PEEP, unlike COPD, where PEEP plays a very big role in overcoming the patient's breathing effort, asthma, there is no such importance. So you can use a minimal PEEP. In fact, if you add too much of PEEP, you might increase your peak pressures further. Okay, so here you'll use a minimal PEEP in contrast to what you do in COPD. Target a peak inspiratory pressure of less than 50. I told you, you accept a higher peak inspiratory pressure and plateau pressure of less than 35. And use sedation and SOS paralytics to prevent desynchrony. Okay, so major thing is controlled hypoventilation, permissive hypercapnia, avoiding dynamic hyperinflation, and low, keeping the PEEP low. So you see each of these challenges has one particular principle on this side. So what mode is preferred? Volume control, low tidal volume, low RR, minute ventilation should be adjusted accordingly. And your IE ratio would be higher, PEEP, again, low to minimum. And in case you see there is breath stacking, you just disconnect the ventilator. This is only recommended in asthma. This is not true for COPD, ARDS, where the PEEP effect is important and you don't want to break the circuit. In asthma, you can. This is one of the recommendations for treating dynamic hyperinflation. In fact, you should be very watchful of this. Additional therapies, I'm not going into the details. You can read it out. ECOR, ECMO, mucolytics, obviously, because there is increased mucus plugging. Nebulized heparin. So giving heparin as a nebulization acts like an anti-inflammatory. It basically stabilizes mast cells, inhibits eosinophils, and because of this, there is a decreased reaction to the allergens. But of course, there is no clear-cut evidence to prove benefit, and hence it's just an additional add-on therapy that can be tried. The dose used in studies are 25,000 international units every 6 hours. rhDNase or recombinant human deoxyribonuclease. So the concept over here is you have mucus plugging in asthma. So that mucus plug is made up of mostly free DNA. So this DNA causes the viscosity to increase, adhesiveness to increase. So you give a DNase to liquefy it and it reduces your mucus plugging. It is a recommended treatment for cystic fibrosis, but does not have enough evidence in asthma. It can be used as an adjuvant therapy. And the last is Heliox. Heliox is basically a mixture of helium and oxygen. So basically, it has a similar viscosity but a lesser density so because of this the airway resistance reduces and the work of breathing decreases. Okay, but this again has no evidence of no large scale evidence of a benefit. Again, just comes under additional therapies. I've put them here because these 6 things, matlab, you can get a question on additional therapies in asthma. It's been mentioned everywhere. So one is ECOR, ECMO specifically because survival rates of ECMO as compared to other indications, asthma survival rates are better. But usually you don't go that far to need an ECMO. Mucolytics, nebulized heparin, and rhDNase and Heliox. So these 6 things come under additional therapy. You just know how they exactly work and mention each like 2 lines on each should give you a decent answer. So now moving to acute exacerbation of COPD. Now in COPD exacerbation, how I have expressed this in this presentation is I've defined both what is COPD and then what is its exacerbation. So this I've done the same way for asthma. So what exactly is asthma and what exactly is the exacerbation? These definitions are from the GOLD guidelines. So I told you, right, like those 3 things, 3 points that you should mention. It is heterogeneous, it is chronic symptom, chronic respiratory inflammation, and airflow obstruction. But in case of COPD, this airflow obstruction is persistent and progressive. In asthma, it was variable and reversible. So what is COPD exacerbation? So baseline patient usually has COPD patients will always be dyspneic, have some sputum and cough. So whenever there is a acute event in the natural course of this disease, such that there is a variation from the baseline symptoms beyond the day-to-day variation, and this should occur in less than 14 days. That requires treatment with oral steroids or antibiotics or both in a patient with an underlying COPD. So basically, change in the symptoms from baseline within 14 days that needs to be treated with steroids or antibiotics or both. Coming to the etiology of COPD. So if you see your GOLD guidelines, they have this taxonomy of etiotypes. COPD-G is for genetically determined COPD. COPD-D is for patients with abnormal lung development. C is for cigarette smoking. I is for infections like chronic TB infections. A is for asthma converting into COPD. U is for an unknown cause. And P is for pollution, biomass or pollution exposure. So basically, they have given such a taxonomy mainly to highlight that apart from smoking, there are other underlying etiologies that can actually cause COPD. What causes an exacerbation? Exacerbation can be either infectious or non-infectious. Infectious are more commonly viral, less and sometimes even bacterial. So all your viral and bacterial causes of pneumonia will come here. And non-infectious causes most commonly are MIs, heart failures, pulmonary embolisms, aspirations, and sudden increase in exposure, like to the pollution or whatever inciting trigger was. Pathophysiology of COPD, I'm just going to brush through this. It starts with inflammation. There is some inciting agent. There is an inflammation in the airway. This inflammation will cause some structural changes in the airway. These structural changes lead to airflow obstruction. Because of airflow obstruction, there will be gas trapping. That will ultimately lead to a decreased FEV1 and FEV1 FVC ratio. What ultimately, because of this, there is a hyperinflation. So because of your structural changes, your airflow obstruction is occurring. Your airflow obstruction is causing gas trapping, and this gas trapping is causing hyperinflation. This hyperinflation will lead to abnormal gas exchange, causing hypoxemia, hypercapnia, and in long-standing cases, it can even lead to pulmonary hypertension. What happens in an exacerbation? You have to only focus on this part, is hyperinflation. Okay. So these patients, because of the airflow obstruction, they're already they have an hyperinflated lung. Now, this hyperinflated lung remains static unless it is stressed. Unless it is stressed means there is some increase in the respiratory drive. RR increases, tidal volume increases, your expiration time further decreases. This is known as dynamic hyperinflation. This change in the baseline hyperinflation or a dynamic hyperinflation is your basis of the exacerbation of COPD. The pathophysiology of an exacerbation can simply be explained by this. Anything that increases your respiratory drive worsens your underlying hyperinflation. Okay, so what happens when you have this dynamic hyperinflation? One, though, gas exchange is obviously affected. There is a mechanical disadvantage. Okay, so now you know an emphysema in COPD or emphysematous lung, there's a flattening of the diaphragm. The entire architecture of your chest and chest wall is changed. So all your inspiratory muscles are already kind of weakened. And on top of that, you are going to increase their workload by causing dynamic hyperinflation. So this is what is again another differentiating point between asthma and COPD. Okay, asthma, the muscle mechanics are not affected. COPD, because of the emphysema and hyperinflation of the lungs, what happens is the muscle anatomy is also affected. The diaphragm flattens, inspiratory muscles also get weakened. So because of this, there's a mechanical disadvantage. This causes neuromechanical uncoupling. So the patient is always dyspneic, and cardiovascular effects. So, so if your positive pressure in the thorax increases, what happens? Your RV preload will decrease and your LV afterload will increase. Clinical features for COPD, cough, dyspnea, cough, sputum, wheezing, fatigue, weight loss. And exacerbation, all of that gets worsened. Dyspnea will worsen, cough will worsen. Sputum, always mentioned, volume also changes, purulence changes. These are the two classical features you always ask in history, just to suspect an underlying bacterial infection. There'll be fever, and COPD, COPD exacerbations, bedside, you're worried about two things. One is your RV failure, and second is your CO2 narcosis. So there will be pedal edema, implicating that this patient has gone to a level of poor pulmonary. or there will be an altered sensorium due to CO2 retention. So the signs, you can write all of these: respiratory system, neurological system, cardiac system. And the investigations of COPD. Okay, this I'm going to skip this slide. This is for an OPD basis patient. But in case of an exacerbation, what all you will do, what all you do with when you normally receive a COPD patient in your ICU, you send blood counts, you send blood gas, you will send sputum, you will send viral panel swabs, you will send CRP, PCT, chest X-ray, ECG, echo, and CT chest. So all of these investigations you can define in detail in 119. And how do you manage this? So only reason I've put this gold uh, 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 guideline of how to manage COPD. This is COPD, not exacerbation. Okay. COPD is that you understand there everything is LABA and LAMA, that is long acting bronchial beta agonist, along with a anticholinergic. Unlike asthma, it is all beta agonist and inhaled corticosteroids. Here it is all LABA, LAMA, and also you can add an inhaled corticosteroids if your eosinophilic count is more than 300. So how do you manage a COPD exacerbation? So COPD exacerbations can be classified as mild, moderate, and severe. In mild cases, you will have the parameters that are used to assess the severity are visual analog score for dyspnea, RR, heart rate, saturation, CRP. Okay, when all of these are low, it is mild. When all of these are high, it is moderate. When along with that, it will be accommodated in, it will be associated with some sort of a CO2 retention without acidosis. And when that CO2 retention comes with acidosis, then it is called as a severe.
This meeting is being recorded.
Gold category will change. So here is the gold categories. Over here is only 0 to 1 exacerbation, and here it is more than 1 leading to hospitalization. So you will have to add something to optimize these patients to prevent them from coming back, getting admitted again with an exacerbation. So part of your therapy at discharge is to optimize that inhaled therapy. So starting, the most important part of this therapies are these: bronchodilators, glucocorticoids, antibiotics, and adjuvant therapies. These three are the most important: bronchodilators, steroids, and antibiotics. Okay. So bronchodilators, here I told you, okay, asthma, it was only a SABA. Here it only when in an exacerbation, sometimes you can add ipratropium bromide. Here you always give a SABA and SAMA always. Okay. The guideline says that there is no difference between a metered dose inhaler or a nebulizer, but in a sicker patient, you will obviously prefer a nebulizer. For continuous deliveries, they prefer MDIs over nebulizers. And if you're using a nebulizer, prefer air over oxygen. Okay, because again, you don't want to give too much oxygen in patients of COPD because you will worsen their CO2 retention. And if the patient is not already on a long-acting beta agonist, you will start that. Okay. The next thing after optimizing the bronchodilators, you add systemic steroids. Again, over here, the dose is 40 mg of prednisolone equivalent for 5 days. Again, over here, they say IV oral equally effective. And even this short therapy can still cause an increased risk of infection. Antibiotics, you look for sputum volume, sputum purulence. When all these three cardinal symptoms are present, dyspnea will always be there. When the sputum volume has increased and the sputum purulence, or only sputum purulence with any one of these, or the patient is requiring a more invasive or non-invasive ventilator, then you add a antibiotic. Recommended duration is only 5 to 7 days. Antibiotic preferred over here is amoxiclav, macrolides, tetracyclines, or fluoroquinolones. And if the patient can tolerate orally, always oral is preferred over IV. And adjuvant therapy, again, if you have RV failure, add diuretics. COPD patients are at a 5.4% risk of venous thromboembolism. So add prophylactic anticoagulation, treat the comorbid illnesses, and provide adequate nutritional support. Okay. Now for respiratory support over here, so in asthma, you target a good saturation, like 94 to 98. Unlike that, in COPD, you target only 88 to 92% saturation. And the preferred device for delivering oxygen in a COPD patient is a Venturi mask. Why do we prefer a Venturi mask? We've already seen it, that it has a more accurate and a more controlled delivery than your usual nasal prongs. It's a fixed performance device. Okay.
This meeting is being recorded.
Sorry, what happens to the minute ventilation is in red, and what happens to the CO2, okay? So when you're giving too much oxygen, the CO2 starts rising and continues to rise. What happens to the minute ventilation? It will initially fall because your hypoxic drive is suppressed, but eventually this recovers. So this is not the main mechanism. Abolition of hypoxic drive is not the main mechanism to cause hypercapnia in COPD patients, okay? The other mechanisms that are actually more important are loss of hypoxic vasoconstriction. Okay, you know what is hypoxic vasoconstriction? Whenever there is an underventilated alveolus, the blood vessels over there undergo vasoconstriction just and divert the flows to better ventilated alveoli in order to maintain the ventilation perfusion ratio. When you give too much oxygen, so even an underventilated alveoli will have oxygen. So this hypoxic pulmonary vasoconstriction is now abolished because the oxygen tension in this underventilated alveolus is high. So because of this, what happens is your VQ mismatch worsens. When your VQ mismatch worsens, even your low ventilated areas are getting good blood supply, and that CO2 is not getting washed out. So there is more and more hypercapnia. Okay. Then comes the Haldane effect. Okay, I already told you what is Haldane effect. What happens between hemoglobin and carbon dioxide in the absence of O2. Okay, whenever that is your deoxyhemoglobin has a better affinity for carbon dioxide than oxygenated hemoglobin. So if you give too much oxygen, what will happen? There is a rightward shift of the CO2 dissociation curve, the Haldane effect, because of which this your partial pressure of CO2 will increase. Your CO2 is not getting carried by your hemoglobin and to the lungs for elimination. So the partial pressure of CO2 in blood increases. Okay. So these three mechanisms you should know, especially your loss of hypoxic vasoconstriction and the Haldane effect. These two are majorly responsible for causing hypercapnia in patients when you give too much oxygen in COPD patients. You can try HFNC, but always remember there is no sufficient evidence to recommend its use, because again, like COPD is more of a hypercapnic failure and HFNC is more of a initial choice in a hypoxic failure. So in stable hypercapnic COPD patients, it has been tried, but the evidence is not good enough. NIV. Regarding NIV indications, we've already seen any respiratory, if your patient has respiratory acidosis or the work of breathing is not settling or has high work of breathing or your hypoxemia is not settling, you go for NIV. Okay. So this is one place where it is preferred over invasive mechanical ventilation as an initial choice of therapy, because it has a lot of benefits. It improves your pH, washes out PCO2, decreases your work of breathing. It's known to reduce VAP rates, length of stay, intubation rate, and mortality. Okay. And the so you don't need to wean the patient from the NIV. In a COPD patient, if they are tolerated 4 hours of unassisted breathing, you can directly stop the NIV. Next is the role of invasive mechanical ventilation in patients with COPD. So what are the indications? Again, whenever your non-invasive has failed, so all your contraindications to NIV are basically your indications for invasive mechanical ventilation in COPD patients, because like already said, NIV is like a first choice. So if you can't use NIV because of some arrest or worsening consciousness, or patient has some aspiration, persistent vomiting, or inability to clear secretions, severe hemodynamic instability, arrhythmias, life-threatening hypoxia. If you see this table is exactly what is given in the contraindications of NIV, you then put a COPD patient on mechanical ventilation. Now, what are the challenges in ventilating a COPD patient? Like we saw in asthma, dynamic hyperinflation is one problem. Along with that, you have something called, I've explained this concept right now. You have an overloaded pump and a flat diaphragm. Already patient is hyperinflated. Over that, there is dynamic hyperinflation. Over that, the diaphragm is already been flattened and weakened. Okay, so they fatigue easily. And there is like a pump failure also, apart from a impaired gas exchange. There's a pump failure also. And of course, CO2 retention is a problem with COPD patients. Again, so here also the principles are the same. Controlled hyperventilation, prolong expiratory time, unload the breathing effort. This you do by adding PEEP. Okay, this is again different as than what it was given in asthma. Okay, you use there is no significant role of PEEP, because again there is no muscle fatigue or asynchrony over there. The problem over here is the intrinsic PEEP with an overloaded muscle causes an increase in the breathing effort. Now the patient has to work against his own PEEP to generate a breath. So you unload this by giving an extrinsic PEEP. Okay, and promote synchrony. That is common to both the asthma and COPD. Use sedation, muscle relaxation as required. So we'll look at each principle. Controlled hyperventilation, you know how to do. You give low tidal volume, give low, keep a low RR, increase the expiratory time. So all of this is done mainly to if less minute ventilation goes, then the expiratory requirement will also be less. And because of that, there will be decompression of the lung. Okay. Because already when there is an airflow limitation and you're forcing a higher limitation, more and more, how much ever you give will just get trapped. The by relation will be able to how do you achieve how you prolong experience? You want to allow how do you do increase the peak inspiratory flow rate or decrease the inspiratory? Now comes to the part of unloading the breathing effort. Okay. So now you understand the rationale behind 41% of the inspiratory effort taken in a COPD patient is spent to overcome that intrinsic PEEP. Okay. So whenever you add an extrinsic PEEP, it sort of negates the gradient between the airway. I'll I'll try to explain this better. And this the ventilator interaction. Okay. So to understand how this works, one thing is really unique to COPD patients, and you should know this. It's also known as the waterfall analogy. Waterfall analogy, you're adding an external PEEP to treat an auto PEEP. Okay. So how they have correlated this with a waterfall is that now you see what is happening in the lung. You have an alveolar pressure over here. You have some narrowing over here, and there is an airway pressure over here. Okay. So this they have correlated with a waterfall, where the height of the waterfall correlates with your alveolar pressure, and the downstream water flow correlates with your airway pressure. Okay. Now, in order to overcome this difference, okay, what you do is you apply an extrinsic PEEP. Okay. So when you apply an extrinsic PEEP, you basically are improving the height of this waterfall, making it easier for it to flow from year to year. All right. So, sorry. So without an extrinsic PEEP, flow will begin only when the intrinsic PEEP or the threshold load is overcome. When you apply an extrinsic PEEP, this threshold is offset, so the patient does not have to generate as much negative pressure, and this is what reduces the work of breathing. And then the last part is to promote synchrony by sedation and SOS, neuromuscular blockade. So I've just summarized all of this in the ventilator settings. You can go through it later. What mode, tidal volume, RR, IE ratio, rise time, targeted P-flat, and PEEP, which is 80% of the intrinsic PEEP. So how do you set PEEP in COPD? You basically gradually go on increasing it till the patient is able to trigger. So basically his intrinsic PEEP is causing a inability to generate enough negative pressure to trigger, right? So you keep on adding a PEEP till every breath is triggered. So the ineffective triggers are reduced. Or you keep on adding the peak pressures. If your PEEP is increasing the peak pressure, you're causing more damage. You're increasing the workload. So you have to reduce this till the point that your peak inspiratory pressure remains static. Weaning in COPD, like I told you, because of this workload I've explained to you, weakened inspiratory muscles and airflow obstruction, all of this will cause a tendency of the patient to be more mechanical ventilator dependent. And that is why the method of weaning a COPD patients to directly bridge them with an NIV. So you directly extubate these patients to NIV. It is proven to have a higher success, decreased length of stay, decreased BAP, and improved survival. Okay, I have explained all of these points as we have walked through asthma and COPD both. I've put it all in one chart for you to be able to reproduce this in exam and for you to basically understand these differences while yourself when you are ventilating and treating such patients. Next topic is tension pneumothorax. Tension pneumothorax is a very short topic. I can just breeze through it. Basically, pneumothorax is air in the pleural space. You have simple, where there is no mediastinal shift, tension, where there is a shift in the mediastinal structures, and open, when there is an open chest wound through which air is exhaling out also. So what is tension pneumothorax? It's a life-threatening form of pneumothorax in which the intrapleural pressure rises progressively with each breath because air enters the pleural space and cannot escape. This will ultimately lead to collapse of the affected lung, mediastinal shift to the opposite side, compression of the contralateral lung, and obstruction of venous return. So this is the defined CPRs and intercostal nerve blocks or any penetrating or blunt trauma. And non-traumatic causes can be primary, like an unknown etiology. You can have spontaneous pneumothoraxis, and secondary causes when there is a underlying lung is diseased and that itself gives way causing a pneumothorax, like your bulle rupture in COPD. So just to simplify to present the pathophysiology in a simplified way, you draw the intrapleural pressure, you draw the alveoli. So the alveoli have a tendency to recoil inward and your chest wall have a tendency to recoil outward. Why does this happen? Because your intrapleural pressure is negative. Because so there is some sort of a difference in these two pressures, known as your transmural pressure, and that is what will cause the alveolus to be kept expanded. So whenever there is a rupture, this negative intrapleural pressure becomes zero, and this causes the loss of the transmural pressure. And now your alveoli will recoil inward and there will be a lung collapse. And diagnosis. So starting from what do you see on examination? There will be reduced chest exertions on the affected site, enlarged hemithorax, hyperresonant percussion, absent breath sounds, tachypnea, desaturation, tachycardia, for tension pneumothorax especially, hypotension and tracheal deviation to the opposite side. What about so normally, if they say approach to a patient with tension pneumothorax, you just write whatever you see on examination findings and go to needle decompression. But if you have a POCUS available, you can always at the same time mention because it's a life-threatening situation. You don't sit and wait for a chest X-ray, CT. It's a clinical diagnosis. You can reinforce your diagnosis with POCUS. So what do you see in POCUS? There is absence of lung sliding. You can see this video. So normally you have a seashore sign. That means when you take an M mode across a lung window, you will see a transition between the pleura and the lung. which is seen as a seashore sign. You can see this part looks like a sand, and this part looks like your waves of a sea. So this is known as your seashore sign. In pneumothorax, what you see is a barcode or a stratosphere sign. The seashore sign is lost, and instead you will just see horizontal lines resembling a barcode. And the most diagnostic feature of ultrasound of a pneumothorax is a lung point. Okay, so normally you will see any air shadow will create an A line. So A lines can be normal or can even be seen in pneumothorax. Absence of B lines is one of the signs of on ultrasound of a pneumothorax. Chest X-ray, you will see this collapsed lung with a definitive demarcation between the collapsed lung and a hyperlucent air shadow. So treatment, immediate needle decompression. Any hemodynamically unstable patient, you have to treat with an immediate needle decompression. Now, the traditionally described site was the second intercostal space in the midclavicular line. Okay, this is not for an ICD insertion. This is a needle decompression done in an emergency. But the latest ATLS guidelines now say that the success rate is higher when you do it in the fifth intercostal space, slightly anterior to the mid-axillary line. Okay. So from the second intercostal space, mid-clavicular line, we have moved to the fifth intercostal space, slightly anterior to the mid-axillary line. You will need a catheter over needle, either 12, 14, 16 gauge with a syringe with attached to a syringe without the plunger. So you insert this into the site and just about the superior border of the rib. And after needle decompression, you obtain a chest X-ray. Now, to increase the rate of successful needle decompression, you prefer a longer catheter around 8 centimeter, and you do finger thoracostomy. Okay, because what they now say is that your needle decompression success rates might be low, so you just insert a finger and try to enlarge your this thoracostomy. What are the other things you do? You cover the chest wounds and you can administer 100% supplemental oxygen to wash out the nitrogen. So whenever you wash out the nitrogen present in the pneumo will move from the pleural cavity to the alveolus, and it will cause some resolution of the pneumothorax, and avoid positive pressure ventilation as much as possible, at least not without decompression. Okay, I think I should I continue or should I 1 second. I'll just get back. Relatively, at least these diseases are relatively simpler. If you really feel that you need something more on this, you can let me know and I'll work on it. Now coming to community acquired pneumonia. So in community acquired pneumonia, we have 3 specific definitions. One is what is a CAP, second is a HAP or a hospital acquired pneumonia, and a VAP, that is a ventilator acquired pneumonia, associated pneumonia, which we will see after this. The older term HCAP, healthcare associated are, one is a non-ventilator HAP. That means it is occurring in a patient who is not on mechanical ventilation. There is a VAP or a ventilated pneumonia. that is occurring 48 hours after intubation. And there's a VHAP, that means patient was not on ventilator. He got a hospital-acquired pneumonia and now he's gone on mechanical ventilation. So that is a subset which is known as a VHAP. Okay. So earlier used to have this definition. Now it is not used. You have only CAP, HAP, and under HAP you have three subcategories: non-ventilated HAP, ventilator-associated pneumonia, and VHAP. That means the patient got ventilated after acquiring a hospital-acquired pneumonia. So etiology-wise, primary pathogens, bacterial, three that you should remember: strep pneumoniae, HIB, Staph aureus, and Moraxella catarrhalis. And amongst atypical bacteria, Mycoplasma, Chlamydia, Legionella. And just because we are in India, also I'm adding Mycobacterium tuberculosis to this list. Amongst viruses, you have most commonly influenza, respiratory syncytial virus, COVID, rhinoviruses, adenoviruses, parainfluenzas, and human metapneumoviruses. Very rarely fungi, only seen in immunocompromised individuals. Histoplasma, coccidioidosis, and blastomyces. Now, how do you score? The easiest severity scoring system is your CURB 65. CURB 65, as the name suggests. C is for confusion. U is for urea, that is your BUN more than 19. R is for your RR more than 30. B is for your systolic BP less than 90 or diastolic less than 60. And 65 is the age more than 65. Each of this parameter is given 1 point, and they have defined more than 3 points as an criteria to consider ICU admission. And it is associated with a 22% mortality risk. The other scoring system is your pneumonia severity index. Pneumonia severity index basically has four major sections. One is your demographics, which includes age, nursing home resident, associated comorbidities, neoplastic liver, cardiac, cerebrovascular, renal diseases, examination findings of either, so all of that you see in the other scoring systems also: altered mental status, RR more than 30, systolic pressure less than 90, pulse more than 125, temperature either less than 35 more than 40, and lab findings where you have pH less than 7.35, BUN more than 10.7, low sodium, low sugars, low hematocrit, or a low saturation, or the presence of a pleural effusion. So the pneumonia severity index is a much more extensive scoring system. The points are given as high as 130, divided into 5 categories: 1, 2, 3, 4, 5. First three associated with a low risk, fourth and fifth with a medium and a high risk respectively. So though they are good at predicting mortality, there is a poor correlation between mortality risk and ICU admission. So they are not very commonly used in severe cases. Instead, what they do use is a smart cop scoring system. So smart cop is found to be more accurately estimating the need for IRVS, that is intensive respiratory and vasopressor support. What are the components of your smart cop? Smart cop S is your systolic pressure less than 90. M is multilobar X-ray involvement. A is albumin less than 3.5. R is expected RR more than 30. T is tachycardia. C is expected confusion. O is oxygen saturation less than 90%. And P is pH less than 7.35. So anything more than 5 points is classified as severe pneumonia. That means they have a high risk of needing intensive respiratory or vasopressor support. Then you have the IDSA criteria, which is a much more simpler criteria to call it severe pneumonia. It needs either one major and three or more minor. Major is one is two reasons why patients come to the ICU, shock and respiratory failure. So any one of this, and minor includes tachypnea, low PF ratios, multilobar infiltrates, confusion, uremia, leukopenia, thrombocytopenia, hypothermia, hypotension. So you can actually most commonly ICU perspective, I think SMART COP is one you should know. COP 65 is easy to remember. IDSA, good to at least know that it has a major and a minor category. Predisposing factors, extremes of age, comorbid conditions like COPD, asthma, diabetes, heart diseases, lung or immunosuppressed patients, lifestyle and environmental factors like smoking, alcohol abuse, exposure to crowded settings, poor air quality, recent viral infections. So like influenza will increase the risk of secondary bacterial pneumonias, immunization status, seasonal factors. Pathophysiology, you can say pathogens will enter the lower respiratory tract via inhalation or droplets, or very rarely hematogenous spread. And if this interplays with an impaired host defense to cause a inflammation and consolidation. Symptoms, again, I've just categorized it: respiratory, systemic, and others. Most of these you can write. Lab investigations, you on the left side, you have all your routine ones, CBC, inflammatory markers. In pneumonia, you do send CRP procalcitonin because it guides therapy. You send blood cultures and other organ function tests just to assess the severity. Specific to pneumonia, you have on the right side. You do a sputum analysis. There are certain urine antigens for Legionella and Strep pneumoniae, and serology or PCR for atypical pathogens. Your mycoplasma, chlamydia, these won't grow on labs, and viruses, COVID and influenza. All of this you'd send a PCR. So you send sputum. If you are suspecting specifically Legionella or Strep pneumoniae, then urine antigen test. And specifically for atypical pathogens and viruses, you send serology or PCR. Imaging, you can describe all of this. Chest X-ray and CT are the most commonly done imaging. And additionally, in some cases, especially if you have a non-resolving CAP or a suspected TB NTM, and the patient is not able to produce a sputum, you do a bronchoscopy. Or additionally, pleural fluid analysis if there is an effusion and HIV. So for CAP, antibiotic therapy, you divide it into three categories. One is if the patient has no risk factors for any drug-resistant pathogens, simple beta-lactam and macrolide. Or most of your guidelines will say either a macrolide or a respiratory quinolone. If there is a risk factor for Pseudomonas, then you should include an anti-pseudomonal agent. Okay, it would be either cefepime, imipenem, meropenem, or piperacillin tazobactam, along with either ciprofloxacin or levofloxacin, or sometimes, though all your pneumonia guidelines say two drugs are effective against Pseudomonas, along with a macrolide or a quinolone. Right now, if you in your ID classes, you will hear that this has mostly fallen out of practice. We usually use even a single therapy is good enough for empirical cover of Pseudomonas. And finally, if you're suspecting a community-acquired MRSA, you treat with empirical linezolid or vancomycin. For viral pneumonias, I've added an entire slide of antiviral agents because there was a question on just viral pneumonias in the ICU. So I've included which drug for which virus and when is this to be given. Whenever there is a non-responder, that means despite adequate antibiotic therapy, you should think of all of this. Drug-resistant pathogens, so which would mandate your changing your antibiotic regimen. Empyema, which would mandate drainage. There might be an abscess or an endocarditis. And Look, also there is a potential question on newer antibiotics available for CAP. Okay, duration of therapy with antibiotics is always only 5 to 7 days for a community acquired pneumonia. And you can, if you started a broad spectrum empirical therapy, you can use biomarkers like PCT to help with antibiotic de-escalation. So this is the whole slide on antiviral therapy. For influenza, it's oseltamivir. It usually started within 48 hours. Dose is 75 mg BD. But whenever in ICU, whenever you get the patient, you will start. For COVID, it's remdesivir. It is 200 milligrams loading, followed by 100 milligrams OD for 5 to 10 days. Cytomegalovirus is not common in routine population. It might be seen in immunocompromised patients. There you add ganciclovir, 5 mg per kg, 12 hourly for 14 to 21 days induction, followed by a maintenance therapy with 5 mg per kg per day. Other therapies for cytomegalovirus is valganciclovir and foscarnet and RSV. Now, this is not usually treated. Very rarely in an immunocompromised patients, they use ribavirin. That is also an off-label therapy. So this is an antiviral therapy for community-acquired pneumonia. So newer antibiotics for community-acquired pneumonia, there is no other way but to sit and learn up these things. What we've commonly heard of are ceftaroline and ceftobiprole. Both of them are fifth generation cephalosporins. Ceftaroline is particularly for MRSA. Ceftobiprole is not active against MRSA. It is instead used for MSSA or methicillin resistant CONS or drug resistant strep pneumonia. Others I have included. You have the time and energy. You might just go through this and try and learn or remember one or two more. Aspiration pneumonia. So what is aspiration pneumonia? Whenever there is CAP in the setting of oropharyngeal dysphagia, which is promoting large volumes of gastric or oropharyngeal content into the lung. Okay. The IDSC guidelines do not recommend adding an anaerobic cover for this unless you're suspecting an abscess or a lung empyema, because most of these will be caused by a gram-negative pathogen. If it is a severe pneumonia, you should direct your antibiotics to cover your upper airway colonizers. Additional anti-inflammatory and immunomodulatory treatment. So for COVID pneumonia, you add dexamethasone. This is given to us by the recovery trial. It is at a dose of 6 mg once a day for 10 days. For influenza pneumonia, corticosteroids is very controversial, and it has actually there is evidence that says that it might actually increase mortality, prolong viral shedding, and increase the risk of secondary bacterial infections. For other causes of pneumonia, you have the Cape Cod trial, which is one of the most recently published practice-changing trials, where they have tested the use of hydrocortisone in severe community-acquired pneumonia. The primary outcome they measured was all-cause mortality, and use of hydrocortisone in severe pneumonia actually significantly reduced the mortality. So 6.2% in the hydrocortisone arm and 11.9% in the treatment in the placebo arm. So this is one of the papers recently published in 2023 that recommends the use of hydrocortisol in severe community-acquired pneumonia. I think I will stop here and continue from WAP and ARDS in the next session. Dr. Priya, are you online?
Yes, I'm there.
Okay, would you
I'll
like
go
to?
ahead. Yeah, fine.
Yeah.
So I think all of you must have been exhausted from 3 o'clock. So there are some easy topics which are coming up. GI bleed. So Actually, my screen sharing is paused. Yeah, can everybody see my slides? Can somebody reply?
Yes, it is visible, ma'am.
Yeah, okay. So we'll go ahead with upper GI bleed. So how do you define upper GI bleed? So any bleeding occurring from the gastrointestinal tract proximal to the ligament of Treats. So that is known as upper GI bleed. And what will be the common presenting feature will be hematemesis with or without melena. So why does melena happen? Because the blood gets in contact with the hydrochloric acid in the intestine gastric contents, it is converted into hematin. So this is excreted as the hematin in the stool presents as a blackish colored stool, which is melena. So for melena to occur, there should be at least 60 ml of blood. Okay, the etiology or the common causes of upper gastrointestinal bleed are most common is non-variceal bleed, that is the peptic ulcer related bleed, followed by other causes. The next cause will be variceal, that is esophageal varices. So the other causes of non-variceal bleed include esophagitis, tumor, angioma, malariviostia, erosions, diaphragm lesions, okay, and polypectomy. The varices can happen not only in the esophagus, but it can occur in the gastric as well as ectopic varices. There can be rectal varices. There can be varices anywhere else in the body. Okay, but common causes of variceal bleed is esophageal varices. So the risk factors, when we look specifically into the risk factors for peptic ulceration, there should be a history of any antiplatelet use, any NSAIDs, NOACs, or smoking history, H. pylori infections. For variceal bleed, history of liver disease or alcohol use, GI angioplasties, kidney or aortic kidney disease or aortic stenosis, aortoenteric fistula, aortic aneurysm, or aortic graft placement in the past. Hemophilia, a patient with hemophilia usually has a history of ERCP or TIPS placement. Okay, and malariviostia, your patient will have history of kind of vomiting, retching, blunt abdominal trauma, so all these things. Malignancy related, any history of smoking, alcohol use. So all these are risk factors. So primarily when you're assessing a patient, so if the patient can be in tachycardia, there can be orthostatic hypotension, or the patient can be obviously frankly hypotensive. So when the patient is obviously hypotensive, requiring, if the mean arterial blood pressure is low, requiring some additional fluid resuscitation or vasopressor support, it means the patient is in category 4. That is blood loss of more than 40% of the total blood volume. So this is severe hypovolemia. Whereas if the patient has orthostatic hypotension, that is decrease in the blood pressure more than 20 systolic or more than 10 diastolic, it means the patient has a blood loss of around 15 to 40%. That is moderate hypovolemia. Is mildly hypovolemic, the patient can have resting tachycardia. Okay. So the other signs what you can elicit is signs of peritonitis. Okay, the patient can have abdominal pain, guarding, and rigidity. The patient can have signs of aspiration, decreased oxygenation, okay, pulling of secretions, and then will be actively aspirating on the blood. Because of severe hypovolemia, the patient can become encephalopathic because of hypotension, and because of pre-existing liver disease, also encephalopathy can be there. And if the patient presents without any kind of obvious history of melena, a rectal examination in a hypovolemic patient will be helpful. Always your GI, when a patient presents with a GI bleed, a rectal examination completes your thorough physical examination. Investigations include complete blood count, doing a serum electrolytes, urea creatinine, LFTs, coagulation parameters, serum lactate, ECG, okay, X-ray to look for aspiration signs. Then you need to monitor the hemoglobin every 2 to 12 hourly based on the status of the patient and based on the amount of bleeding that is happening, severity of the bleed. So next will be how will you risk stratify the patients. So these are the various scores that are available. So the Blatchford score is the most commonly used score, the modified Blatchford score. So this has found to outperform the Rockall score. So the various parameters that are looked into the Blatchford score are the hemoglobin, which is different for men and women, the systolic blood pressure less than 110, which is considered significant, and there are various grades, the blood urea nitrogen, pulse rate more than 100, presentation with melena, presentation with syncope, hepatic disease, or cardiac failure. A total score of 0 to 21, wherein 0 to 1 is considered as a low risk score, and a score more than 6 needs intervention. So the Blatchford score is performed at admission. Okay, there is a Rockall score which is done at admission and post endoscopy. Okay, at admission, if the score is 0 or less than 4, the patient may not require admission. If it's 0, the patient may not require admission. If the patient score is less than 4, maybe an elective admission in the wards. More than 4, high-risk patient ideally needs ICU admission. So what are the various risk factors it is looking into? Age, shock, comorbidities, okay? Based on cardiac failure, renal failure, shock in terms of hypotension, tachycardia. So, and depending on, so this is the pre-endoscopic scoring. And post endoscopy, the score is complete. So based on the endoscopic stigmata, that is no lesion, no malarious tear. If there is peptic ulcer disease and it is just an erosion or esophagitis, it is low grade. If cancer, grade 2, and other signs of recent bleed like active bleeding, visible clot, so these are considered to be high grade. So the maximum score prior to diagnosis, that is prior to endoscopy, is 7, and the maximum score after endoscopy is 11. A score more than 8 gives a poor prognosis. The other score is the AIM-65 score. So in the AIM-65 score, they look into the albumin levels less than 3, INR more than 1.5, altered mental status, systolic BP less than 90, age more than 65. But maximum score is 5. A score more than 25 has a high risk of mortality. So these scores is not only for prognostication, it is for risk of rebleed as well as for mortality. So how will you manage a patient presenting with the GI bleed, upper GI bleed? So immediately, if the bleed is severe, intimate the medical gastroenterologist, intimate surgeon, and alert the interventional radiologist as well. Take care of your airway, breathing, and circulation. If the patient has a risk of aspiration or altered mental status, immediately consider endotracheal intubation and mechanical ventilation, and secure large IV cannulas. Okay, in central venous catheters and vasopressors if indicated, and volume resuscitation with large volume crystalloids to ensure the patient is not hypovolemic, maintain a mean arterial pressure of more than 65. Simultaneously consider starting a vasopressor infusion, and do not keep the MAP very high also. The patients can exsanguinate and bleed torrentially. So the hemoglobin target should be around 7, okay, and maintain above 7. If there is an urgent need for transfusion, O negative blood can be considered. The severe ongoing bleed, you alert the bank and initiate a massive transfusion protocol as such. If the patient has been already on some anticoagulants or antiplatelets, consider stopping them immediately. Correct the prolonged INR or APTT. So if the INR is prolonged due to warfarin intake, then you'll have to give FFPs at a volume of 15 to 20 ml per kg or prothrombin concentrates. There are two types of PCCs, 3-factor or 4-factor PCCs. So you can transfuse either of them at a specific units based on the INR. So there are specific units that are recommended. For example, if it's 4 to 6, it will be at a certain value units per kg. So you can give the prothrombin concentrate, then consider reversal of the anticoagulant activity with antidotes like dabigatran with idarucimab 5 grams IV bolus, rivaroxaban or apixaban with andexanet alpha 800 milligram IV bolus followed by 30 milligram per minute over 30 minutes. And this should be followed by an infusion, 8 milligram per infusion for 120 minutes. And if the APTT is prolonged or if there has been a heparin infusion which was ongoing, consider protamine sulfate to neutralize 1 milligram for 100 units of heparin that has been given. So for massive transfusion, you give 1:1:1, that is PRBC, FFP, and a platelet at that certain ratio. Okay, what are their targets? Your hemoglobin target is 7. Okay, and as per the NICE guidelines, correction of coagulopathy, your targets are platelet target 50,000, INR more than less than 1.4, APTT less than 1.5 times, maintain the fibrinogen more than 150. So these are the targets to be maintained. Next, so we have optimized the patient, risk stratified, initial management, reversal of anticoagulation. Next will be your specific therapies. Prior to that, there will be some pharmacological therapy that we need to institute. First, pre-endoscopic management of the patient. Is there any indication or evidence for tranexamic acid in GI bleed? No, this is as per the halted trial. So what did they find? There is no difference in the rebleed, but the risk of venous thromboembolism is very high when the patients were treated with tranexamic acid. So tranexamic acid is not recommended in GI bleed. Use of somatostatin analogs. So what are the somatostatin analogs? Terlipressin, octreotide, somatostatin. Dose being 2 milligram Q4th hourly during the first 48 hours, followed by 1 milligram over 4th hourly. So octreotide 50 microgram IV bolus followed by 50 microgram per hour. Somatostatin 250 microgram IV bolus followed by 250 microgram per hour infusion. So these need to be continued 5 days to avoid early rebleeding. But if endoscopy has been done and if there is any lesion and the therapy has been done, endoscopic therapy has been done, then it can be discontinued after the next 48 to 72 hours. So is there any role for erythromycin? Yes, a single dose of erythromycin, 250 milligram, 30 to 120 minutes prior to endoscopy, it improves the endoscopic visualization because it improves the motility and clearance, thereby it improves visualization and it decreases the need for relook endoscopy. So nasogastric and orogastric tube can be placed and then continuous Riles tube aspiration can be maintained. Is there any role for antibiotic? Definitely, yes, because there is a breach in the barrier between the blood and the gut, and there can be translocation, so bacterial translocation. So antibiotics, definitely, yes. Ceftriaxone 1 gram IV OD for 7 days. Norfloxacin has been traditionally recommended, but right now we don't use norfloxacin due to is very high. Bacterial associated with rebleeding due to increased heparin endothelial because of and what is the indication for proton pump inhibitors? So if it's a variceal bleed, there is no role for proton pump inhibitors. If it is a non-variceal ulcer-related bleed, yes, there is a role for proton pump inhibitors. So what is the dose? 80 milligram IV bolus followed by 8 infusion continued for 7 hours. So how does it work? It increases the gastric pH to more than 6, so it's stable. So post endoscopy, the proton pump inhibitors should be continued for 3 days. In patients with high risk, that is Glasgow Blatchford score more than 2, it should be continued for 2 weeks. Ideally, during endoscopy, the rapid urease test normally performed. If it is positive, then consider H. pylori treatment as well. So what is the regimen for H. pylori? When we look at the French regimen, clarithromycin 500 BD, amoxicillin 1 gram BD, pantoprazole 1 gram BD, 40 milligram BD has been administered. Some regimens consider quadruple therapy wherein metronidazole has also been added to it. If there is penicillin allergy, bismuth quadruple therapy, metronidazole, tetracycline, pantoprazole, and bismuth subsalicylate has been advised. So next, after you initiate the pharmacological treatment, important thing would be to go ahead with the endoscopy. So how early should endoscopy be done? Early as less than 24 hours. Urgent endoscopy less than 12 hours. Delayed is more than 24 hours. So what will be the endoscopic therapy for variceal and non-variceal bleeds? For variceal bleeds, if there are esophageal varices, variceal ligation should be done. For fundal varices, mostly glue injection will be done. First, if the patient has esophageal as well as fundal varices, the fundal varices should be approached first. Because if the esophageal varices are ligated first, there is increased risk of bleeding from the fundal varices. Then sclerotherapy is not routinely done because there is an increased risk of gastric wall necrosis and pulmonary embolism. Non-variceal bleed, endoscopic therapy involves adrenaline injection, more than 1 milligram diluted in 10 ml of normal saline, which is injected in grade 1 and 1A and 1B. Okay, it is only temporary, so there is a risk of rebleed. It should always be combined with some other therapy. So fibrin glue application. This is mainly for duodenal bulb where the clip does not stay. So ideal would be to do a hemoclip and adrenaline injection. Hemo spray powder, this is also something which is temporary because risk of rebleeding is very high and it is mainly for tumor bleeding. Hemoclip application compresses the vessel and the surrounding tissue. So the different grades, this is the Forest classification of the ulcer bleed, wherein 1 is active bleeding, 1A is spurting, 1B is active oozing. Okay, this has a high risk of rebleeding from 60 to 100%. Next is signs of recent hemorrhage, that is 2A, B, and C. 2A is a non-bleeding visible vessel, 2B is adherent clot, 2C is flat spot with the ulcer base, flat spot in a ulcer base. Grade 3 is clean base ulcer. So these are the various endoscopic therapies and the stigmatas. So in case of variceal bleed, what other therapies can be given? If there is refractory bleeding that is ongoing, not responsive to endoscopic therapy, or if the endoscopy therapy is delayed and not routinely available. So what can be done as a temporary measure? That is sinks taken, black and more tube, or other tubes which can be done. So there are three lumens: the gastric suction port, the gastric, and the esophageal inflation port. So there are two balloons, the esophageal balloon and the gastric balloon, which can be inflated and maintained at a specific pressure. So this compresses the varices and prevents bleeding. But this should not be done beyond a certain period, like beyond 24 hours. It increases the risk of ischemia, gut ischemia. So some other alternative measure should be taken. Either a radiological intervention or a surgery should be considered. Other tubes that are available are the Minnesota tube, which has 4 lumens, one esophageal suction port, gastric suction port, and 2 inflation ports. Okay, this has an additional tube which can actually remove secretions above the gastric balloon. So this is Minnesota, and the other one is the Lincoln Nachlas tube. So the next therapy which can be considered is radiological interventions, that is for non-variceal. So if there is a recurrent bleed despite the endoscopic therapy, consider transarterial embolization. Surgery in case of failed embolizations, and then if the lesion is something that is neoplastic and some vascular abnormalities like Dialfoy's lesions, aortoenteric fistulas. So these are the lesions which should be treated surgically. So ultimate treatment for variceal bleed, refractory variceal bleed would be transhepatic transjugular intrahepatic portosystemic shunt, that is TIPS, wherein there is they decompress the portal pressure by creating an artificial bypass between the portal vein and the hepatic vein. So this the indication for this TIPS would be recurrent and uncontrolled variceal bleed. So contraindication, the main complication of TIPS would be hepatic encephalopathy. So contraindications in a patient who is already encephalopathic, this will definitely worsen. So hepatic encephalopathy is a contraindication. Also, it increases the pulmonary pressures. So portopulmonary hypertension is a contraindication. Portal venous thrombosis, if there is a already pre-existing clot in the portal vein, that is a contraindication. Hepatic failure with reduced ejection fraction, and child classification C. So these are the contraindications for TIPS. Okay, so you have done the control of the bleed. So some patients who had already been on antiplatelets for coronary artery disease, they have to be restarted on their medications or antiplatelets. So when will you consider restarting these antiplatelets in non-variceal, that is ulcer-related bleed? So you look at the risk, okay, if the cardiac risk as well as the risk of rebleed. If the patient's endoscopic stigmata is forest 3, that is low risk of bleeding, and hemostasis is achieved in the next 24 hours, you can restart aspirin. Okay, if the cardiac risk is low, then you can wait for 48 to 72 hours. If the bleeding risk is very high, that is a spurting or a oozing vessel, the decision to start the thrombotic therapy should be considered. Actually, it should be discussed with the cardiologist and then decided. So the next topic is gastrointestinal ischemia. So acute mesenteric ischemia is something very important in the ICU. So it's defined as a group of diseases characterized by interruption to the blood supply to varying portions of the intestine, leading to ischemia and secondary inflammatory changes. Of supply leading to ischemia, secondary inflammatory changes. Incidence is 0.09 to 0.2% of all surgical admissions, acute admissions to emergency department. The mortality is very, very high, 50 to 70% if you delay the diagnosis. So the types of acute mesenteric ischemia is broadly classified into occlusive, non-occlusive. Non-occlusive is nothing but spasm or vasoconstriction is something we can consider. Occlusive is divided into arterial, venous. Arterial can be either a thrombosis or an embolism, and venous can be a thrombosis. So you can broadly classify the primary etiologies as mesenteric arterial embolism, which is the most common, 50% of all the cases. Mesenteric arterial thrombosis, which is 15 to 40%. Mesenteric venous thrombosis, which is very less, that is less than 10%. And non-occlusive mesenteric ischemia, which is approximately 20 to 25%. Okay, it has recently increased to 25%. So when we are considering the risk factors or differentiating factors between the mesenteric embolism, mesenteric arterial embolism, arterial thrombosis, and non-occlusive mesenteric ischemia, the embolism, the patients will have a history of atrial fibrillation. Mostly 50% of the patients have a history of AF, recent MI, a cardiac thrombi, poor LV function, any cardiac valve issues, endocarditis or atherosclerotic aorta. It can be due to atheroembolic also. And mitral valve disease, any ventricular aneurysm, and previous embolic disease like a embolic stroke, which should have happened in the patient. So these are the risk factors for arterial embolism. Arterial thrombosis, it is due to mainly diffuse atherosclerotic disease, vasculitis, mesenteric dissection, or mycotic aneurysm. Whereas when we are considering non-occlusive mesenteric ischemia, always remember there is vasoconstriction. So it could be a low perfuse state, like low cardiac output, low flow states, cardiac failure. Patient will be on some vasopressors, resulting in vasoconstriction. So something like an abdominal compartment syndrome. The cause being SMA vasoconstriction due to low spanglic blood flow, severe coexisting illness, particularly cardiac failure precipitated by sepsis. Main precipitating factors would be hypovolemia, vasoconstrictive agents. The risk factors, cardiac failure, recent cardiac bypass surgery, vasopressor use, hemodialysis. So these are the main precipitating factors. So clinical onset, how can these three differ? Okay, in embolism, there is sudden, strong abdominal pain. So always in mesenteric ischemia, remember the pain will be out of proportion. So this is pain and vomiting. In arterial thrombosis, there is an increase in postprandial pain. So whenever the patient has some food, the pain increases because the blood supply is shunted off. So the patient has a high pain postprandially. Progressive pain, diffuse episodic pain happens in non-occlusive mesenteric ischemia. So what are the vessels that are commonly involved? In arterial embolism, the SMA is more commonly involved, whereas in thrombosis, either the celiac trunk SMA or inferior mesenteric artery origins. So these are the vessels that have been involved. In non-occlusive, it could be a superior mesenteric vein progressing to a portal vein. So it can happen. So when we look into each and everything in specific, SMA embolism, so the vulnerability of the SMA is because of the large diameter and a low takeoff angle from the aorta. So usually the embolus lodges at a site which is 3 to 10 centimeter distal to the origin of the SMA, sparing the proximal jejunum and the colon. So more than 20% of the SMA emboli are associated with concurrent emboli to other arterial beds also. In case of thrombosis, okay, we already saw the patient will have postprandial pain. Because of that, the patient will not have food. There will be weight loss. There will be food fear, okay. So frequently due to celiac occlusion, the ileocholic artery involvement can cause a necrosis of the entire proximal colon. In case of mesenteric venous thrombosis is mainly due to a triad. We know which was triad, which involves stagnant blood flow, hypercoagulation, endothelial damage. This venous thrombosis is usually because of local pathology, like some inflammatory process which is going on, a pancreatitis, irritable bowel syndrome, or some surgical trauma, hypercoagulable disorders like factor V mutation, protein C deficiency, antithrombin deficiency, phospholipid syndrome. So, like malignancies, hematological septolysis, shutdown, sections without. So, GI bleeding about 10% of the patients. So pain will be out of proportion to the physical findings. So this is very, very important. Nausea, vomiting, diarrhea. Triad includes fever, pain, positive occult blood in stools. Signs of peritonitis can be there. Lab parameters, elevated lactate, which is very important. Leukocytosis can be there in 70% of the patients. Lactate more than 2. Whenever a patient has abdominal pain, high lactate should prompt a CT angiogram. D-dimer that is a goal. Delay the diagnosis by so in C you can find things like you can detect SMA thrombosis, free fluid, portal venous portal or splenic vein thrombosis, pneumatosis intestinalis, portal venous gas, free air. If there is a blood supply that has been affected, bowel necrosis can also be seen, gangrene. So these are the specific findings. In non-occlusive mesenteric ischemia, the vessels will be mostly patent. In venous thrombosis, thrombus in the SMV. So there will be a target sign. A target-shaped bowel wall can be seen caused by thickened hyperattenuated bowel mucosa and a submucosal edema from venous congestion due to impaired blood flow. So because of venous congestion due to impaired venous drainage, it will result in a target-shaped bowel, which is known as target sign. And this results in increased inflammation, increased permeability, pneumatosis, splenomegaly, and ascites. So these are the other findings. Diagnostic angiography differentiates between occlusive and non-occlusive. Duplex ultrasound has a limited role. MRI, it has a limited role in emergency setting. So mainly management differs in all these three conditions. For thrombosis, arterial thrombosis and embolism, it's almost the same. Non-occlusive mesenteric ischemia and venous, it differs. Okay, so when there is a suspicion of mesenteric ischemia, go ahead with the CT angio. First, correct hypovolemia, electrolyte imbalance, stop enteral nutrition, continuous Riles tube aspiration, abdominal girth monitoring, normally something that we do in our ICU. Basic CT to look in for occlusion of vessel. So if there is a arterial thrombus or embolism, so if there is an arterial occlusion that is present, consider revascularization, either endovascular or surgical. Okay, and go ahead with full anticoagulation. If there is an arterial thrombus, you have to start antiplatelets and statins. If there is a venous thrombus, full anticoagulation. So you need to remember, for venous, full anticoagulation, arterial thrombus, antiplatelets and statins. So if the arteries are patent, okay, there is no obvious occlusion. So it means there is non-occlusive mesenteric ischemia. So there can be narrowing of the arteries. So what we have to do is optimize the etiological factors. The cardiac functions need to be optimized, optimize the volume status, try to come down on the vasopressors. If make sure your intra-abdominal pressure is optimized. Consider intra-arterial vasodilatation if possible. If there are signs of transmural ischemia, okay, if there is pneumoperitoneum, absent bowel wall enhancement, pneumatosis intestinalis, so this means the patient is very unstable, might require a surgery. Okay, patient is clinically unstable, signs of peritonitis, elevated lactone, abdominal compartment syndrome. So these are the indications, okay, specific indications for surgery. Okay, when they do a surgery, they will see about two things. One is revascularization of the vessels. Second one, if the bowel is non-salvageable, okay, they will have to go ahead and resect. Okay, and the resection zone, like your which part to be exactly removed and which is the viable and the non-viable part, is very difficult to intraoperatively tell, because the margins can also be at a risk of ischemia. So always consider a relook surgery. So a day later or 24 hours, they may not even close the abdomen fully. A second day, they can have a second relook. And start the patient on, remember, antibiotics, very essential. So improve intestinal perfusion by maintaining oxygenation, treat hypovolemia, optimize cardiac function, make sure avoid hypervolemia and hypovolemia, minimize vasoactive agents, control of intra-abdominal hypertension, and withhold enteral feeding until the perfusion is assured. So this is the management aspect. So remember, it's different for venous thrombosis, full anticoagulation. For embolus, it's full anticoagulation. Arterial thrombus, antiplatelet and statin. For non-occlusive mesenteric ischemia, the main thing would be correcting the etiology. So immediate management, this is a exact same slide, wherein fluid resuscitation, then maintaining electrolytes, NG decompression, broad spectrum antibiotics, then revascularization techniques, embolectomy, angioplasty, bypass, hybrid techniques like retrograde open mesenteric can be considered. Surgical intervention when there is signs of peritonitis. So laparoscopy can be done and assess the extent of necrosis, and then make sure the blood supply is established. If not, bowel viability assessment is very critical. That is, it can be done by inspection. It's very difficult. They'll apply a difluorescent or Doppler or the Sindao green dye application. So these are the methods by which they'll assess the bowel viability. So arterial thrombosis, antiplatelet statins, venous thrombosis, anticoagulation, emboli, anticoagulation, therapeutic anticoagulation. NOMI, always treat the etiology. Okay. And post-operative care, long-term management, because the patients are at a risk of nutritional compromise. So nutrition is something that needs to be taken care of. If your nutrition is compromised for a considerable period, consider parenteral nutrition, antibiotics, anticoagulants, and if the patient might have a reperfusion injury also. Okay, long-term need to consider anticoagulation, antiplatelet therapy. So this is about acute mesenteric ischemia. Is everybody there okay to continue? Shall we proceed with the next topic? Okay. So the next topic is on C. diff infection and fecal transplantation. So Clostridioides difficile. So new name is not Clostridium difficile, it's Clostridioides difficile infection. It's a gram-positive rod, anaerobic, spore-forming, toxin-producing. And the main modes of spread is fecal-oral route and fomites. Okay, the mortality is up to 35%. So it can be a colonizer in few hospitalized patients also. The risk factors being age more than 65, previous hospitalization. Main risk factors is recent antimicrobial therapy, especially clindamycin, fluoroquinolones, second generation cephalosporins, any antibiotic per se. So these are the main risk factors. Immunosuppressions and PPIs, proton pump inhibitors, CLD patients. So these are the high risk factors for C. diff infection. So mostly it colonizes in the large intestine. With adequate immune response, usually they are asymptomatic carriers. With the use of antibiotics, the microbial flora is altered, making the patient susceptible to C. diff infection. The transmission is usually via fecal-oral route, and the infection is mainly due to the enterotoxins, toxin A and D. Toxin A is enterotoxin, whereas toxin B is cytotoxic. So usually when there is colonization and toxin production, when the patient's immune response is adequate, it becomes a carrier stage. When the immune response is inadequate, the patient will have diarrhea and colitis. So based on several criteria, we can classify into non-severe, severe, and fulminant infection, mainly based on WBC and creatinine. So if the counts, white cell count is less than 15,000 and the creatinine is less than 1.5, it is non-severe infection. Severe, and the patient is WBC count, white cell count is more than 15 and the creatinine is more than 1.5. Fulminant infection, when there's hypotension, shock, ileus, toxic megacolon. So frankly, septic and shocky. So that is fulminant infection. So how do you diagnose C. diff infection? So the main gold standard is culture. So culture and cell cytology neutralization assay. So this is something that can be considered. So these two are the main tests that can be done. But what is the disadvantage? The cytogenic toxigenic culture and cell cytotoxicity assay. So the turnaround time is going to be more than 48 hours. It's 24 and it's not available on all centers. It's difficult to perform also. Okay, but it is very highly sensitive and it is the reference standard. So toxigenic culture is the gold standard. Cell cytotoxicity assay. So normally what we do in the hospital is the ELISA or the enzyme immunoassay. So this you check in for GDH and toxin A and B. So GDH is insufficient for diagnosis. Always toxins should be positive to diagnose the pathogenic state. GDH can denote a carrier state. Okay, other thing would be a nucleic acid amplification test. This is more expensive than enzyme immunoassay, but it is highly specific and sensitive for toxigenic C. diff. And next would be a RT-PCR for toxins. Okay, so how do you go ahead to diagnose it? So when the patient has C. diff infection, always contact isolation, hand hygiene. Remember, the chlorhexidine hand wash is not going to prevent a transmission because the spores are not going to be killed by chlorhexidine. Always hand washing is the important strategy that we need to maintain. So contact isolation, send NAT or EIE GDH test. So looking for GDH toxin. If toxin A and B are positive, it means C. diff is confirmed. If GDH is positive and toxin A and B are negative, it can be a carrier state. If GDH is negative and toxin A and B are present, it is positive. So remember that. So toxin is very important for diagnosis. If the results are inconclusive, go ahead with PCR or culture test. So possible causes for negative result would be if there is a false negative. So it could be due to low toxin levels, false negative EIA results, and it could be a carrier state also. So other things, so C. diff can cause pseudomembranous colitis and toxic megacolon. So colonoscopy, flexible sigmoidoscopy or colonoscopy can be done if the patient has persistent symptoms and abdominal distension. So pseudomembranous colitis is due to inflammation of the colon. Yellow-white plaques can be found in the intestinal mucosa. Differentials would be uremic colitis, ischemic colitis, irritable bowel syndrome, Behçet's. So it can be, pseudomembranes can be scattered or it can be confluent, okay, involving 2 centimeters or like confluent involving the entire bowel, and it can involve a greater depth also. So when it involves a greater depth, it's graded high. So sigmoidoscopy or colonoscopy usually useful in patients with ileus, paralytic ileus, and biopsy can help us diagnose. Contrast CT abdomen. So in case of toxic megacolon, so if the bowel colon is dilated more than 7 centimeters, it is known as toxic megacolon. There can be small bowel dilatation, air fluid levels, thumb printing, scalloping of the bowel wall, air under the diaphragm. If frankly the patient had a perforation, so peritonitis can be there. So air under the diaphragm, neural thickening. So these are complications: pseudomembranous colitis, toxic megacolon, and perforation of the abdomen. So what is the management strategies? When we look into the different guidelines, the IDSA or the SHIA guidelines is the guidelines that we normally follow. The European, this is Australasian guidelines. So each guidelines differ in their management. Normally what we follow is the IDSA guidelines. Initial episode, non-severe episode, consider vancomycin 125 milligram per oral 6th hourly for 10 days. If above agents are not available, you can give metronidazole also. The patient, it is a non-severe form of C. diff infection for 8th hourly for 10 to 14 days. Fidaxomicin 200 milligram dose can be given. Okay, in case of severe infection, adjunctive besletoximab, vancomycin 6th hourly for 10 days, besletoximab. So this can be given, or fidaxomicin alone. Okay, so if there is if primary C. diff infection and the risk factors of recurrence is high, if the patient is immunocompromised, age more than 65, or prior history, so then you will have to consider this form of treatment. If it is fulminant infection, so you have to give vancomycin a higher dose, 500 milligrams 6th hourly per oral, followed by metronidazole 500 milligram IV. So these two are combined, high dose vancomycin and metronidazole. And consider vancomycin per rectum if ileus is present. Severe complicated fulminant complicated fulminant refractory. So here there is no recommendation, but then if the recurrence happens, first recurrence and second recurrence, based on the recurrence, ideally for every week it has to be kind of pulsed and tapered off. So first recurrence, you'll have to give it for a period of 10 days and then adjunctive beslotuzumab if prior episode was within 6 months. So then again for the second recurrence, you'll have to give 3 drugs or either fidaxomicin, vancomycin at a tapered pulsed regimen. So every week you'll be like coming down on the 4 times a week, then 2 times a week, like that. It should be pulsed and tapered off. So if there is more frequent recurrence, consider fecal microbiota transplant. Okay. So the dose of these drugs. So vancomycin 125 6th hourly, and this is per oral. Rectum 500 milligram in 100 ml of normal saline 6th hourly as retention enemas. Bezlotoxumab as 10 milligram per kg IV during IV, fidaxomicin 200 milligram 12th hourly for 10 days. So extended pulse regimen. How do you do the extended pulse regimen? So 200 milligram for 12th hourly for 5 days, followed by every other day for 20 days. That is alternate day. Tapered and pulsed vancomycin regimen, 125 milligram, 4 times a day, 10 to 14 days. Then 2 times a day for 7 days. Then once a day. So this is how it is kind of tapered off. Then once a day for 7 days, and then every 2 to 3 days for the next 2 to 8 weeks. So this is a tapered or the pulse regimen for recurrence. So the other guidelines recommend various other strategies. So we'll just follow the IDSA. So the last topic for today is fecal transplantation, definition, indications, and various delivery methods. So fecal microbiota transfer and implantation of the stool and bacteria from the colon of a healthy person to a colon of a person with a certain disease to affect the cure of that disease. So what are the indications? Recurrence more than 3 times of mild to moderate C. diff infection, failure to respond to standard therapy, more than 2 episodes of C. diff infection resulting in hospitalization and significant. So if you have recurrent C. diff infection, mild to moderate C. diff, more than 2 episodes resulting in hospitalization, that is severe, almost significant morbidity, moderate C. diff with no response to standard therapy for at least 1 week. Severe C. diff, no response to standard therapy after 48 hours. So these are the specific indications for FMT. So what are the other indications other than C. diff? So we have seen these 4 indications for C. diff, and other indications would be inflammatory bowel disease, irritable bowel syndrome, metabolic syndrome, fatty liver disease, multi-resistant organism eradication, hepatic encephalopathy. So all these conditions, it is tried. Okay. So the mechanism is that fecal microbiota transplant restores the microbiota of the intestine by installation of donor stool into the gastrointestinal tract. So this procedure has a good clinical, normally it has a good clinical response to refractory and recurrent C. diff. So the evidence comes from the systemic review that was published in 2011 for recurrent C. diff infection. And clinical resolution was found in 92% of the patients without any significant side effects. So how is it being done? First is donor selection, screening of the donor, then preparation of the stool and administration. So these are the 4 steps. So first, donor selection. The donor family members, intimate, the patient who's receiving should be, the donor should be either a family member or an intimate friend above the age of 18. And certain diseases are common in women, so men are preferred over women. And pre-screening of the donor. And donor screening involves, so we'll look at this in detail. Donor screening involves similar to blood product donation. So usually screen for certain diseases to make sure the person is healthy. So what are the infections that are screened? Hepatitis A, B, C, HIV, H. pylori, syphilis, C. diff, Giardia, E. coli, Salmonella, Shigella, Campylobacter infections. So these are the usual screening. Stool preparation. So how is it being prepared? Ideally, the stool is collected from the donor and processed in 250 ml of water. Okay, if the large particles are filtered, and it can be frozen and kept for future use. So administration, it can be done either as oral capsules, retention enemas, colonoscopy, and nasojejunal tube placement, and small bowel upper endoscopy to the jejunum, and it can be transplanted to the jejunum. So these are the various criteria and the lab tests that should be done for the donor. So the potential exclusion criteria for the donors include age less than 18, obese person, more than BMI more than 30, person who has a metabolic syndrome, more undernourished person donor who has a diarrhea within the last 3 to 6 months, history of C. diff infection, immunosuppressive agents, a history of drug use or recent risk factor to HIV or viral hepatitis, history of travel to tropical regions, irritable bowel syndrome or disease, or gastrointestinal malignancy, major surgery, any autoimmune or atopic illness, chronic pain syndrome, so any neurological, neurodevelopmental disorders, malignancy. So these are the specific criteria, and also history of antibiotic use in the last 6 months. So this is also something that is one of the criteria for exclusion. So what are the lab tests? So they screen for bacteria, viruses, parasites, and others. So bacteria includes Salmonella, Shigella, Campylobacter, H. pylori, VRE infections. Viruses, all hepatitis, HIV infections. Parasites, strongyloids, amoeba, microsporidia, geodia, cryptosporidium. So all isosporas, cyclospora, all those which can cause diarrhea. Just remember like that. And C. diff infections also. Okay, these are the specific screening tests. So how is it being administered? So either as pill or liquid form, that is something. So once the good bacteria is processed, it is made into either pill or liquid, either through the nasoenteric tube. So the advantages and disadvantages of every method is being given here. So upper endoscopy can be done relatively. This is also a procedure. Capsule, very easy to administer. Colonoscopy, procedure related risk, additional cost. Sigmoidoscopy, same. Retention enema. So these are the 6 methods wherein it can be administered. So efficacy, when we look into the safety and efficacy, the risk of on the short-term basis, risk of aspiration, if not delivered deep into the small intestine. So that is there. Risk of acquiring infection from the donors, but if it adequately screened, the risk of infections is rare. Procedure-related complications, bleeding, perforation, transmission of other infections other than whatever is screened is less than 1 in 1,000 to 1 in 10,000. Long term, it is something that involves a complex interplay between the gut microbiome and the host. So the conditions of the donor play a role. So intestinal microbiota has been associated with colon cancer, diabetes, obesity, and other atopic disorders as well. So we come to the end of this session. Is there anything somebody wants to ask, or is it okay to continue? Somebody wants to continue? So we are coming to the end of this session. Any doubts or anything, or any other difficulty that anybody is facing? You want any additional kind of material on any specific topic discussed today? Are the topics discussed today are clear and useful to everybody? keep going on with your preparation. All the best to all of you. Okay, we'll meet up tomorrow then. Sure. Good night. Thank you.
The recording has stopped.
Thank you, ma'am. Good night.
Yeah, good night.